Good evening, everyone. I would start this meeting with a small quote. Actually, I would say that some people are very, very lucky and privileged. I consider myself as one of the privileged, the luckiest person because I have the opportunity of introducing and also starting this webinar, which is very, very successful among the ENT fraternities. And as I was sharing with you last time, this is the 12th webinar where the average learning hours goes from 7 to 8 hours for a webinar and giving with lots of stuff and learning and take home messages. So it is very, I feel that's why I'm very, very lucky enough to give the introduction and a warm welcome to all of you. So today, it's my privilege in welcoming you all again to an interesting webinar focused on very basic to advanced ENT surgeries. My heartiest welcome to all the delegates, and my first heartiest welcome goes to Professor Raymond Sachs, and of course our Dr. Professor Sethi, and our legend Dr. Satish Jain with Dr. Rajeev Pachauri, and today we have with us Dr. Madhusudan Rao and Dr. Gautam Kaun, and of course, Dr. Parmita Saha as a moderator. Once again, my heartiest welcome to all the delegates and also the galaxy of stars who are in the panel. On behalf of Sun Pharma, let me remind Mahendra Varman of Pharma Care Division, which is dealing with Apex, Sipodum, Recipro, and Pitagard. Once again, thank you all, and I'm handing over the session to Dr. Rajeev Pachauri. Thank you.
Welcome. Mr. Varman, thank you, Sun Pharma. This is Dr. Rajeev Pachauri from this Explore Legends group. And today again, this is 12th webinar or 12th episode of this series. And I think all are most welcome. This is just going like you can say cocktail and mocktail of the surgeries, which we are going to show you with Dr. Satish Jain. Today we have 5 or 6 cases, and we will start with the JNA. I would like to welcome all my friends from India, from abroad. And today we have galaxy of panelists. We have guest Professor Raymond Sachs and Dr. Sethi as our. He's with us since the starting, and I welcome you both from what we have. And we have Dr. Madhusudan Rao, Dr. Gautam Kaun. They are our guest panelists today, as well as Dr. Paramita. And about Satish Jain is that he's going to show us all the surgeries, which I think would help all of you to getting new dimensions, new concepts, and managing all these. I would like to thank Sun Pharma for organizing this great academic event, because without their support, without this thing, it is not possible, because they are the core of this event, and they are helping us in different way. They are just promoting this event. They are just explaining all the delegates, all the friends around the world in India, and also without this concept of. So we have started with basic concept of sinus surgery, basic concept of ear surgery, basic concept of skull base and neck, etc. Radiology been covered in detail, everything been covered in detail. So now it is the extension of that basic. Now we are going on to surgeries. And during the surgery, Dr. Satish will try to explain everything again in detail. And I will request everyone, those who are sending the questions, please find out where this part been covered in past or not. If it is covered, then try to go again to the videos and just find out. So we request all your support to feedback information, and I would say just make it more spicy with your support. Again, welcome all my friends and delegates, and especially the guest, Dr. Sethi and Dr. Sachs, and Dr. Madhusudan Rao, Gautam Kaun. Over to Dr. Satish for this wonderful event. I need all the participation from all the panelists with their positive comments and positive suggestions. So again, Dr. Sethi sir, as usual, your strong support is there with us. So again to Dr. Satish Jain, please start. Anything from Dr. Paramita?
No, I would just like to welcome everyone. So the question links are open for all. You can ask any question. I'm here there to convey the questions to Dr. Satish Jain. We have all interesting cases today lined up. So we are very thankful to Dr. Satish Jain, Dr. Rajeev Pachauri for organizing such a wonderful event for all of us. And he's making sure that all these topics are thorough to all of us. We know these topics well. And of course, we have experts with us to share their expertise. So here we go to Dr. Satish Jain.
One more thing is there that we have a quiz today, and quiz is not from new concept that already been taught in last 11 means you can say series means events, and the questions will be from that parts. So you have to give the answer. Those who give the earliest answer will be awarded with the so many things will be there that we will take care. So over to Satish. Thank you.
Thank you, boss. Thank you. Thank you all. And good evening, all friends. It's a great day for us to have some great people with us today. Believe me, it is like a dream come true having some legends with us. And first of all, I welcome Professor Raymond Sachs for sparing his valuable time. Thank you, sir. Thank you so much for even for such a short notice. Thank you so much, and I really am thankful to Professor Sethi for helping us having Professor Raymond Sachs. So for everyone, Professor Raymond Sachs is, I call him personally like a king of rhinology, and what the kind of work he has done is something phenomenal. You know, he's been attached to, he's heading the department of the prestigious Macquarie University in Sydney. Besides the Sydney University and the Concord Hospital he is heading, his academic achievements are innumerable. Besides hundreds of publications, so many book chapters, he has authored a book on endoscopic orbital surgery, which is like something never before. And besides that, he has been co-author of many of the prestigious journals like American Journal of Rhinology and Allergy, Journal of Laryngology and Otology, and so many academic achievements. He has been organizing so many workshops, conferences, and he's been awarded as a globally as a rhinologist of the year by many of the rhinology societies. Thank you, sir, once again for being with us. And I'm sure today we all will be benefited by his expertise, his comments, his suggestions. Sir, feel free to comment and interrupt us anytime with your valuable comments. Dr. Sethi doesn't need any introduction. We all know he is our own. He is no more a guest. Being in Singapore, he has always helped us. And Professor Sachs, he is the one amongst those, I'm talking 25 years back, who popularized this concept of sinus surgery in our country. And we all are following since then. And we are so grateful to this great man. Friends, we have our own colleagues who are here today to help us, to guide us, and to, you'll see their expertise by their comments. And I welcome Dr. Madhusudan Rao. Madhu is a dear friend, and amongst all, probably he's the youngest one here. He's 64 now, unbelievable. And his academic achievements are innumerable. Besides his, PG from the PGI Chandigarh, the prestigious institute, he has many academic achievements with his name. And besides running a hospital in the rural area of Andhra Pradesh, serving rural popularity there, he's doing a lot of, social work for the people. He's helping people achieving their many of the dreams coming true. He's involved in so many social work and other things. He's doing hundreds of surgical procedures free of cost for them every year through his hospital. Thank you, Madhu, for being with us. And we have done a couple of workshops at his place, his center, and he's amazing. And today we'll be benefited with his presence. And then we have Dr. Gautam Khan from Guwahati. He's known for helping youngsters, training them in basic otology, rhinology, laryngology. He's master of all, doing training people in every field of otolaryngology, and attached with a prestigious hospital like Apollo and the Pratiksha Hospital in Assam. And today, thank you, boss, for coming with us. Thank you so much. And today with this panel, I'm sure we all will be benefited. Thank you. And before we start, I am indeed grateful to the Sun Pharma for making this happen and the mastermind behind this show. No words to thank him, Dr. Rajeev Pachauri and Dr. Paramita. And Paramita looking rejuvenated today with your illness now, and I'm sure we'll have more and more questions today.
Okay,
So
surely.
thank you all. So
Satish, a few words, Satish.
yes,
Sorry for the interruption. Thanks for this affectionate word. But before you start the live surgery, just a few words. I have seen all your webinars, maybe 12, maybe I think one or two I have missed. I can say you are like a Vignan Bandhar, like knowledge treasure.
no,
The
no.
amount of
I'm a student, boss.
I can describe you as a 5D personality. First, it is your desire, dedication, determination, discipline, and deadline. You take time and you stick to time, answer the questions, and I think, among all the webinars, the ENT webinars, you are the most popular. And I am going to be, it will be, all these webinars are going to be like a Gita. Go back, revive, recapitulate. Thanks for all the things. Great.
Thank you, Madhu. And today, again, we have an opportunity to learn more and more. Every day we are learning something from the masters. And today, Professor Sachs, he has been amongst the pioneers in propagating concepts of endoscopic surgery, not only sinus surgery, but beyond. And now, because of their work, what we are following, we are able to do more and more advanced, addressing more and more advanced lesions of the skull base. So, sir, today we are starting with this first case, and I will share with you certain details of the patient of this first case. So, can you share the screen, please? Are you getting my imaging pictures?
Yes.
Yes, we are.
Okay. So this guy, this is a 13-year-old male who presented with a history of nasal blockage and intermittent epistaxis. On endoscopy, it revealed a mass in the nasopharynx and the posterior part of the nasal cavity. 13-year-old male with history of nasal blockage, epistaxis, and the mass in the nasopharynx itself takes you to the diagnosis of a JNA until proved otherwise. And we all know JNA being have a propensity to bleed. We are never, prone to take a biopsy for such lesions. So, in order to substantiate your diagnosis, radiology is the key. And for, like we discussed in the previous JNA case, the first radiological investigation to be ordered for all these JNA, when you suspect JNA, is a contrast enhanced CT scan. This gives us lot of details, anatomical details, and the extensions of the tumor. This tumor has a propensity to invade certain areas. This is characteristically growing to the certain areas preferentially, which gives us a diagnosis, which confirms our diagnosis of JNA. We all know this is a very vascular tumor. A diagnosis is highly relied upon radiology. MRI is needed once the tumor invades the skull base high up on deep intracranial structures. Then we need to have an MRI to have a clear relationship, understanding of that relationship with the nerves, vessels, and the certain intracranial structure. Otherwise, good contrast enhanced multiplanar CT scan is good enough. So first of all, I'll take you through certain findings of these tumors in this particular case, and then I will take you through the CT angiogram pictures. This is basically a CT angiogram I'm showing, which I'm using as a contrast CT scan as well. So, first of all, as I said, this tumor has a typical origin from certain area. Let me tell you. This tumor typically starts in the region of a pterygoid wedge, the anterior surface of the pterygoid process here in the vicinity of the sphenopalatine foramen. And then this preferentially extend to the posterior part of the nasal cavity and the nasopharynx, and then laterally to the pterygopalatine fossa and the infratemporal fossa. That is how this tumor preferentially spreads. This goes circumferentially. Then it invades the pterygoid process, then it may go up towards the skull base, towards the middle canal fossa. It may invade the orbital fissures to go further behind into the cavernous sinus and all. So first thing we want to know the extension, and this characteristic extension, if you go through in all three planes, you'll get to know how this tumor is going. I'm reconstructing again, and this is the sagittal picture, and you see how this is the tumor which was arising here in the region of the pterygoid and invading everywhere. Now, the first and the most important thing which I am going to take you through is this patient was referred by a surgeon and the radiologist reported as a lesion invading the pterygopalatine fossa, infratemporal fossa, nasopharynx and nose. That's it. Because it was a single plain printout of a CT scan picture. One axial, one sagittal, one coronal, that's it. We didn't have DVD, we didn't have other pictures of the other areas. Then we got this CT angiogram and I will take you through certain important picture where this tumor is going. Now see, this tumor is going in the infratemporal fossa. Can you see? From where it this tumor is, see here. From the infratemporal fossa, here it is coming behind the maxillary sinus. See this? And here ascending into the orbital fissure. Can you see here? Can you see this tumor ascending into the?
Yeah, very nice.
See the orbital fissure? Let me show you through the sagittal plane first to give you a three-dimensional understanding how this tumor is going from where to where. See this tumor, it is ascending to the inferior orbital fissure, high up towards the superior orbital fissure here. And then from here, see, so interesting, which was so easily missed even by the radiologist.
Yes.
This tumor, let me reconstruct back to the coronal. This tumor is ascending high up. See from here, this is superior orbital fissure where the tumor is going. Now, if I go behind, see how vascular it is, a bunch of vessels in the tumor, bunch of vessels. And then it is going into the orbital apex. This is superior orbital fissure. You can compare with the opposite side. See the opposite side. See the opposite side, superior orbital fissure. If you remember the endoscopic dissection that day, I mentioned three landmarks. The maxillary strut separating the V2 from the superior orbital fissure, then superior orbital fissure up, then the optic strut separating from the optic canal. See, this is the clinoid process from where the optic strut is arising, and below that and anteriorly, this is the superior orbital fissure. And this is where the tumor is widening the superior orbital fissure, number one. Number two, as we go behind further, the posterior extension of the superior orbital fissure is what? Cavernous sinus. Or you can say the anterior extension of the cavernous sinus is simply the superior orbital fissure, where all the nerves coming from the cavernous sinus lead to the orbit. And this tumor is going behind from here into the cavernous sinus. This is cavernous sinus proper. And as I go behind, see, this is the cavernous carotid.
Yes.
That is the cavernous carotid, and if I follow this carotid, this is ascending as a supraclinoid in relation to the clinoid process, and as it goes up, it leaves the ophthalmic artery over here.
Okay.
So, see, this tumor is in close proximity to the carotid artery, pushing the carotid behind. I will show it from the other angle, how it is pushing the carotid behind. Now, this is the simple extension of the tumor arising from the pterygoid wedge, going to the posterior nasal cavity, nasopharynx, going laterally to the pterygopalatine fossa, infratemporal fossa, then through the inferior orbital fissure, then superior orbital fissure, and then behind to the cavernous sinus, where it is in close proximity to the carotid artery with a thin periosteum separating. You can see. Now, there are a lot of things we expect from the radiology to give us more and more surgical details. And as I said, radiology is a roadmap. We need to see ourselves, the radiologists, rather than relying on the radiologists, because radiologists most of the time blinded with the clinical details. We need radiological details to understand in terms of our surgical, to make our surgical course simpler. So what radiological detail we expect from this CT angiogram? Number one, let me take you. See this quickly. We first of all need to know what vessels are supplying this tumor. Now, there is a difference. If the radiologists say the internal maxillary artery is supplying to this tumor, fine. But what all we need to know is how the internal maxillary artery is entering into the tumor. If I know how the internal maxillary is entering into the tumor, with this endoscopic approach, I'll have a full 3D picture in my mind where to go and catch the internal maxillary. Secondly, we need to know if other vessels are supplying the tumor. I told you, if the tumor is supplied by vessels from behind, we cannot go and catch them before removal of the tumor, and that is simply a contraindication to endoscopy or the need of embolization. Professor Sachs, we are not routinely embolizing these tumors. With the simple principle which I am going to show you, we use coagulator to stay on the periphery to devascularize the tumor all the time. We believe in exposure and exposure and exposure three-dimensionally all around 360 degree around the tumor before going into the tumor. Then we catch the principal vessel, that is internal maxillary, which is anterior to the tumor, devascularize it, and then we remove the tumor. So we need to know how the internal maxillary is entering into the tumor. So here my CT angiogram, if I show you my CT angiogram, you can have a quick look at the CT angiogram quickly. This is the common carotid artery. Can you see? Yes. Now it is dividing into the internal and external carotid. See carefully.
Right.
This external carotid here, it is giving the first branch. That is, see this? This is the thyroid artery going to the thyroid. Then I go back further the external carotid. I am following the external carotid only simply. Other branches, the facial, lingual, I am leaving. Following the external carotid, I am following the external carotid. It is going behind. Can you see this?
Yes, clearly.
Behind the mandible. See, keep an eye on this vessel. External carotid. Keep an eye. Chota karna hai. Why it is
Just
not?
zoomed out too far.
Yeah, I am just showing. Yes. Coming smaller. Yes. So this is external carotid here. Now you will see how this external carotid is dividing into two vessels. Can you see here?
Yes.
Yep.
Yes. See, this is the superficial temporal going out, and this is the internal maxillary. I'm following the internal maxillary here. See this internal maxillary, huge.
Yes.
How big the internal maxillary, and this is classical in JNA. When it is the principal vessel, it becomes very, very big. See, the size of the internal maxillary is like size of the external carotid here.
Yes.
And if I follow the internal maxillary, see this. I'm following this internal maxillary. Let me reduce the size. Yes. See, follow this internal maxillary here where my cursor is, and now where it is going. See this. This is the tumor in the infratemporal fossa, and this tumor is going the vessel is going anterior to the internal tumor. Can you see very clear?
Very clearly.
And this is the where behind the posterior wall of the maxilla, the anterior most structure is internal maxillary, and this is how it is so easier to be caught. When we do the Denker's approach, see my tumor is laterally going till here. So what approach I am going to use from here endoscopically? Like this. I will remove this medial wall of the maxilla and the anterolateral wall of the maxilla to go head on to the lateral part of the tumor. When I remove the posterior wall of the maxilla, the first structure I am going to come across is internal maxillary. And that is what I need to ascertain from CT angiogram. Number one. Number two thing, during surgery, sometimes because of the big tumor, it is difficult to identify the vessel into the tumor. So how can you have your landmark inside the tumor? See again how you can follow this vessel. That was the internal maxillary here in the axial. You see here.
Yes.
If I reconstruct and bring my cursor over here, you will find the same vessel in the coronal plane. Can you see here now?
Yes. Seen.
See my vessel here in the coronal plane. See this vessel.
Yep.
See this vessel, how it is ascending, and see how this vessel is ascending into the tumor. See this vessel?
Yes.
This is the internal maxillary. This is the internal maxillary, and this is how this vessel is going. See this, how this vessel is going behind at this level. So now, what will I keep in my mind as an idea how to find this vessel? See this level of this vessel. I will relate this level to two landmarks. My level of the palate. See this level of the palate?
Yes.
And from here, this is 1.6 centimeter above the level of the hard palate behind the posterior wall of maxilla, and I will be right on the internal maxillary. There should be no confusion. you can go and catch this vessel so easily. And that is what I'm going to show in surgery as well. As I open the posterior wall of the maxilla, behind the posterior wall of the maxilla and the periosteum, exactly at 1.6 centimeter above the level of the hard palate, I'm going to find this vessel, horizontal vessel. So that is another utility of seeing the CT angiogram yourself. Your radiologist will tell you this vessel is the tumor is being supplied by internal maxillary. But how the internal maxillary is entering into the tumor, you need to see yourself. That is number one. Number two, if any other vessel from the external carotid branch is supplying the tumor. Fortunately, this tumor is not being supplied by any other external carotid branch. Third is, now see very important thing. That is very so important. I found in this tumor is supplied by one of the most important branch from the internal carotid system. How to find out? See this. I am following the tumor, following the tumor. This is the superior orbital fissure part. This is the cavernous sinus. The same tumor what I was showing in the coronal section. You can see here. This is superior orbital fissure. This is cavernous sinus behind. This is carotid artery. And see, a thin periosteum is separating the tumor from the carotid artery. And this is almost always there. See how the vessel is ascending up to become supraclinoid. Can you see very clear?
Yeah, very clearly.
And in primary tumor, this is always a thin periosteum separating. This is never an invasive tumor in primary condition. In revision condition, it can be invasive. It can happen anything to the tumor. But in primary, it is purely non-invasive. It is spreading by means of expansion, and there is always a periosteum intact between the tumor and the carotid. Howsoever, it is spread in the cavernous sinus. Now, another important thing, if I follow this vessel here, up, I can see the first retrograde branch. Can you see this?
Yep.
Yes.
That is ophthalmic artery. Ophthalmic artery. See this? So clear. Now, if I follow, for your just for your reference, if I follow this vessel, see this, I am following this vessel in the orbit. Can you see this?
Yes, sir.
Very clearly.
Very clear.
See how it is going into the orbit?
Yes, yes.
Three structures in the orbit, I want to tell everyone here. This is very important from anatomy point of view. Three structures entering into the orbit, crossing the optic nerve medially, from lateral to medial. And one of them is ophthalmic artery. It runs inferolateral or superolateral, then crosses the optic nerve and come towards the medial side to give anterior and posterior thyroidal arteries. Okay, number one. Number two, can you see this structure where my cursor is?
Yes.
This superior ophthalmic vein. This is another structure which crosses the optic nerve from lateral to medial. And third is a small nerve, nasociliary nerve, which we can't see here. So three structures crossing the optic nerve from lateral to medial into the orbit. Now, if you follow this nerve vessel, believe me, with this good CT angiogram, I can show you the anterior and posterior thyroidal arteries so easily with this angiogram. Let me show you quickly, because these arteries we always discuss in sinus surgery. The anterior and posterior thyroidal artery, why not to see them now? See, this is ophthalmic artery. I take my cursor on the ophthalmic here. And see, I come onto the coronal. This is my level of the ophthalmic. See, this is my ophthalmic artery here. Can you see?
Yes. Yes, you
Now,
can see clearly.
if I follow here, the first branch it gives is a lateral one lacrimal artery.
Okay.
Sometimes the tumor deeply invading the orbit, they acquire additional supply from the lacrimal artery. We have seen a couple of times. Then if I come anteriorly, see this ophthalmic artery follow. See this artery, and there here it is dividing into vessel, and this is the branch. This is anterior thyroidal artery for everyone. Where it is going? At the confluence of superior oblique and the medial rectus. Can you see where this anterior thyroidal artery, and this is going to leave the orbit here at this point from through the orbitocranial canal to the intracranial fossa. That's how you can follow these vessels. Now the second thing, what I was about to say about the vascularity coming to this vessel from the internal carotid system. Now see, if I show you this tumor here in the coronal plane, you saw this carotid artery
Yes.
up there and dividing into the anterior cerebral and middle cerebral. What you need to see, the ACOM. See the ACOM forming so well. That is the communicating artery. This is important once you deal with the tumor involving the carotid artery, you need to have a good idea of the cross flow from the opposite side in case in any unfortunate situation, if you need to sacrifice the artery is injured, whatsoever happens, you need to have a full information of the cross flow coming from opposite side. So at this point, if I follow this vessel behind, now follow this vessel, this is the cavernous portion of the artery. In the horizontal cavernous portion, laterally it gives off a branch, inferolateral trunk. Okay? And see here, this tumor is supplied by this inferolateral trunk. Can you see very clear or not?
Yes, yes.
Yes, very clear.
See, this is the inferolateral trunk, which is emerging from this vessel. See this?
Yeah.
And this is supplying to this tumor in the cavernous sinus. Now, when we talk of embolization, what do we expect from the embolization? It looks so fascinating that once you embolize the tumor, there should not be any bleeding. It should behave like a polyp. It doesn't happen like this. The reason is there are three major sources of bleeding. One is the external carotid branches, like in this case, internal maxillary. I will go and catch the internal maxillary intraoperatively like an intraoperative embolization to devascularize the tumor, number one. Your embolization cannot embolize the internal carotid branches. So what we are not doing? Your embolization cannot embolize the veins. They are the major source of bleeding once you go into the skull-base bones or the infratemporal fossa. The venous bleeding is a significant contribution. Your embolization takes care only of the external carotid branches. And if we know we have a principal artery internal maxillary supply, we have to go and catch rather than wasting time and money in embolization. That is what our principle is. And this is what we are going to follow in this case as well. So what we get to know from this CT angiogram, the extension of the tumor, the location and the course of the internal maxillary going into the tumor as a principal supply, the internal carotid contribution from the inferolateral trunk laterally, you can see this is the inferolateral trunk in the cavernous sinus. And if you want to see the other view of this carotid artery in the cavernous sinus, how it is ascending and how the tumor is pushing it up. See this in the sagittal plane. Let me show you in the sagittal plane. See this vessel. This is carotid artery. See this carotid artery here. And now it is coming in the cavernous sinus, ascending up, ascending up, ascending up, ascending up. And here is the tumor. So we know the internal carotid contribution for this tumor. Third is, we know no other external carotid branch is supplying. We know there is a thin periosteum separating from the carotid and the tumor is entering from the site of origin circumferentially everywhere. See, this tumor is arising from this region, pterygoid wedge, and it is spreading everywhere. Laterally, it is going to the infratemporal fossa, superiorly going to the orbital fissure. This is superior orbital fissure, and from where it is going in the cavernous sinus behind and separated from the carotid artery. So, like the tumor is going everywhere, we are going to pull it out from everywhere. This is going to be the principle. What all we need is the exposure. So, my 90% of the surgical time is going to be invested in exposure, exposure, and exposure. I'll expose from all around, anterolaterally, medially. I'll take the internal maxillary in control in the beginning as I go behind the maxillary sinus, and then we'll expose medially, posteriorly, behind, everywhere, and then we'll start delivering the tumor. This is going to be my plan. Sir, your opinion, anything you do differently or any suggestion?
Well, I'm absolutely fascinated and in complete awe of you, Dr. Jain, and I have always been. And I think for you to consider yourself a student, not a teacher, is a gross injustice to yourself. I think you're one of the leading teachers in the world, and I'm in a position where I've been fortunate to watch Dr. Stam and Dr. Sethi for 2.5 decades, and I've learned so much from them, and I'm going to learn so much more from you. I've just got one question. Do you have any concerns about the ascending pharyngeal coming from behind?
Yes, sir.
Because our access there is so limited.
Yes, absolutely. You're absolutely right. That is so valid a question. In the last case, sir, 2 weeks before when I demonstrated one JNA, there was a small branch from the ascending pharyngeal going to the tumor. And this is such an important concern Professor Jacks has raised, Professor Raymond Sachs has raised. This ascending pharyngeal enters the tumor from behind over here. See this? This is ascending pharyngeal. And if it goes to the tumor, it enters the tumor from behind. Now, once you are delivering a tumor without embolization, our principle is go and first catch the vessel. If your vessel is coming from behind, you can't go and catch the vessel first and then deliver the tumor. And that is something is against the endoscopic procedure. So what we do in those situations, that's why we get the CT angiogram done. If the tumor is getting supply from any other vessel coming from behind the tumor, like a month ago, we had a tumor which was high up in the infratemporal fossa. It was in the peripharyngeal space. The tumor was taking supply of a huge branch from the ascending pharyngeal, meningeal branch of the ascending pharyngeal from behind, and had a huge supply coming from the middle meningeal from behind. That patient, we got embolized. We had no option but to do that.
Yep.
Because we can't control those vessels which are coming from behind before delivering the tumor. So
Yep.
that's a very important question. If you have a vessel coming from behind, what to do? And then the only embolization option left is the embolization. And sir, we offer our patient when we embolize, if we can afford, we offer onyx embolization. Intratumoral onyx embolization, which we believe is the best. The cost is a limiting factor, we know, here in our country. Otherwise, onyx, in our opinion, is the best. We have a very good experience with the onyx. It goes to the tumor of microvasculature in the depth, and you can literally debride the tumor with your microdebrider after that, with hardly any bleeding. But the cost is for this tumor, this big tumor, this dimension of the tumor, probably I will need at least 10 vials of onyx. 10 vials means $18,000 for the embolization. And that is a big, big factor in our country.
I understand that completely, and I really respect and appreciate what you're saying. I've actually only ever done 4 JNAs without embolization. 3 of them were in India and 1 was in Myanmar. So in Australia, I've never done it without embolization. So I'm really, really keen to see how you manage this.
Yeah, thank you. And for that matter, in embolization, like in our country, whenever we talk about embolization, I always mention it's not all that easy. You need to have an expert intervention radiologist. Embolization has its own hazards. If the intervention radiologist is no experience, not very careful, if there are dangerous anastomosis with the internal carotid, it can lead to complications. A lot of complications have been reported earlier. Cranial nerve palsy, blindness, all have been reported because of the dangerous anastomosis. Nowadays, with the... Yes, sir.
No, I agree 100% that embolization is not a benign procedure. It's an invasive procedure in its own right, with significant complications in a young man.
Yes. And you know, the second thing, why we are against this policy of embolization, besides the cost here in India is a big factor. Believe me, if we get this tumor embolized, in less than that amount, we will operate this tumor completely. So cost is a big factor in our country. Secondly, there are a lot of studies, and even we have observed post-embolization, we all know this tumor has a typical nature or a kind of extension goes to the narrow crevices and canals like Vidian canal and so many. All these tumors post-embolized, they get collapsed. They get crumbled, and sometimes it becomes difficult to identify those collapsed tumor, and you may leave behind. This is a benign tumor. This is a benign tumor, pure benign tumor. It cannot recur unless it is left behind. It is always a residual tumor which regrows to a bigger one. If it is completely removed, we can give it a complete cure to the patient. So, radical removal is necessary, and in that sometimes the embolization is a big problem. It affects your identification of the tumor in those difficult areas. Last time we had a tumor which was going in the pterygoid process. It was deeply invading the cavernous bone of the pterygoid to all the narrow honeycomb bone of the pterygoid process was completely involved, where we removed the tumor and drilled away the pterygoid completely. So that is one of the commonest site of the so-called recurrence. That is the commonest site where the tumor is overlooked easily. You can leave the tumor behind and then it can come back. And once the tumor which recurs, now the blood supply is never predictable, because you have already taken off the predictable blood supply from the internal maxillary and all. And most of these tumors invading the pterygoid, they invade further skull base as they acquire more and more blood supply from the internal carotid, and they become truly invasive. We have seen many of these revision tumors going purely intracerebral, not only intradural, intracerebral, completely invading the brain tissue, which a primary tumor never does. Never ever the primary tumor does. However big it is, it never does. Second philosophy of ours, what we believe in is this extension of the tumor in the primary situation. Whatever tumor size it is, wherever it is extending, if we follow the exposure protocol, which I'm going to show now, the Denkers and the extension, one can remove the tumor with any extension with the endoscopic approach, provided it doesn't have any blood supply from the intracranial vessels, like middle cerebral artery and other anterior cerebral artery contribution. If they are coming, then you can't control. Otherwise, you can remove endoscopically. It's not that we are avoiding an incision. That's why preferring endoscopic. Anything which gives an external scar but a good result, I will go for it. The reason for endoscopic is this excellent visualization this endoscope provides, because this tumor is going to go in the narrow areas here and there, and you can't identify with the open approach unless you have a brilliant illumination from the endoscope, on-site magnification and illumination. And that gives you opportunity to go that to the narrow angles, to the blind areas. You can go and drill there with your high-speed drill and remove the tumor from all these areas to prevent recurrence. So this was about the radiology part. Any questions we can take this time?
Satish, the picture which I am seeing now on the screen, the spinopalatal foramina or the entry into the nasal cavity is almost more than 1 centimeter wide.
Yes, that is a classical sign. If you see this,
opposite is very narrow.
Yes, this is the pterygopalatine fossa on this side, and Madhu, you have rightly picked up. Yes. For junior colleagues, this widening of the fossa, yes, because of something mass lesion coming from behind, yes, pushing the posterior wall of the maxilla anteriorly. This was described by the Hallman and Miller long back. Is known as a Hallman-Miller sign, and that is classical for any tumor coming from behind and pushing the wall of the maxilla anteriorly. So
another question I am getting, you were talking about embolization. Previously, they used to use gel foam. Is it still used, or the disadvantages, yes, are more than advantages?
Madhu, this is actually the domain of intervention radiologists, and I am in very in close touch with them. Yes. They use variety of materials, you know, but that's I believe nowadays this liquid embolization with the onyx is the safest. Yes. Yes. The commonest material they use is the particulate, the PVC particles, yes, of less than 150, 200 micron. That is good one. It goes to the depth of the tumor, but still it doesn't block the tumor microvasculature. So in spite of having blocked the vessel laterally, the big vessel, you may not control the bleeding completely because you don't devascularize the tumor microvasculature. That's the biggest drawback of the embolization, because first of all, it controls only external carotid branches. It doesn't have any effect on the venous bleeding, doesn't have any effect on the intracranial bleeding. And that too, when the external carotid branches are not embolized to the level of microvasculature, it is of no use. There is no fun. And the same effect you will see, you have seen last time. I will show this with the endoscopic approach when we go and catch the vessel directly and devascularize the tumor. And second thing is our philosophy. With this tumor histology, we have observed a lot of publication on the histology. This tumor has a maximum vascularity on the surface. As the tumor grows bigger and bigger, in the center it becomes more and more acquire fibrosis and less vascularity in the center. So if we use the cobbletter on the surface more and more, we devascularize the tumor more and more. It results in tumor shrinkage as well. Visible shrinkage of the tumor you will observe when we use cobbletter. And that really helps us in maintaining our visualization, because you know what happens otherwise on the surface. If your any instrument happen to touch the tumor, it is going to bleed like anything. It will not allow us to work. And in endoscopy, the most important thing is the visualization. Yes. So this surface with coagulation, it helps you, visualization of the tumor all the time like anything. Professor Sethi, when you give green signal, I will go for the surgical part.
I can't wait. Let's go.
Satish, I want to make a comment.
Yes, Ashish.
What a brilliant simplification of a complexity. I mean, this is what, and he's laying bare the tools of his thought. Actually, this surgery is over in his mind. When he has in such great details analyzed the vascularity, and the demand of this imaging is about the supply. His surgical strike is only on the arteries. He's not worried about the tumor. I think that is how he is planning his surgery in millimeters and in anatomical landmarks. He knows exactly what to find where, so there is no fear. One of his missions of his surgical training.
I always emphasize on radiology. Radiology is most important. It is not only
I think the surgery is over in your mind. The way you have shown the arteries, and you have to go catch them. The surgical strike is on the arteries. The tumor has to come out. This is what I want to bring the thought process of this great master. They say that if you cannot explain something to a 6-year-old, you have not understood it yourselves. I think Satish has explained this to a 2-year-old. Thank you, Satish.
Satish,
thank you, man.
Satish, any additional information with MRI?
Yeah, that's a very good question. We didn't have MRI of this patient. I'll tell you the reasons.
Yes.
MRI is useful further to substantiate your diagnosis by means of a characteristic picture of flow voids in a vascular lesion. Number one.
Okay.
So it helps you achieving your diagnosis better now. Secondly, I told you, those tumors which invade the pterygoid process deeply, it is only the MRI which can give you a proper information about the invasion of the bone marrow of the pterygoid and the sphenoid bone. You know what happens?
Yes.
MRI in a particular sequence of fat suppress imaging.
Yes.
The bone marrow has a fat.
Yes.
In a normal side bone marrow, where there is no tumor, when you suppress the fat and do the imaging, you will find absolutely dark.
Yes.
But in cases where the tumor is invading the marrow spaces, it will not be dark, and that is the sign that your tumor has invaded the marrow spaces that may not be visible even endoscopically.
Oh.
You may find absolutely normal endoscopically, but yet your marrow spaces is invaded by the tumor, you can overlook, and then the recurrence is imminent. So that's how the MRI is important when the tumor deeply invades the sphenoid bone and the pterygoid process. Third is relationship with the great vessel. Here I found on CT angiogram a good periosteum separating the tumor from the carotid. I didn't find the need of getting unnecessarily an MRI done. Otherwise, yes, MRI is indicated to have relationship with the dura, with the carotid artery, with the optic nerve, cranial nerves, and beyond the dura. So it is important. MRI is useful for deeply invading tumors to substantiate the diagnosis, and most importantly, what I believe, the invasion of marrow space, because that cannot be picked up by any means. By the brilliant endoscope, CT scan, your vision, your experience, nothing can pick up the marrow invasion. Only the MRI can pick up. And you get on MRI a T2 weighted fat suppressed image, you will find if there is tumor inside the marrow space. That is the value of MRI.
I think, Satish, we should start with the surgery now.
Okay, boss. Let's go ahead. And I'll be with the endoscopic picture in a couple of minutes. You can continue the discussion meanwhile.
Satish, one question.
This is the 1 square inch area that we were discussing on the previous anterior skull base dissection, when you were saying that this area terrifies the surgeon.
Yes. Oh, that's an important point, Paramita. Thank you. I forgot. And I want to bring to your notice again, if you remember our endoscopic dissection where I repeatedly mentioned 1 square inch area.
Yes.
See this?
Yes.
Professor Sachs, this one square inch area I always mention at the level of the skull base for the endoscopic surgeon, which frightens the endoscopic surgeon. What is that 1 square inch area? In this 1 square inch area are a lot of cranial nerves.
Yes.
In this 1 square inch area, below is V2, above is all the cranial nerves in the superior orbital fissure, then superior and inferior ophthalmic veins, then behind in the cavernous sinus, the carotid artery and the cavernous sinus itself. This 1 square inch area is so critical. Any tumor arising in the nose and paranasal sinuses, if it is invading this space, it frightens the endoscopic surgeon. So we must be well versed with the 3-dimensional in-depth anatomy of this area. And this tumor is typically invading this 1 square inch, you can see.
Yes.
So I will show
very much so.
with endoscope the entire anatomy of the superior orbital fissure, cavernous sinus, the carotid artery. We have a Doppler here. And another thing I forgot to mention here is something about the ophthalmic veins. Since this tumor is invading deeply the cavernous sinus, the veins draining into the cavernous sinus are engorged. Can you see the superior ophthalmic vein?
Yep.
Compared to the opposite side, is completely engorged. And same is with the inferior ophthalmic vein. These veins are engorged, which are giving us a picture how their flow is obstructed because of the tumor compressing in the cavernous sinus. And this is so important. All these patients should be screened for their vision field, and they should be counseled well for the vision as well, because we are going to go typically in the close proximity to all these nerves which are responsible for the vision and the movement of the eyeball.
Peculiarly, the sphenoid opacity looks different from the tumor. Sphenoid is only...
This is secretion.
Secretions only.
Secretion.
See, the tumor is enhancing, and see, this is hypodense. This is not taking contrast. This is secretion. This tumor is typically not going into the sphenoid. See this?
Yes.
Not going, and it is ascending in the terrible. And see the terrible blood supply. The bunch of big vessels. This tumor is nothing but a bunch of vessels in a single line. Single line vessels in some of the fibrous stroma, but more and more vessels. That's it. These vessels do not have, the muscular wall, elastic wall. Once these are punctured, they keep on bleeding. They keep on bleeding. They never stop bleeding like a regular vessel. That's why we are so frightened with the bleeding part. So let's go ahead. I hope you are all now tuned with the extension of this tumor three-dimensionally and the vascularity as well. So let's go ahead with the surgical part. In a couple of minutes, I'll be back with the endoscopic picture. You can continue meantime.
Very beautiful radiological explanation. I don't think even radiologists can give such a detailed explanation, sir.
There's no radiologist that would compete with
Madhu,
that, please.
Radiologists know all this,
But
the problem is a big gap among the surgeon and the radiologist.
Yes.
I tell you, we refer a patient for a CT PNS when you plan a sinus surgery.
Yes.
A radiologist will give bilateral pen sinusitis. That's it.
Yes.
It's of no use for us. We want anatomical details. Like radiologists here will give us an entire picture that the tumor is being supplied by maxillary artery. But we want more details how the artery is entering into the tumor. That's why we need to see ourselves. Because radiologist is not knowing the importance of this fact, how the artery is entering into the tumor. That is what we want.
Satish, they just tell you that there is an enemy out there.
Yep.
And
Madhu, I think this is
better yourself.
Yep.
Yeah. So
Madhu, I think there's a very, very big difference.
Yes, sir.
Sorry.
A day has
think
come.
there's a very
Radiologists will ask the opinion of Satish. Radiologists will ask the opinion of Satish rather than reverse going.
So there's a question.
But I think, Madhu, that there's a very, very big difference. And when we examine on radiological interpretation, we will specifically direct our exam candidates to give us a diagnostic assessment or a surgical assessment. And they're very, very different. What we just got from Dr. Jain is probably the single best surgical assessment of a CT scan that I've ever heard. And that was unbelievably impressive, and I learned a fortune. But it's not a diagnostic assessment. It's not saying there's tumor, there's secretions. And I think that was a very valuable lesson for everybody. So thank you, Dr. Jain.
You are correct, Raymond. You are correct.
There's a Dr. Zia from Pakistan. She's saying that I did one angiofibroma and ligated internal maxillary artery as taught by Dr. Satish Jain sir in the last webinar. So it's just an example of so many surgeons all across the world. By watching these webinars, we can actually do the surgeries on our own, and it is so much informative for all of us.
Thank you. That is something which is making us happy. Now see, are you getting the endoscopic picture?
Yes.
Beautifully.
Yes. So how is the picture, sir? Is it good?
Beautiful. Beautiful.
Oh, great. So now this is the left side nose. We have not prepared yet. We have not done anything to it. And this is the right side picture. So first of all, my preparation starts with these gauze pieces soaked in ringer lactate and adrenaline. This is our solution we want to use here in this young child.
Why ringer lactate instead of normal saline, Satish?
Madhu, it has now been proven.
Yes.
In the lot of studies, the ringer lactate is more physiological to the mucosa as compared to the saline, as it contains additionally the potassium and lactates.
Yes.
So it's better than normal saline for the mucosa. And everywhere, even in the nose, while doing sinus surgery, post-op irrigation, everywhere, we are now totally switched to the ringer lactate than saline for irrigation and all those things.
Yes.
So it is much better. So why not to follow that? See now, this is the first picture of the decongestion.
Decongestion. Undiluted adrenaline, or you dilute
adrenaline. This is a young guy, so I'm using 1:1. I don't mind using in young patients even pure adrenaline.
Oh, very.
Because I'm using on it topical, and I have said already mentioned umpteen times that we never use any infiltration in the nose for anything.
Yes.
Whether doing sinus surgery, skull-based surgery, or whatever, we never use any infiltration for anything in the nose. Nose is richly vascularized, and if your adrenaline goes in the systemic circulation, and it can create a lot of complications.
There is no role of infiltration now for nasal surgery at all.
It's not about the role, no advantage.
Advantage, okay.
You can achieve the same field
with packing.
By topical, by taking into consideration the other measures, like you can keep the head up to facilitate venous drainage.
Yes.
Like in sinus surgery, you can reduce the heart rate by giving bradycardia to the patient.
Yes.
Or in this patient, this is purely arterial bleeding we are going to deal with. So here a controlled hypertension is very, very important.
Yes.
So we are taking into consideration all these, the controlled hypertension, the reduced heart rate to reduce the overall cardiac output, and then this saline adrenaline. And this is the primary picture, you know?
Yes.
Okay. Now my best tool, which I always mention for this surgery, which I call it as a man of the match tool for this surgery, entire surgery is the coblation.
Coblation.
And I tell you how we are able to achieve the resection of such tumors without embolization and without transfusion, however big they are. Because the principle remains same. Exposure, exposure, exposure. Not to fiddle into the tumor unless you catch the vessel completely and expose it completely from all around. Okay?
Sir, any special anesthetic implications? Because 13 years old boy to have a controlled blood pressure, anesthetic.
Yeah, these are the young chap who can tolerate any change in blood pressure and all. Okay. You cannot afford to give hypotensive anesthesia in elderly labile patient as compared to the young patient. Yes. I can use 1:1, even pure adrenaline sometime in young patients as a topical agent.
Yes.
But we don't do such in the elderly patient for other surgeries. Huh?
Yes.
Dr. Amit Keshri is asking, how many units of blood have you reserved for this patient as the blood volume?
We always reserve 1 unit of blood. Like in last patient also we reserved, but we didn't use. In our over 85% of the cases, we don't need any transfusion for that matter, using this technique. Now my first thing starts. My first goal is to expose the tumor anterolaterally by means of a Dankers. And for that, like we have shown Dankers many a time in these webinars these days, right from the live cases to the cadaver. Our Danker is removal of the medial wall of the maxilla along with a part of the anterolateral wall. This is modified Dankers, what we do endoscopically, which were described by the Danker earlier through the sublabial approach. Yes. So my number one concern when you think of Dankers is not to enter into eyeball above. Eyeball is just above the maxillary sinus. And you never know from here where the maxillary sinus roof is. So what you can take an idea by and large is stay centimeter below the axilla. Stay a centimeter below the axilla. Now I'm using my 70. Ablation, directly ablation here.
Yes.
Now using ablation to remove this mucoperiosteum. We all know this nasal cavity mucoperiosteum is very vascular. Using the coagulation makes your life easier. The only disadvantage of the coagulation is it doesn't work on the bone.
Yes.
So whenever...
This is EVAC 70, Satish.
This is Pro Size Max, man.
Okay, Pro Size Max, okay.
See what we got in the beginning.
Yes.
What we got in the beginning, as I was cutting the periosteum, there was some oozing from the underlying bone. Can you see?
Yes.
And how you can control? Once the oozing comes from the bone, your coagulation is not going to work. And then your cautery is one which is going to work. See, this is the bleeding coming from the bone. Can you see here?
Yeah. The point is clearly visible and coagulated.
You cannot afford to use the coagulation on the bone.
Yes. This is unipolar suction diathermy.
Yes, suction.
Yes, beautiful.
See, once it comes to the bone, you cannot afford to use coagulation, otherwise that will ruin the blade. Went completely.
So the whole armamentarium should be ready in your hands.
Yes. See now, I am removing more and more this mucoperiosteum.
Yes.
Anteriorly, coming to the level of the pyriform aperture.
Satish, the intermittent irrigation that you're doing is also with Ringer's lactate?
Pardon?
The intermittent irrigation that you're doing, that is also with Ringer's lactate or saline?
No, are you using intermittent irrigation?
Yeah, it is Ringer's
or normal saline?
My coagulation was not on the proper setting. Why did you change this?
Satish?
Yes.
What is your protocol for revision cases, revision angiofibroma, especially in reference of vascularity? How you can
vascularity in revisions? Mostly the vascularity is from the aberrant vessels, and in that situation you have to be different than the primary situation. After the angiogram, if you find the aberrant vascularity, you have to be more prepared for the bleeding.
Yes, sir.
Because even if you embolize those tumors, it is difficult. See this. Lot of bleeding from the bone coming. See this?
Yeah.
Yes.
Usually, sometimes the bleeding comes from the underlying bone, and then you have to. Touch. See this bleeding coming from the bone here in the beginning, you can control with a diamond drill as well.
Yes.
See this unusual bleeding coming from the bone. You can't help it, but cauterize it. Drill. Give me a pack here. See, it's not tumor, it is the exposure which is giving this much of bleeding unnecessarily. See now what I'm using? My diamond. Can you see?
Yes.
Super. Very nice. Is it a 3.2 mm diamond burr?
Yeah, that's a coarse diamond burr from the Medtronic.
Medtronic, sir.
The stylus one. Anyway.
I think you must be knowing now unipolar suction cautery, diamond burr, and precise max coagulator. 3 armamentariums are there ready.
Everything should be there.
Yes, that's what I'm telling you.
Slowly, I'm reaching to the level of pyriform aperture.
Satish, you were talking about revision cases.
Yeah.
Supposing you're doing a revision done by somebody else, where the external carotid has been ligated earlier.
Yeah.
So in those situations, how do you assess the patient?
See, when the external carotid is ligated, first of all, that's a big disadvantage because you cannot do a DSA, or you cannot do any embolization or anything, even if you plan.
Right.
Yes, sir.
So that is something, a procedure we always condemn. See, this is our piriform aperture.
Yeah, very clearly, the cleavage is now very clearly seen.
Now the picture is so clear, except those two vessels, small vessel coming from the bone inside.
Yes.
See, this is an inferior turbinate, which is a separate bone. Can you see this?
Yes,
Yeah.
yes.
Very clearly.
Oh, very
I
clear.
hope the picture is good.
Wonderful.
Yes, yes.
So you have to remove this inferior turbinate as well. Again, when you remove the inferior turbinate, you come across bleeding very often. The reason is the major blood supply into the inferior turbinate comes from behind. Okay? That is a branch of sphenopalatine which we have not taken into control yet.
Satish, what is the settings you keep for ablation, 7 or 8?
The coagulation, my setting is 9 for the coagulation and 5 for the
Yeah.
cutting. Now see, this is the inferior turbinate bone.
Yes, very nice.
Yes.
Submucosal separation is done.
Yeah, because this is attached to the maxilla here. That's a separate bone. And for this exposure, I told you my 90% of the time is going to be invested in exposure.
Exposure and exposure.
Tumor. Oh, power cut. उसको कहाँ मैंने उस पे लगा दे. एक दिन लगे चढ़ा देगा इतनी देर में. Hello?
Yes, sir.
Yeah, increase the light now. Yes, so there was a power fluctuation. Are you getting the picture now?
Yes,
Yeah,
yes.
we are getting.
We can see.
Rider.
अपना केमिस्ट के पास जरा ठहरना कोई है तो इधर भी है
Buddy.
So Dr. Milind Kirtane sir has joined us.
Oh, welcome, sir.
थैंक यू
So I'm waiting for the rider to start. Just for a moment. Welcome, sir.
थैंक यू ड्रेसिंग के लिए समथिंग कॉल्ड टिंचर बेंजोइन डू यू हैव इट टिंचर बेंजोइन फॉर ड्रेसिंग
अभी चल रहा था.
So there's a question I'll ask till then, Professor Sachs. How many cases of nasopharyngeal angiofibroma have you seen in the girls?
Girls?
Yeah.
Zero. Zero.
Never seen, and for that matter, whatever tumors reported as angiofibroma in females, see, those are not true angiofibromas actually, because the histological architecture of tumors is like any other vascular tumor. Without knowing the details of the patient, they can be termed as angiofibroma sometimes by the pathologist. A true angiofibroma is never reported in the...
Yeah. I agree completely, Satish. I think that if you get a JNA report in a female, you've got to question your histology and your clinical diagnosis.
Yeah, that's what I'm saying. The reason is, most of the time it is similar in histology with any other vascular tumor.
Yep, you're right. Absolutely.
Yes,
angiofibroma, actually angiofibroma is not a histological diagnosis.
No, it's a clinical one.
Angiofibroma is a clinical diagnosis. Histologically, it is like any other vascular tumor.
Is it genetics or hormones responsible only it's for males?
Pardon?
Is it hormones or genetically it is decided that only males get NP, JNA.
There are so many theories,
Yeah.
See what I'm removing is the inferior meatus mucoperiosteum. Can you see?
Yes, yes.
Beauty of the cobbleter is you can do everything under vision, absolutely bloodless. I have not given to the tumor yet. See this, the turbinate.
Any comment on DPT, direct puncture therapeutic embolization for JNA?
Therapeutic?
Yeah.
Yes. Yeah. Sometimes in a, in revision situation, the fundamental, the principle behind that is that it blocks the vascularity of the tumor. So it may prevent the growth of the tumor as well. And that is something as a strategy sometimes used in inoperable situation or revision tumors. This is one of the strategy along with the radiation to embolize the tumor. Though we never do all this.
So you have removed totally the inferior turbinate for better one exposure.
Yes. This is for exposure.
Yeah. That's what I'm reading. So that see how much amount of space you got now.
Yeah, I have ample of space now. I have this part of the tumor in my exposure now. And whenever I see the tumor surface, I will keep on using the cobbleter all the time. See this?
Yes.
9.5. I will keep on using the cobbleter on the surface to devascularize and for the tumor shrinkage, all the time.
Yes.
Both
whatever tumor coming into my picture more and more, I will keep on doing surface coagulation more and more. Number one, it will reduce the vascularity. Number two, with my inadvertent touch of the instrument any point of time, it is not going to bleed. That is something very, very important. And see, this is just coagulation. I am not using ablation at all. Ablation is something which can take you through the tumor and then it can start bleeding. Then it is very, very difficult. In no circumstance of this tumor surgery, we are supposed to go through the tumor.
We can appreciate that white blanching. That means the vessels almost got coagulated. Right.
This is the turbinate, middle turbinate.
Middle turbinate.
This tumor has a propensity to take attachment to the turbinates and acquire vascularity. See, wherever it takes attachment on the periosteum, it takes the periosteal vessels as a vascularity. This tumor has a propensity to attach to the septum. See this here.
Yes.
I got a lot of stuff from...
See this? The nasal septum. A high propensity to get attached to the nasal septum, and see how I am devascularizing.
Yes, sir. Yes.
It is attached to the turbinate, which I am devascularizing.
Yes.
So whenever, whatever tumor portion you see, you can coagulate to devascularize it wherever you see the tumor.
Yes.
I hope it is very clear.
Yes, very clear.
Satish, after the using of coagulation, before coagulation, the JNA management would have been wonderfully easy and better.
A lot of people are using, bipolar and other things. This coagulation is something, is like a magic tool. See, only one hand I'm using this. I'm using this coagulation hand in one hand. It is a function of coagulation. It is a function of cutting. It is a function of irrigation all the time along with the suction. What all you need in a tool.
Yes.
That's why we call it as a magic wand. Professor Raman Sachs, are you using coagulation for other things in the nose or anywhere?
I love coablation, and certainly for tumors. For JNAs, I think it's an absolute must. For pyogenic granulomas, for plasmacytomas, and for skull base. I think coablation is really nice in skull base for coagulating the mucosa when you're going to drop the anterior fossa and then bipolaring the anterior ethmoid and posterior ethmoid artery. So I think coagulation is fabulous.
Yes. Even I have used intracranially many a times. Day before I was doing a craniofacial, I had to remove almost 10 by 10 centimeter of the frontal lobe of the brain and did with coagulation. Absolute bloodless, very safe. See, because of the irrigation all the time, it keeps the temperature cool and the overall collateral damage is minimum as compared to the cautery and other things. Now see, I am on the anterolateral wall. Can you see?
Yes, yes.
Yes, we can.
I have the lateral extension of the tumor. I showed you in the axial picture how lateral it is going.
Yes.
And this is how we need this anterolateral exposure. So this anterolateral exposure is again not hard and fast depending upon the need. My lateral limit here could be the infraorbital neurovascular bundle.
Yes.
Like in the last case, we didn't even go till that because our tumor was not going so laterally.
Yes.
Sometimes we have tumors going far laterally coming out of the zygoma. And then we really need a good lateral exposure. And what we do nowadays, we can remove the complete anterolateral and the posterolateral wall of the maxilla after transposing this, the infraorbital nerve. And that's a very simple technique proposed by Professor Paul Casanova. You can transpose the entire infraorbital nerve out of your field. And you can remove the entire anterolateral wall completely without damaging the nerve.
Satish, who is that person using retraction? What's that? That black one sheet?
Yeah, he's my assistant.
No. What is that instrument? Is just simple retractor or a cautery or a suction?
No. It is simple with a suction.
Suction.
Yeah. Cannulated suction. I mean insulated suction.
Just a Fraser sucker.
Yeah.
See now, I have this my pyriform aperture in view.
Yes, wonderful.
The thin bone I can remove with my lux forceps.
Yes.
Now here again I want to tell everyone where to enter into the maxilla. Why I was saying not to enter into the roof.
Yes.
That is very, very important because here one can enter into the orbit at the beginning of the procedure and that can be counterproductive.
Yes.
So what I want to show first, I will show you the reference of the upper limit.
Yes.
And see, I will go head on into the maxillary sinus to show this.
Okay.
See this? I am in the maxillary sinus anterolateral wall.
Yes.
At this point of time, see straight away I am entering into the maxillary sinus. I am in the sinus.
Can you exactly tell at what point you should do this step? I mean anatomically.
This is to show you where is my upper limit. Just to show you, demonstrate you.
Yes.
The neurovascular bundle is.
That is still far superior, Paramita.
See, this is the interior of the maxillary sinus.
Yes, very nicely seen.
Let me show you. Just a minute. That is the interior of the maxillary sinus. See that? And see the level of the roof above.
Yes.
It is quite high up. Why I want to go to the level of the roof? So that I can flush my nasolacrimal duct along with the roof.
Yes. You always stress that point. You have to go.
Yeah, that is important to prevent post-op epiphora.
It should never be hanging.
If your nasolacrimal duct is hanging,
yeah,
you are likely to give a permanent epiphora. Now see, after breaking this, I will remove this part of the bone to show you a much better picture drill of the interior of the maxillary sinus. Retract. Irrigation. See this?
Yes.
The tool what I am using is a 15-degree angled Medtronic stylus drill.
Why don't you use
something my drill for the skull base. Wherever in the skull base, in the depth, this is my drill. The beauty is your shaft doesn't come in the way. It has a natural 15-degree angle. See the posterior wall of the maxilla and the bulge? Madhu, what you were asking?
Yeah. That's what I was asking.
Miller sign.
Yes.
So, this is how my goal is to go to the posterior wall of the maxilla quickly. And that is my nasal.
Yes, clearly seen.
See it very nicely.
In this,
why can't we use a cutting burr in this area instead of that?
What?
Meditronics cutting burr.
Cutting burr is fast, you can use it,
Yes.
but then you're likely to give complication if it happens to touch here and there. And
Yeah,
for that matter, Madhu,
Yes.
we have a next case where I'm going to show you the draft with this same stylus.
Okay.
This stylus runs at a speed of 75,000 RPM.
Yeah.
This is not pure diamond. See, this is coarse diamond.
Yes, yes. Now we can appreciate. Yes.
In 10 minutes time, you can complete the ipsilateral draft too.
Yes.
Less than 10 minutes sometime. See, it cuts like butter section. See, it cuts like butter with full control. And being a diamond, it is quite safe.
What's the name of this? You just mentioned the name of this burr.
Stylus.
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 It's a Medtronic stylus. 15-degree diamond.
Yeah.
Yes. See, I am covering the tumor with this gauze piece, so my section doesn't puncture it. Okay?
See the amount of take-home messages. He's covering with a gauze piece so that even inadvertent some shaking, it should not damage the tumor.
Yes. Now see. Now
bulb
see
is-
my more and more maxilla. My goal is exposure. I will remove 360-degree all bones around the tumor.
Yes.
That I can deliver one piece. Sometime like last time I showed you, the plant division of the tumor as well.
Yes.
Sometimes you do a plant division after taking away the vascularity. That I can also show you today as well, as we have a good lateral extension also in this case. Now see, towards the floor. I will flush it with the floor of the nose. Yes. I will flush it with the floor of the nose all the way till the posterior wall. I have not done anything to the nasolacrimal yet, which I have left above, and I will show you what to do to prevent future problems of epiphora for sure.
I was fascinated by your measurement from the hard palate surface, 2.6 centimeters from the roof.
Yeah, that's what I'm going to show you, the artery, exactly at that level.
Yes, really interesting to know.
That is in my mind where to go to catch the artery.
Yes, yes, yes.
See, flush, flush, flush. See, the biggest advantage of this approach over the other approach is the post-operative follow-up. If you do by any other approach, which doesn't allow you to follow in the post-op,
yes,
that can never be a good approach, because after this approach, you saw the picture last time, after removal of the tumor. After removal of the tumor, you don't need to do radiology at any point of time,
Yes.
You put your 0 degree and everything is in front of you.
Yes, the whole world is in front of us.
So let me clean the field and show you. Yes, now give me debrider. I will further improve my exposure. See, this is all thick mucosa, a little bit.
Yes.
All these patients, we start antibiotic and steroids 5 days before the surgery at least, to improve the condition of the mucosa, because of this tumor, sometimes the sinuses are blocked, because the tumor being in the nose affecting the mucociliary clearance, and the mucosa many a times is, edematous, inflamed, fatigue. And for that, it is always better. Touch mat karo. So that improves the surgical field, because in endoscopy, the most important is the surgical field. See, this is the lateral part of the maxillary sinus.
Yeah.
Yes.
Now I have the control is in my hand, how far laterally I need to go according to the tumor. I can anytime extend my lateral exposure, anytime. I hope you are all oriented.
Yes.
Yeah, beautifully. Your exposure is
Thank you.
fantastic.
Now what I'm going to do to deal with this nasolacrimal duct, I'm using my punch. The most important thing to prevent epiphora, go right up to the orbital floor and then catch this duct.
Yes.
That is very, very important, not to allow this duct hanging down below the level of the orbital floor. Otherwise, this will result in stenosis and epiphora.
I should really appreciate, because I have observed more than 10 to 12 cases of JNA by Satish. He stressed this point, because though the surgery goes on very well, but that patient will lands in permanent epiphora. To prevent that, what Satish is saying, that go flush to the base of it and cover. Never it should happen.
See now, this duct is hanging down.
Yes.
I can catch any time, but this is not the time to catch this.
Yes.
You have to remove anything coming in the way, first of all. See, this is the anterolateral wall of the maxilla.
Yes.
What I am doing, I am cobbleting this wall to tighten this tissue, you know, so it doesn't fall in the way.
Yeah, very good.
Drill. Now I will open up this, drill. I will open up this duct further up till the floor of the maxilla.
See this step. The way that bony projection in front of nasolacrimal duct is first removed.
The beauty of this drill is, see, my shaft is not coming in the way.
Yes. 15 degrees angle and shaft is not coming in.
Yes, and you have a better control in this. This is like I'm holding like a pen, you know.
And your assistant, we should appreciate, constantly irrigating.
Irrigating and suctioning at the same time.
Yeah, great.
See, Madhu,
yes,
my assistants, both hands are busy.
Yeah.
My both hands are busy.
Yes.
My both legs, my foot are busy, you know. And one foot, I have a pedal of the cobblator, and in the other, the pedal of the microdebrider.
Satish, if you do not mind, there is a word in Mahabharata called Savyasachi. That means you can use 1,000 hands. You are Savyasachi in nasal field.
You know, I am breaking the posterior wall.
Yes.
So this only, see now, my duct is now standing in front of us. See now?
Yeah.
Yes. Very nice.
Now catch. Catch now, flush with the orbit. See this?
Yes. And you're also...
Yeah, that's it.
Yeah, beautiful. Now you can see the opening.
Now I will show you the opening of the duct. See, look now. Yes, wash. Yes, wash. Now see where the duct is, like me.
Yes.
See this? Can you see?
Beautiful demonstration.
That's it. Debrider. Now my orbital floor is very flushed. चला ना यार. Now I am taking away this part of the uncinate process. Now my goal is to go right to the posterior wall of the maxilla. Completely flushed. See this? I will remove everything here and remove the mucoperiosteum over the posterior wall of the maxilla as well. See this?
Yep.
Because that way I will uncover the anterior wall of the pterygopalatine fossa. See this? Can you see this?
Bone's going to be very thin.
This way I can uncover, see the bulging.
Yep.
This is everything coming in one piece. See this? Everything. This all has to go. See the posterior wall of the maxilla uncovered. See all mucoperiosteum removed.
The number you have dialed is currently busy. Please try later. आपके द्वारा डायल किया गया नंबर अभी व्यस्त है.
Can somebody switch off?
कुछ समय पश्चात प्रयास करें.
Dinesh ji.
Dinesh, Mr. Dinesh, I think the video is little jerky. I'm getting quite messages. Yeah.
See now what I'm doing? Removing rest of the part of the medial wall going till behind, flushing with the posterior wall, completely flushing with the posterior wall.
Yes, sir.
Now see, what is there at this medial end? At the posterior wall, the greater palatine canal.
And vessel. Yes.
You remember?
Yes, yes.
We have seen in the last case, we have seen in the cadaver,
Yes.
we have seen the flap based on the greater palatine
Yes.
in the cadaver.
Yes.
See this bone completely flushing to the posterior wall.
Yes.
Okay?
Yes, yes.
Now,
Beautiful.
since the tumor is bulging from behind,
Yes.
the tumor is bulging from behind,
Mm.
the wall has gone thin. The posterior wall is automatically become thin. See this?
Yes, yes.
Yep.
Because of the tumor bulge, right and left.
Almost
Now
as if
see how I can elevate this bone easily. Sometimes the bone is thick, then you have to use your drill to thin it out.
Yes.
And once it is thin, see this
Yes, sir. You're elevating the periosteum.
bone. The
No,
thin
that's the bone. That's the bone.
Okay.
That's actually the bone of the posterior maxillary wall.
Yes, sir.
Just very, very thin.
Okay.
It has become
Closing
thin.
the periosteum of the pterygopalatine fossa.
Forceps. It has become thinned out because of the pressure of the tumor coming from behind, you know. Now I am so happy a lot of people have started doing endoscopic angiofibroma.
Yes.
And this will be something to shatter their fear if the tumor is going into the skull base, into the 1 square inch area. No need to fight and follow the principles, and you can remove it. See, this all thinned out. I want more and more exposure. And here is the tumor which is ascending into the orbital fissure.
Yes. So, Doctor
Right.
Girish from Bhilai was asking, was there any visual complaints of this to this patient?
Not really. In spite of the ophthalmic veins engorgement, despite the slight proptosis, this patient doesn't have any visual complaint. Even on the visual examination is absolutely 6 by 6. See this entire bone I'm getting out. Satish sir.
Dr. Jain, you know, you're doing an unbelievable demonstration of the importance of exposure before you even start thinking about tumor resection. And I think the two important keynotes here is that it's exposure and then vascular control, and you're doing a tremendous demonstration. So I thank you very much.
And thank you. And see, sir, the beauty of cobbleter. All these periosteal vessels, see this, the cobbleter will take care of them. This is periosteum. All these vessels which were oozing, you know, now completely under control. So this cobbleter is a great tool. At no point of time I am going to use this cobbleter in the tumor unless I have to do a planned division. Otherwise, this is to be used on the surface only. Wash. Yes. Mop. Mop. See the posterior wall of the maxilla?
Yes.
Now, before going to the other areas, I will take the vessel into control first to devascularize my tumor to some extent, to major extent.
You had said the level was how many millimeters above the hard palate?
Pardon? How many?
You had said reference to the hard palate, the
1.6 centimeter.
1.6, yeah.
So I have a good idea that sometimes this vessel is quite low, pushed by the tumor. See, after this case is over, I'll show you certain examples where this vessel was certain areas that it is otherwise. Look at the CT angio, it is impossible to identify the vessel. CT angiogram gives you a great idea where the vessel is going from. See now. Yes. Hope the picture is good.
Yes, yes.
We can see the fat laterally.
Yes. Now see the fat
Yes, we can
popping
see
out. The fat is the sign of the lateral extent of the tumor. You know?
Yes, yes.
Now this is the periosteum of the pterygopalatine fossa. And we all know that vessel is in the anterior plane. You know? In the anterior plane, the most important thing is the fat and then the vessels. Very soon my vessel is going to come. I will tease out a little bit of the fat here. One minute. Yeah, give me divider. See, at this point of time, I would prefer to tease out little bit of the fat. At a very controlled speed, you know. Just to acquire more space, that's it. But you have to be careful not to take the vessel into it.
Debriding only that what has prolapsed into the side.
Yeah.
I have seen you using the coablator also at this point.
Now, give me the, you know. See now, this is the periosteum.
Right.
And I intend to go behind the periosteum. I can cut this periosteum with a coablator. I can cut sharp with the coablator as well. Yeah, you go.
Satish, are you able
See,
to
this is the infratemporal fossa. Yes, please.
Yeah, is fat always the lateral limit of the tumor? After that, there is
Yes,
not.
yes, because the tumor pushes the fat more and more laterally. Otherwise, this fat would have been here.
Fat, you are happy that we are having a cleavage.
Yeah, and this vessel is has a very, very tortuous course. Can you see the glimpse?
Yeah, yes.
I clear it more and more to show you, because this is very tortuous and it gives number of branches here. All branches in this region are coming from this vessel, number one. Number two, to all named foramens in this region, this vessel is giving branches. Like posteriorly, it is giving posterior superior alveolar nerve. In the greater palatine canal, it is giving greater palatine artery. In the median canal, it is giving median artery. In the pharyngeal canal, it is giving pharyngeal artery. And in the sphenopalatine, it continues as a sphenopalatine artery. In the infraorbital foramen, it gives as an infraorbital artery. So, this 1 minute of patience is very important. किसकी आवाज आ रही है?
Dinesh, please. Dinesh, we need to mute.
Yeah, wash. Yes. Now see, hello?
Yes, so we can see.
I'm in the infratemporal fossa.
Yes.
And my vessel, I'm going to catch here. Once I remove this, my vessel is quite high up.
Yes.
Reasonably high up in this patient, I have seen.
1.6 centimeters.
And it is quite a big vessel.
Yes.
Now, what you see here laterally, where I am seeing?
Yeah.
Can you see something laterally? Hello?
Yes, sir.
Yep.
What canal is this? This is the nerve. Superolaterally. See this?
Yep.
There's the nerve there.
Yes.
Can you see the nerve?
Yes, sir.
Yes,
This is the
beautifully.
continuation of the infraorbital nerve. Can you see that?
Yep.
Yes.
That is the limit here where you see the infratemporal fossa. Laterally in the infratemporal fossa, see the vertical fibers?
Yes.
Yep.
That is temporalis.
Yep.
To give you the lateral limit of the infratemporal fossa.
Okay.
And that is the lateral limit of the tumor as well. See this?
Yes.
And this is my vessel here more anteriorly. Right here. Can you see here?
Can see it beautifully.
See this vessel behind?
Yes, sir.
Later. Let me cut this tissue anteriorly to expose the vessel.
So is this a 0-degree scope that you're using?
All the time. See in the skull base, whatever you are doing, you have to use 0 degree. You retract. See, I don't want to damage the vessel. I'm just removing the tissue anterior to it.
Satish, apart from the radiological finding,
See my vessel. Yes.
can you give us some tips about identifying the intermaxillary artery?
Depending upon the tumor, how it compresses, boss. Depending. I will show you some example after this case on my laptop, how the variety of tumor situation extending into the intertemporal fossa. Can you see my vessel?
Yes.
Yes.
Right.
See how big it is?
Yes.
Can you see it very clear or not?
Yes, yes.
Beautifully,
Very clearly.
See, this is the level of the hard palate here.
Hmm.
And the vessel is quite up. I told you. See this vessel. And behind is the tumor. Can you see very clear or not?
Yes.
We can see it very clearly.
Yeah. Can you hold this, Pagar? And now the first thing what I am going to do is to use a clip on this vessel. There. So what I am going to use is my. अरे ये हटा ना बीच में क्या रखा? क्या करता है? I am going to use my clip over here. See this?
Yes, sir.
This is one. Record. One more. See my nerve above, vessel below, the infratemporal fossa laterally. Everything is in our view.
It's a beautiful dissection, Satish. Beautiful.
Thank you, sir. And this is remove. Now, let's see our clips are in proper place or not. See these two clips on the vessel. Now, what I will do, I will trace this vessel more medially. See the clips on the vessel?
Yep.
I told you this vessel has a huge tortuous course. And there are many branches. See this vessel, how big it is. I will use one more clip here. Looking at how big the vessel is, you know. Both the clips are looking good. Earlier clips. See this? Can you see the vessel again?
Yes, yes.
What I will do, yes, hold it. One more clip. रुक जा, पहले वो दे मेरे को, अब later.
So what is the size of this clip?
This is 200.
Okay.
There are a variety of sizes. So we have from 100 to 400.
So Dr. Mohan from Bangalore is asking how to avoid injury to nerves in the pterygopalatine fossa.
Yeah, now the nerve under vision. That's the best way. That's why I have kept.
Mm-hmm. Dr.
See,
Mudit Mishra.
one more on the vessel here.
Yes, yes.
Now I will sacrifice this vessel. See now. See now. The big vessel, everyone.
Yes.
Now I can coagulate this vessel like any other vessel. Hey, what happened? Lose connection. Some lose connection. भाग क्यों जाता है? What happened? Yeah. There's some loose connection. We are sorting out. Just a minute. We are not doing anything.
So till then you can tell us, Dr. Mudit Mishra is asking from Bareilly, what precautions will you take while coagulating the fat?
Paramita, can you repeat your question?
What precautions will you take while coagulating the fat? Like we have also seen you using a coagulator in that fat region. So what precaution will you take in that while coagulating the fat in the infratemporal fossa region for
You have to be careful not to take the vessel into it. You know, if like when I was doing debridement of the fat, if the vessel happens to come in the micro debrider, it's a disaster. Then you know how this vessel is going to bleed. This so big a vessel. Yeah. Come. Okay, the connection established.
Yes.
पतला ले चीज भर के चुका हूं मैं पतला ना पतला वाला See now, that was the vessel. I have already placed 3. Arey yaar, come on. Virender, ऑन कर ये सब काम पहले करने चाहिए ना Okay, are you getting the picture now?
Perfectly.
Yeah, sorry for the interruption, boss.
No problem.
Now see my vessel. I am coagulating this vessel now. As if it is nothing for me now. I am coagulating and now I am cutting it through. ये bone piece है. Can you see the vessel completely segregated?
Yes.
Can you see or not?
Yeah, we can see very clearly.
So now there is no vascularity from this vessel anymore medially. You can see very clear. See, this vessel is completely separated like this. See this?
Very nicely shown.
Completely segregated, and this leads to very good devascularization of this tumor. And see, here is the tumor behind. I need to separate from this tumor here. This infraorbital nerve. That's a very important nerve which we need to preserve all the time. Hold this tumor. See, this is the tumor.
Yeah.
And we'll just hold the tumor. Yes, and separate this nerve. This is a blunt instrument and it works well. Just a minute. This is important so you don't end up injuring the nerve at all. Yeah, hold this. It's difficult to have a catch-hold of the tumor at this point of time. See this now. Can you see this V2? See this V2?
Yep, there's V2.
Yeah, come later. So now this is on the tumor side. Since we went into the tumor here a little bit, so this little bit of the bleeding is expected here. See this? Gordon. Yes. And you can use a simple gauge piece here rather than fielding into it, just for a minute over here. Okay? So what we have achieved now, we have devascularized this tumor here from this vessel laterally. Okay? I hope it is very well clear to everyone.
Yeah.
See, this is the periosteum of the pterygobaltine fossa, which I am opening more and more. Now this tumor is here, ascending up here into the orbit. See from here.
Right. Yeah, you can see it clearly.
Yeah, Garrison. I will remove this part of the bone here to expose you the orbital floor. Once we have devascularized, this is major devascularization of this tumor. Okay. Now see how this tumor is going up from here. See this?
Yes.
This is the tumor which is growing up. See this?
Yep.
This portion what we saw on CT scan. And this is your, V2, which is going from here, and this is the tumor going up. So now give me the coagulator. See this? I can pull out this tumor from here. See this?
Yes.
So
delivering beautifully.
When we start delivering the tumor, we'll pull from here. This is where this tumor is ascending. And I'm just coagulating the surface. Just coagulating the surface, nothing else.
Satish, are you able to hear me?
Yes, sir.
At any time you had to sacrifice infraorbital nerve?
No way.
Yeah.
That is not our enemy, man.
Yes.
Infraorbital nerve is a useful nerve.
Yes.
See the tumor behind which is going up. See that?
Yes.
That is the surface of the tumor which I wanted to see here. All those tumors which have an additional vascularity from the internal carotid system, you have to be prepared to deal with that much of bleeding.
That is the fat that we see above is from the orbit?
Pardon? Yes.
The fat that we see above, is it?
Yeah, that is orbital.
Orbital
The moment I see the surface here, yes, I leave it because right now we are not going to disturb it. We have just exposed it.
Right.
Okay.
A bit surgicel.
Yeah, a little bit of the surgicel on the surface, and then is this gauge piece. Okay.
Yes.
Finally. So we have done devascularized from laterally. We have got the anterolateral exposure of the tumor. Okay.
Yes.
Now I will get more anterior exposure, superior exposure, medial exposure from everywhere. Oh, give me the coagulator. So first of all, I have to cut this middle turbinate over here to expose this tumor right into the ethmoids. And what I'm doing, a little bit of the surface decongestion so that my field remains good. See, this is the turbinate I am cutting.
Satish, do you ever use neurosurgical cottonoids to do blunt dissection, pushing the cottonoids between the fat plane and the tumor.
Yeah, we can use that, sir. That's a great idea. But since I'm using most of the time cobblator.
I see.
I'm not using that, but that's a great idea. That's a good idea to use neurosurgical cottonoids between the tumor and the surface. Wash. Now see what I have uncovered. This is the tumor. See this? Medially.
Yep.
Yes.
I have removed the turbinates from front. And now I will remove these anterethmoids, inferior part of the anterethmoids. And here my lateral limit would be lamina papracia. See? This is anterethmoidectomy, keeping the lamina as your lateral limit. See my lamina papracia very clear?
Yeah.
Very clearly.
This I can go fast. This is my lamina papracia all the way. See that? Straight. So I have defined here above laterally, this is the lamina papracia. Now I will remove the rest of this and go above and behind the tumor.
Yeah,
So
go above and behind the tumor.
Yes, in no time.
Yeah.
See this part of the
middle turbinate.
Yes. This tumor is a very vascular tumor, you know.
Yes.
As it has a good supply coming from the internal as well.
You are also mentioning the intraluminal tumor vessels were so prominent.
See now, I am in the post-ethmoids.
Yes.
Yes.
I'll show you the skull base. Everything I will remove from here. Show you the tumor three-dimensionally. This part you can do faster. Now see, Madhu, what you were asking about that anatomy in the sphenoid. That was a mucocele. See that?
Yeah, we can.
Very nicely.
Now this, I quickly removed all these ethmoidal cells. Section. All these ethmoidal cells. And see now, I am in the sphenoid sinus behind.
Yep.
And this tumor is limiting. See, this tumor is limiting here at the anterior wall. The 40 the drill. Everything between all these bones between the tumor has to go. See this? That's my medial wall of the orbit.
Yep.
All this bone, I should be able to see only tumor, nothing else, in continuity. 40 debrider. And see now I am going in the sphenoid for this mucosa. See the sphenoid from inside?
Yeah.
Wash.
Yes.
It does look like a bit of tumor going into the sphenoid, though. Inferiorly.
Yes, yeah.
That's tumor.
Yes, that's the tumor inferiorly. Yeah, this is at the opening of the sphenoid.
Yep.
So now, if I remove all these cells here, see this. See the result of the pack?
Yeah, super, very nice, very nice.
And see now, only what you see is the tumor, nothing else.
Yes.
Now, the more of the tumor is under exposure, more I will use the surface coagulator. See this, all tumor surface, it starts oozing. The moment you touch the tumor, see it is, what I will do, surface coagulation. This takes care of everything. See how effective it is.
And it shrinks it down very nicely.
Sir. See the tumor surface being coagulated. Now this bone piece anteriorly between the lateral and the medial part of the tumor here. See, no bone piece should be there. See this, how this tumor was going. This is the medial component.
Yeah.
And this is the lateral component and no intervening bone. Can you see?
Yes.
Yes.
This is the bottleneck.
Yes,
Right.
sir.
See, little bit of oozing from here. Let me press it. Just for a second, it will stop. Now what you can do, I have more exposure of the tumor anteriorly, above, anterolaterally, and behind as well.
Yes.
Superiorly and behind. Yet I have to go medial to the tumor and infero posteriorly. Then everything will be in my control. See this?
Yes, sir.
See now, there is no bleeding. It is behaving so well.
Yes, yes.
Very nice. Now,
really, the exposure is so widely.
Yeah.
The 0
For
degree.
this exposure, Madhu, you can remove any given extension of the tumor.
Yes, yes.
I will show you those difficult extensions today.
Yes.
With the same exposure. No bone piece should be left freely. It may poke into the tumor and start bleeding, you know.
Satish, can you use bipolar forceps at any time for coagulating the vessel?
Yeah, you can. But see, the problem with the bipolar, the difference between the bipolar and this coagulator is, it is constantly being irrigated. See this?
Yes, constantly being irrigated.
Now see this attachment to the septum I am taking off.
Yes, sir. Yes.
This is important because this sometimes drives the contralateral blood supply.
Yes.
Being a midline structure, very often it drives the contralateral blood supply.
Yes.
This some part of the tumor inferiorly to the floor prolapsing into the sinus. See this?
Yeah. What that was inside the sinus has come out.
Yeah. See this in the floor?
Yes.
So, just to show you, I am not removing it this point of time, but just to show you how this tumor was right at the anterior edge of the sinus. See now?
Yes.
I pulled it out at the anterior border of the sinus, anterior surface.
Right.
See this? Right on the anterior surface it is, here. So now I will push some gauge piece inside the sinus so this tumor doesn't fall back in the sinus.
So you are pushing into the sphenoid sinus?
Yes.
Yeah.
I pulled it out at the anterior border.
Yes.
And pushed some gauge piece inside the sinus. Okay.
And you also know that there is no tumor in the sphenoid sinus. It's only a edematous shadow.
Yes. So I can leave here some gauge piece here for the time being. I'm not starting removal at this point of time at all.
So there are a few questions on the coagulator itself. Many want to know again the settings that of the coagulator that you is there now for coagulating the vessel. Can you repeat so once again?
Yeah, I keep all the time on 9 and 5.
9 and 5.
Okay.
Maximum. This tumor is a vascular one. A cobbleter is to tackle the vascularity. Now, what else a situation you will get than this to control the vascularity? Now, I am coming medially. See now, I am doing a posterior septotomy at this level from the anterior border of the tumor. See this?
Yeah. So more exposure even to go to the from opposite side you want to.
Yeah. I will go to the opposite side. I will remove the contralateral blood supply coming from the opposite side, from the nasopharyngeal roof, if it is. Because that is a common attachment this tumor onto the nasopharyngeal roof. See this little bit of the oozing from the sphenoid component which I, touched. See that?
Yes.
What I will do here, surgical. See this, what I'll do simply, I don't want even this oozing. See that?
Yes. That is
I will use a surgical in the floor.
Hello?
Yes. And then pack with this.
Hello?
Yes, sir. Kitne sir?
Yes, sir. Here. See now? Now even there will be no oozing which was coming from here. Okay?
Satish.
Yes, please.
One precise max wand is sufficient, or sometimes we have to use two?
Mostly one is good enough. See, this is still working so well.
Yeah, that's what I am appreciating.
Hello? Yeah.
See, this is working so well.
Yes.
See now what I am doing? I am doing the posterior septotomy here.
Bol.
I am removing the ipsilateral mucoperiosteum. Then I will go to the opposite side. Section. See this?
Yes, sir.
Break the septum.
Yeah, very nice.
And go straight away to the opposite side to control the tumor from behind.
एक बेसिक हे पाठव प्रेझेंटेशन त्याच्यात तेवढ्या स्लाइड्स ब्लँक ठेव आणि तिकडे फक्त लिखी स्पीच क्लोज विल कम इन दिस स्लाइड असं लिहून ठेवायचं. वाटेल तेवढ्या चेंजेस शेवटच्या दिवसापर्यंत तू चेंजेस करू शकतेस, काही काळजी करू.
Kirtane sir.
प्रियंका ना काय नाव म्हटलं तुझं नाव?
Milan, can you mute your microphone?
We are there to help you.
Dinesh.
It is not some official thing.
Dinesh, please mute. Dr. Kirtane sir.
Whatever help you require, we are there. We have absolutely no tension.
Dinesh ji, can you mute?
Like your own family function.
बोलना क्यों पड़ता है यार?
आपलेच लोक आहेत. ओके. प्रियंका दांडेकर ना काय नाव म्हणायचं?
वॉश.
सेव्ह करून ठेव तुझं नाव. आणि बिलकुल टेन्शन घेऊ नकोस.
See now, I am going to the opposite side. I remove the bony septum a little bit. I hope you are oriented.
Yes, perfectly.
Yes, sir.
Yeah, now see the after removal of the bony septum.
Yep.
Now I will remove the opposite mucoperiosteum. See now very close is the inferior turbinate. See the posterior part of the turbinate is so close. And see now the opposite eustachian tube. Can you see?
Yes, we can.
हल्के हाथ से पकड़ो. So now I will improve this exposure. Block. Section. Go there, cobbleter. See now, in no time, this is the tumor. See this?
Yep, you can see it beautifully.
I am exposing more and more for the opposite side. tumor to be seen. See, now you can control the posterior part of the tumor from opposite side. Very clear?
Very, very clear.
And at this point of time, I will show you. See, this tumor has attachment only to the roof.
Yes, yes.
That is the mucoperiosteum of the sphenoid roof. See this?
Yeah, yep.
And what I'm doing is dividing the blood supply, if any, coming from opposite side. Let me clear for you much better. Let me remove this bone to show you better. This tumor never takes an attachment on the adenoid surface, for that matter. Never.
Is rostrum.
Is the reason?
Yeah,
Satish?
that's a part of the rostrum.
Satish?
Yes, please.
Why it doesn't take any vascularity from adenoids, anything like that? Mucosa is separate.
That is its characteristic. See, certain area it never comes in contact, never takes an attachment. One is the adenoid surface.
Yes.
Another is, the nasal floor.
Okay.
Even in the sphenoid inside, it doesn't take any attachment to the mucosa.
This is classical example. Here it is totally not taken. But it can take from septum.
Yes, septum, very common attachment. Almost always. Septum and turbinate problem. Septum and turbinate always.
Always, okay.
Now see, this mucoperiosteum I am removing. See, completely segregating from the opposite side.
Yes.
By means of cutting away this periosteum completely, like a vertical line. See this?
Yes.
Just to take out the opposite blood supply. See now, the vertical line. Onto the periosteum. See, bone deep.
Right.
Oh, there is no blood supply now coming from opposite side.
Yep. You are already blocked from opposite side. Yes.
Yes, that is important. See, I told you, we have to do all possible things to cut off the blood supply before we deliver this tumor. Okay?
Yes, sir.
Now, this tumor we have exposed from medially, from posterior medially and posterior inferiorly as well. See that?
Yes.
Posterior superiorly and posterior inferiorly.
Yes.
Very clear?
Yes, sir.
Very clear.
Now, once it comes to removal of this tumor, what I will do for simplifying the things for everyone, I will divide it. A planned division. Since I have already taken this vessel in control,
yes,
so I can afford to do a planned division. Why planned division? Then what I will do, see this, what I will divide the opposite blood supply. Just to leave a gauge piece there. Okay? Gauge piece. Gauge piece. See the panoramic view.
Yeah, sir. It's super view. Satish, just to mention, 3 decades back, I remember transpalatal surgeons used to put their index finger and just bluntly dissecting out and removing the amount of bleeding.
Yes, exactly.
Post-operative period, sir.
Yeah.
The amount of simplicity now.
Yeah, now see the visualization, man.
The open book view you are having.
See now what I am doing? This is the fissure which is widened by the tumor. The inferior orbital fissure. I am inferior to the orbit.
Yes, sir.
This continues behind to the superior orbital fissure. I will show you. See, this is sphenoid.
Yes.
That is sella.
Right.
See that?
Yes, sir.
Inferior to the sella, here is the superior orbital fissure.
Yes.
See, let me open up the superior orbital fissure. See the tumor.
Yes.
This is all tumor inside the orbital fissure here.
Yes, sir. So this is the 1 square inch area that we are almost reaching.
Pardon?
So this is a 1 square inch area that we are almost reaching.
Much above.
Much above. Okay.
Yeah. So this is just to show you landmarks.
Okay.
Sir, can you just point out the landmarks for orientation?
Okay, let me. This is the medianoid. You see the sella there?
Ah, yes, yes.
Yes, sir.
Lateral to the sella is the paracellar area where the anterior band of the carotid is.
Yes.
And just anterior to that
Yes.
is the superior orbital fissure.
Supraorbital fissure.
This is superior orbital fissure. Above is the optic canal. Optic canal is above. Superior orbital fissure is below. And they are separated by a bone known as optic strut.
Optic strut.
Okay.
And the maxillary strut, sir, where the maxillary strut is already out.
So I will follow this tumor. See here. From here, behind is the carotid there. This tumor is entering into the superior orbital fissure here. See, that's the periosteum.
Okay.
Which was oozing. I will remove this bone, medial bone completely to enter into the superior orbital fissure and then go into the cavernous sinus.
Okay.
Now, why not to do that small part with ease? With ease after removal of the rest of this part so that we can have ample of space. See this?
Yes.
This space is unnecessarily occupied by this huge tumor.
Yes.
So what I believe is in? What I believe in is?
So bisecting and making more
Plant
space.
division. Plant division.
Plant division. Plant division. Yes.
See, I will divide this tumor here at the medial end of the maxilla and remove this nasal, nasopharyngeal, all these medial component. Why?
Yes.
Then I will have ample of space to accommodate my lateral tumor.
Yes.
Ample of space for the instrumentation. Got my point? And
Yes,
you know,
sir.
this removal of this division of the tumor is like cutting the cake.
Yes.
See this?
Yes.
I showed you last time as well.
Yes.
Is Professor Ramansek there?
Yes, absolutely.
Sir, I am dividing
fascinated.
this. I am dividing this.
You are using coagulation mode.
See my posterior limit, this is the entry wall of the
Yep.
sphenoid. Can you see, sir?
Yes.
Yes.
Yep, I can. Satish, you know, I published years ago on using that for traction so that my system
Is free?
Yes.
Completely free or not?
Yes, sir.
completely.
That is completely free. Give me a gauge piece. See, with minimal oozing, this tumor is the medial component is absolutely free. Now, see how much ease we will have in the removal of the lateral component. See, this entire medial area is opened up for our instrumentation. Hata do. Wash. Give me a good wash to orient. See now? Now, since we have segregated the tumor, I will remove this part of the tumor through the oral cavity. Like, see now the medial part is out.
Yes, yes, yes. Very nice, very nice.
And now, last 10 minutes for the rest of the work. See this, no bleeding.
Yes.
Let me open the mouth. Let me remove the medial part. So the beauty of division, it's always a planned one. I could remove in one piece as well. That makes your life so easy. I have now ample of space for instrumentation. See this part of the tumor out?
Yeah.
See this component of the
Beautifully
tumor. Section. And now see the amount of space we have got. This is our Eustachian tube below. See that?
Yes.
Nothing to do with that.
Clearly.
Cobblator. Now I will coblate this mucoperiosteum for the little bit of the oozing there. See this? I will take away this little bit of the mucoperiosteum from here.
Satish,
Yeah, yes.
since how many years you are using coagulation for JNA very so widely?
It's been more than 5 years now.
5 years, okay. Before that, you are using like unipolar and bipolar cartridge.
Bipolar, unipolar.
Yeah.
So many
But
different things.
I think earth to sky difference you have experienced after coblation.
Yeah, coblation has tremendously changed the game.
Yes.
See now, everything clear in the midline.
Yes.
Okay.
Super.
Now, the goal is the lateral component. What I will do, I will drill a little bit of the bone to expose this component more. See the coblation, everywhere there is bleeding, you can stop in a minute like magic, you know.
Yes.
So far, the picture is good. I hope you are oriented.
Yes.
Now
Beautiful.
Now see where I am going. This is the superior orbital fissure medial wall. See the medial wall of the superior orbital fissure.
Yes, sir.
And above is the optic canal.
Above is the optic canal. Yes.
Yeah. Yes.
And behind is the carotid.
Yes, sir.
Suction girl.
Under classification, it comes under type 2, Satish.
Oh my God, such a difficult question.
No, I will not disturb. We will discuss later. I will not disturb.
There are more than 100 classification systems.
Okay, right. We will leave it now. I will not.
So what about the maxillary strut?
No, the maxillary strut is below. I remove the medial wall of the superior orbital fissure.
Superior orbital fissure.
I will show you the maxillary strut. This is below here.
Okay, yes, sir.
And how will you define that? I will show my V2 is going to go in the foramen rotundum.
Yes, sir.
And the bone above the foramen rotundum separating from the superior orbital fissure here. That is maxillary strut. Okay?
Yes, sir.
Now see this bone. I have already removed. This is superior orbital fissure. This is sella, and here going to be the parasellar carotid.
Can you point the inferior orbital fissure?
Inferior orbital fissure is here where.
Yes.
See this? From inferior to superior to the cavernous.
Yeah,
This is how the tumor is extending. And now finally I am going to start delivering this tumor soon. Ramita, any question?
Yes, sir.
There is the periosteum.
See this tumor, this bleeding from this space is mainly from the internal system. Hello?
Yeah. This is from internal carotid system.
Yeah, a lot of venous bleeding in this region, you know, you will find. That even your embolization is not going to take care of. Now see how will it's a matter of traction and counter traction now. See this tumor. This tumor proper, huh? Can you see?
Yes, sir.
Now I am separating. This is tumor proper. No, ये नहीं पकड़ रही. साफ कर. The forceps is not catching. Give me gauze piece. Suction. I will just start delivering the tumor. In no time now it will be. See this tumor surface where I placed my surgicel, it was oozing here.
Satish, you are mentioning there is a vessel posterior to the tumor itself in the radiology.
That the vessel is mostly ascending pharyngeal.
Yeah, that's what, because. Okay. What is this instrument you are using now?
No, the simple. I want to have a catch hold of this tumor, you know.
Okay, right.
Yes, now. Poblator. See this section. Traction and counter traction. See my V2?
Yeah, we are clearly seeing the V2. Will there be any thermal injury?
No, I am away.
Away, much away. Okay.
Number one, I am away. Number two,
Constant irrigation.
yeah, constant irrigation, man.
Yes.
So what if there is some thermal injury to V2 then?
V2 injury, you can't do anything. Gone. See this how intimately it is related to tumor.
Yes, I'm going through the tumor.
The tumor is so crumbled, you know.
Is the nerve being encircled all around by the tumor?
No, it is. It runs on the surface, you know.
Okay, surface. Okay.
It will. Don't worry. Sometimes you have to struggle like this to separate this vessel, you know. My forceps is not having a good catch hold. That's what I'm looking for. Section. No.
I think a bit bigger forceps.
Will take. Give me a good forceps. Good forceps. Yes. See this. What I'm see here, the traction and counter traction is very important.
Oh, that is the surface of the tumor.
This is all lateral component of the tumor. You can see.
Yes.
This is my vessel where I divided.
Yes.
Right. This is where, Satish, I would tend to put neurosurgical paddies and put multiple paddies in to actually push it away.
In the plane.
In the plane.
Yes, I got it.
Satish usually use Merocel. So for like what neuropathies Sir Raymond's is stressing?
Merocel is too soft.
Too soft.
Yeah. Very nice.
See what I'm doing. Process. I should not have this. Just a minute. Wash. What I am trying to separate is the vessel. See, this is right adherent on the anterior wall of the tumor. I'm leaving it pushed laterally. See, that's the lateral component.
Yes. There's a good cleavage seen clearly.
Yeah, what I'm doing is pulling. तो लंबी थी ना मोटी. See, sometimes you need to have a good forceps, which what I'm struggling is the catch hold, you know. See this now.
Yes.
It should have come earlier. The more the time you spend, more is the unnecessarily oozing.
Can you put a gauze piece there and as a spacer?
Gauge piece. Yes, you're right. I can push like Professor Raymond Singh is saying.
Yes, yeah.
In the
so
plane.
that there will be some cleavage in that area.
Yes.
And
see now?
That will prevent the tumor also falling back.
Yes.
Wow, very nice.
See?
Yes.
Very nice.
Separated.
That's exactly what I was saying, Satish.
Yes, sir. Raymond's, your idea was that correct and that followed.
Yeah.
Just like.
See this tumor?
Yes.
And now the final component. See, faster you see this. See the V2.
Yes.
That is V2.
Going down.
Yes, sir.
It's coming away.
The V2 is going up there. Here.
Yes, sir.
Here is the V2. See this section?
Yes.
Yes, sir.
Very nice. Yes.
Yes.
See that?
Yes.
Yes.
Beautifully seen.
Yeah. Here, foramen rotundum.
And that is the tumor. Now,
Sir, Dr. M.V. Appara is asking, can it be a V2 short number?
No way. Come on.
No.
Now see, I want to show you something very interesting here. The last part, which I am going to pull out. Wash. Give me a good wash. I want to show something. Wash. Yeah. Good wash. Now. Good pack. 1 or 2 packs. See now, this entire pack I have removed. This part of the tumor has been removed from laterally.
Yes. Nasal, nasopharyngeal, lateral.
This lateral component.
Yes.
I have removed and I have packed with the gauge piece here. Okay?
Yes.
Just to keep our field good.
Yes.
I hope this is okay.
Yeah.
Beautiful.
Now, this is our V2. See this.
Yes.
See this V2? This is the V2. This is your foramen rotundum. See this.
Yes, sir.
Yes.
And this is maxillary strut. Can you see this?
Yes, sir.
Very clear. The bone above the foramen rotundum.
Yes, sir.
This is foramen rotundum. This is maxillary strut, and see where the tumor is going.
Superior.
It's about going.
Yes, sir.
Now give me the coagulator first. See the superior orbital fissure?
Yes, sir.
Going through the superior orbital fissure.
That is the value of anatomy we saw in the cadaver.
Yes.
Yes, sir. The 1 square inch area.
Yes. See this? I am just pushing this orbital fat up.
Yes, sir.
So now the things are very. See now. This is your foramen rotundum. See here.
Yes.
This is your superior orbital fissure.
Yes.
And now this is your tumor. Now in order to pull this tumor, I will remove some more bone. See, this is getting vascularity from the internal carotid. So don't waste time into vascularity. This is not going to come under control by any means. We have to get fast. See, this is, I am opening the medial periosteum of the superior orbital fissure. See this?
Yes.
And immediately behind. See, this is sella.
Right. Okay.
Immediately there is the carotid behind. See this?
Yep.
Yes.
See the sella, the paracellular carotid area.
Yes.
Doppler
You are
ready.
sending fluid with the Doppler.
Keep the Doppler ready. Now see, I am catching up this tumor. See this tumor?
Yes.
Suction. Cut. You put it. Give me the coagulator. See, let me show you. This is how the superior orbital fissure and the cavernous sinus are in continuity.
Yes, sir. So there's a porous bone that you had said during the dissection. Near the paracellular carotid, you said that there's a porous bone there during the dissection you had mentioned.
What?
Porous bone.
See now, this is the tumor. See this tumor, I am bringing it out.
Yeah.
Yes.
Yep, beautifully.
Not holding. See now. This is the cavernous sinus. See where my tumor is coming from. See my tumor.
Yes.
See this tumor?
Yes.
Yep,
Yes.
clearly.
This big component coming from cavernous
Cavernous
sinus.
sinus.
Yes.
Beautiful.
Beautiful.
This little bit of the oozing of the cavernous sinus you don't mind. Now see, show. See, this is the cavernous sinus proper. Can you see?
Yes, we can see
And the
beautifully
tumor
there.
I have pulled out from there. Now let me show you the. No. I never pack the venous bleeding immediately coming out of here because. No. First, give me the coagulator. The reason is if I pack this, I may push the tumor if it is there inside. What my point? No. Sorry.
But I think you're free of tumor there now, Satish.
Pardon?
I think you're free of tumor there now.
This, I'm afraid, could be a 6 now.
That's what
I think
the cavernous sinus nerve looks like a nerve.
May not be. Give me the Doppler.
I think you have removed all the tumors, Satish.
Yeah, tumor is out.
Tumor is out
in single go.
Yeah. And cavernous sinus is all boundaries are very in front of you.
Give me the drill here for a while. See, the bleeding is automatically stopping.
Yes.
So this is a very important point, not to pack the cavernous sinus area immediately. People with the fear of bleeding, the moment they open the cavernous sinus, they try to pack it first. See that? Why I am saying so? The reason is, if you pack the sinus, if there is even a small amount of the tumor, if you are not confirmed.
Okay, it will get compressed or go inside.
Yeah, I am just removing this bone over the. See, this is over the paracellular carotid. My drill is right on the paracellular carotid. Huh?
Yep.
Pani.
Our heart rate is increasing, but you are really looking very stable.
I think that's the 6th nerve just lateral to you, Satish.
Yeah.
Hey.
I am afraid this could be now. I am not sure. But this is too anterior. So I should not be a nerve. Give me just a little bit of the surgical.
No, but that glistening neural sheath looks like that.
Yeah, that's what I was once suspected. Just a minute. See how the entire area is up.
Yes.
It's really nice.
See the entire area which is opened up?
Yeah.
Yep.
All.
That's the carotid. See behind up.
Yes. Yeah, there's the carotid.
Can you see the carotid up?
Yes, you can see the carotid beautifully.
Beautifully. Give me the Doppler. Section. Section कर. Section उठा वहां से. See, don't have to worry about cavernous sinus bleeding. It stops.
Yes.
छोड़ो. This looks like some nerve. I'm not sure. Yeah. कर इसके नीचे कर. Can you see the area completely clear?
Yeah, very clear, Satish, very clear.
Make sure the Doppler is working, because obviously the carotid.
Hear the pulsation of the carotid.
Yes.
Can you hear?
Yeah, we are able to
can hear it clearly.
Now the mic is close to my mic.
No, we are able to hear, no problem.
Clear cut arterial pulsations, can you hear?
Yes, we can.
Yes, we can hear.
So clear.
Now,
what I am trying to see, section.
So what about the third, fourth cranial nerve?
Pardon?
What about the third and the fourth cranial nerve?
I was afraid of the sixth one. I was afraid of the sixth one earlier. Straight में पानी लगा के दे. Let's see. But the sixth is the medial most. That's why.
Medial most and the longest, and it looks like so.
And the sixth is the only one which passes truly through the sinus medially.
Yes.
Rest are in the lateral wall. Now, I will show you the clear picture now. See now. Section. See the cavernous sinus. Those who have a fear of cavernous sinus bleeding, see this?
Yeah,
I don't have to do anything.
But that looks like a nerve only, Satish.
Yeah, they see it is so medial.
If
it is a nerve, it should be the sixth one. If it is.
But it's intact, nothing to worry at all.
A little bit of the traction inverted the eye, but I don't know. See now, let me clear you. See, there is hardly any bleeding.
Yes, hardly any bleeding.
I told you last time, cavernous sinus bleeding, you don't need to worry. The tumor itself takes care of it. Now see the anatomy.
Yes.
This is your V2. See this?
Yes, V2.
This is foramen rotundum.
Yes, foramen rotundum.
Maxillary start.
Yes,
this is superior orbital fissure. This anterior part is small. Superior orbital fissure is just an opening.
Yes.
From cavernous sinus to the orbit. And see here in the lateral wall, this is periosteum, and there runs all the cranial nerves.
Okay.
Yes, sir.
I mean, your 3, 4 will run on that wall.
All other cranial nerves. This is the meningeal layer of the
cavernous sinus,
lateral wall of the cavernous sinus. All the cranial nerves. You can see the glimpse of the cranial nerve now.
Yeah, yes.
Yes, sir.
Yes. There are two strands like
in the lateral wall. Professor,
yes,
can you see the cranial nerves in the lateral wall?
Yeah, I can see them very, very clearly.
Very clear.
So if it is a cranial nerve, if this medial one, this is too medial, if it is, it should be abducent. I am not sure. Still I am not sure. It is too medial.
Yep.
Now give me a small gauge. See, the tumor is out, otherwise it would not stop bleeding.
Yes.
See that?
Yes.
Yes,
and it came gently by pulling and pulling only. So last time I told you, once you do Denkers, it will take extra 10 minutes to remove tumor from anywhere else. And that is what exactly happened. It took us just 10 minutes extra.
Satish, can you orient us with where is the obedient canal?
Yes, everything. Wash. Just wash. Now my job is to orient only. Nothing is required to be done. I will remove all packs, clean the field, clean all the field, suction, motor lele. See, we'll take care of this small oozer also now. The bottom line is, I never advocate, packing the cavernous sinus or the pterygoid region as you remove the tumor. Because the tumor which is going into the cancellous bones can be pushed inside. So let it come. Let the bleeding come, and you can see that. Cobblator. See now, we'll check each and every area. There's a small oozer in the infratemporal fossa. See that? See the infratemporal fossa. See this is the pterygoid plexus.
Yep.
Yes, sir.
See the venous plexus?
Yes, sir.
There are various parts of the pterygoid plexus. This is between in the lateral pterygoid. Another one is deep one. See this venous bleeding?
Yes, sir.
And no embolization ever will have any role on this.
Yes.
Give me a surgical. Let me tell you the final answer to this bleeding. There is no point in fiddling into it. Suction. See this venous bleeding? The final answer to this venous bleeding in no time is surgical. See this. In 1 minute's time, it will stop. That's it. See my muscles all around.
Yes.
See this horizontal muscle is lateral pterygoid. See this, Daba.
Yep.
Can
Satish, do you ever use?
Pardon?
Yep. I say, do you ever use any thrombin materials like Flow Seal or Surgery Flow?
In case required, you can. I have. I always keep them ready. In case needed, I can use Surgery Flow. Khola hua hai? Let me show.
Yeah, because I find it very useful for those venous bleeding.
Give me Surgery Flow. Let me tell you what it is, what Professor Sachs is saying. This is Surgery Flow. Can you see?
Surgery Flow. Yes, we are able to see.
See, there are 2 syringes here to mix them again and again, 3-4 times. And this material you just pour inside and pack with a gauze piece for a while, or less than a minute, and it settles down and take care of the bleeding. See now the anatomy I was showing here. This vertical muscle is the temporalis. See this?
Yes, sir.
And going here below is the coronoid process. I mentioned in the facial, I broken the pterygoid below in the facial nerve course on the cadaver. And this one is the horizontal, is the lateral pterygoid. See this?
That is lateral pterygoid.
Yeah, this is lateral pterygoid. This is pterygoid process. This is lateral plate from where the lateral pterygoid is emerging. This is medial plate. In between is the pterygoid fossa where the medial pterygoid is arising. Okay. So this is how you can control this easily. Okay. Now for the surface of the nasopharynx, see, I didn't even bother to do anything here. On this surface I will use the cobblator. That's it. See this. This bleeding will come in control. Thoda surgical or dena hai. Little bit more surgical. This is how you can easily control. Yes.
So you will show us the pterygoid canal, the Vidian canal?
Vidian canal is gone. I will show you the area. If it is, otherwise I will drill it. That is one of the commonest sites of a residual tumor. Now see, I am removing from here. Now see the orientation.
Yeah.
In the midline, in the coina where I have put my pack, see no bleeding?
Yes, absolutely no bleeding.
Without any pack?
Yes.
So this was done without embolization. See this?
Yes.
We have not transfused as well.
Yes.
Yeah. See now, let me clean this field. इसको दबा के रख दूँ. See, this is midline. Anybody has any doubts at this point of time?
Looks beautiful.
Yes.
That is anytime malignant transformation of JNA is noted in the literature.
What?
Malignant transformation in JNA.
Yes, we have seen even in one case.
Yeah.
Sarcoma.
Ah.
Yeah. That was a 25-year-old patient. Was already operated 3 times.
Okay, for the same.
Yeah.
Okay.
After 3 surgeries, that patient came to us, and that was a huge component. You know, it was going in the middle cranial fossa everywhere.
Okay.
Since it was a proven case, it was going in the temporal lobe, so we did a combined approach with a subtemporal approach.
Okay.
We could remove completely, and it turned out to be a sarcoma.
Sarcoma. Very rare to even hear about.
The same radiology, same everything, 3 histopathologies of angiofibroma. See now the midline is clear. See now the adenoid surface.
Yes.
Always clear. It is the roof in the periosteum where it takes attachment. It doesn't take attachment on the nasal floor. See, doesn't take attachment on the adenoid surface. Doesn't take attachment in the sphenoid mucosa. See this.
Yes,
Anywhere.
Satish, Satish, exactly where your suction is now.
Yeah.
Somebody was asking where the Vidian canal is.
Yes, this is pterygoid canal. This is pterygoid canal.
That's exactly where it is.
Yeah, and see,
And
this
it's very consistent.
This is the cavernous sinus and the superior orbital fissure. See now, this clear field without bleeding is the evidence that there is no tumor behind.
Yes.
Yes, sir.
Professor Sachs, do you agree with me?
I agree 100%. And I'm saying you can see with that view, you can see the V2 beautifully just at 3 o'clock on your...
What is that white structure, Satish?
Pardon?
On the lateral wall of the cavernous sinus.
Yeah, that is the nerve. There are 4 nerves you will find in order.
Yes.
The third above, then the fourth, then the six medially, the 6 medially and the V1 laterally. And there are 2 veins, the superior and inferior ophthalmic veins, superior above and the inferior most below. So like if I drill this, maxillary strut, if I drill away this maxillary strut and go in the superior orbital fissure here behind the periosteum here, the first, see the periosteum. See what are the layers here? This is the meningeal layer of the periosteum, then are the cranial nerves, and lateral to that is the periosteum layer, and lateral to that is the temporal lobe of the brain. Now if I drill this pterygoid over here, just above the V2, see this? This V2, this is the anteromedial triangle. What is anteromedial triangle? This is the V1 going here into the superior orbital fissure, okay? And the V2 coming out of the foramen rotundum and in between this bone. If I drill away this bone, I will be right in the temporal lobe. Majority of the angiofibroma, JNAs ascending to the temporal lobe are through this region.
So between V1 and V2.
Then between V1 and V2 is the anteromedial triangle, and then there is
between V2
and V3.
V3 there is the anterolateral triangle.
Lateral triangle, yes.
These are the 2 triangles which gives avenues for the JNA to ascend in the temporal lobe. Okay? If I drill this thin bone, right, I will be on the temporal lobe dura.
Yes, sir.
And that is how these tumors ascend in the temporal lobe. So see, this nerve is passing truly through the cavernous sinus. The sheath is eroded a bit, and this should be abducent. The rest 3 nerves.
The lacrimal nerve, the frontal nerve, and the nasociliary nerve will also be?
No, the frontal and nasociliary are the branches of V1.
Yes.
I tell you again. This V1 as it enters the superior orbital fissure here, the V1, it divided into branches. The 2 branches go outside the tendon. There is a common annular tendon here. The 2 branches, the frontal and the lacrimal, they go outside and run on the roof of the orbit. The lacrimal towards the lacrimal gland and the frontal towards the dividing finally into supraorbital and supratracheal. Okay? Then the second branch, the very important sensory branch, nasociliary, it passes through the annular tendon. Here is the annular tendon. It passes through the annular tendon and then it divides into many branches, more importantly anterior and posterior ethmoidal nerves and a sensory branch to the ciliary ganglion. Okay? See, this is the cavernous sinus, so open, so clean, and here behind is the carotid artery, and this was the periosteum which is separating it from the carotid. Okay? I hope it is clear.
Beautiful.
Yes, sir. It's clear.
Usually such an exposure, can we appreciate any pulsation or no?
Yes, pulsations you can. I will show you. I saw that.
So, sir, there are a few questions on this, that removal of pterygoid wedge, whether it is necessary. Removal of the pterygoid wedge, whether it is necessary in every case. I mean,
Yes.
in this.
Yes, because you never know if there is a involvement of the pterygoid process with the tumor, unless you are very sure about it. Let me do what Professor Sachs was saying about the pterygoid canal. That's a very common infiltration. You cannot overlook. Give me the drill. This pterygoid canal is, to me, is one of the best landmark for the foramen lacerum carotid.
That's correct.
See now what I am doing. This tumor has a propensity to invade the pterygoid canal. See, the bone looks good. See, the pterygoid bone looks good.
Yes.
You saw the pterygoid process last time, how it was involved with the tumor.
Yes.
Which is not in this case. Can you see very clear?
Yes, yes.
Yes, yes. In the last case, we remember.
Yeah, see, no tumor at all in this. This is पानी डालना है, वहाँ पे डाल यार. वहाँ रख. वहाँ चाहिए मुझे exactly. And see this tumor, I will drill away this pterygoid canal completely. In cases of tumor, and you have to identify the foramen lacerum carotid, this is the landmark.
Okay, okay, okay.
वहाँ डाल खाली.
And the Viridian canal is a very consistent at the junction of the floor of the sphenoid and the medial pterygoid plate. You can see that very nicely there.
Cobbleter. Now see, I will show you the canal properly. I will show you the canal here.
Canals there is nicely seen. There's the canal.
Here. See this?
We're on the canal now.
Here is the canal.
Here's the canal.
But you have to ensure that your pterygoid is free of.
So what is the limit of the drilling?
Limit of the drill.
Until
you find the normal bone. Until you find the normal bone. वो दे मोटी वाली bone. I will use a different burr here. There is some oozer here. We have not controlled yet. Yes, give me the cobbleter. Here. Cobbleter. See some oozer in the lateral wall?
Yes, yes.
Section लगा. Yes. Section लगा. See this?
Yes.
At this point, I can see.
Madam?
Done? See now, no more? See this? This area was unnecessarily giving a small oozing. And now see what I am using. I am using my different. This is pure diamond. Now it is not coarse diamond, and that too I will use without irrigation. See this. Come dal. Come dal pani.
So, though you've answered this question, again, there are doubts on this, that they're asking irrigation is with warm saline or ringer lactate.
Yeah, here in the bone it is warm saline.
Okay.
See this is pterygoid canal. Pandal
Yes,
बीच
sir.
में डालना.
Yeah.
And I am using this burr without irrigation in between. See, to drill away this pterygoid bone until I find the normal bone. That's a very important part of the surgery. See this pterygoid? See the video now?
Yes, yes, clearly seen, sir.
Very clear or not?
Yes, yes.
Satish, one simple question, Satish. Hello?
Yes, see the pterygoid now completely coagulated.
Wow.
Now, is there any question of pterygoid canal involvement?
No. Sir, is this drilling necessary in this particular case, or because we have asked you are doing, Satish?
No, it is always better to do.
Yes.
Because these are the common sites of,
Recurrence.
Yeah, leaving the tumor behind. It is never recurrence. It is the residual tumor which regrows.
Okay, right.
So you have always said
Now
that there are...
complete radical clearance from the Ravidian canal.
Yes,
Yes.
sir.
So you've always said us that there are 3 foramen in the pterygoid process. So foramen rotundum, V2 you have shown.
This was the median canal.
Medial. Now
This
the
is at the junction
palatovaginal.
of the medial pterygoid plate with the floor. Okay?
Yes, sir.
The body of the sphenoid. One
sir.
medial foramen here. Idhar kar. One medial foramen here. See carefully.
Pharyngeal nerve.
Yeah. See the one medial foramen here, which I have already drilled, is the palatovaginal canal between this palatine process of the bone and the vaginal process of the medial pterygoid plate, which is the part of the sphenoid. That's why the palatosphenoidal canal also it is named as.
Yes, sir. Yes, sir.
See now, this is the complete, I would say, panoramic picture straight laga. Anybody has any questions?
Satish, finally, just take a ballpoint and show all the anatomical landmarks, superior, inferior, lateral, medial, because it's so beautiful exposition.
Yes, very
beautiful. The key is the
exposure.
dankers. After the primary danker, whatever extension you have, you can remove in 10 minutes additionally.
Yes.
Okay, let me pakadna section. So coming from the anterior to posterior.
Yes.
This is the, just a minute. See, this is the anterolateral wall of the maxilla. Can you see?
Yes.
Yes, sir.
And this is the floor of the maxilla flush with the floor of the nose.
Yes.
That is the maxillary sinus. This medial part, medial to my periosteum, between this and the medial wall, this is the area behind which is the pterygopalatine fossa. That's a very small area.
Nasolacrimal duct?
Yeah, that is here. Sorry. That is cut here. Nasolacrimal duct. If I, see this?
Yes, now it's very clear. Yes.
Now, secondly, see, this is the level of the lateral pterygoid plate. Can you see this level? Section lagaya.
Yeah.
Lateral to this is the infratemporal fossa.
Yes.
What is the fissure? See, this is the maxillary bone.
Yes.
And this is the pterygoid. So this is pterygomaxillary fissure from here. See, this is the site of pterygomaxillary fissure where my periosteum elevator is.
Yes.
And how you practically see this? Go up where the maxillary nerve V2. See this? Where the V2 crosses laterally towards the inferior orbital fissure. This is the point of separation of the pterygopalatine fossa from the infratemporal fossa.
Okay.
And in the roof, this is this prominence. This prominence is V2, along with the artery which was given by this maxillary, and this was going here. Right. See, this is the foramen rotundum.
Yes.
Can you see very clear?
Very clear.
If I put my drill here, I will reach directly the temporal lobe of the brain.
Temporal lobe of the brain.
Chota gauge piece. Now this 1 square inch area now. Anybody has slightest doubt, please come forward. Gentle. Yes, now this is the pterygoid process. Now if I go behind, here at this point of time, see, this is the nasopharyngeal musculature.
Yes.
My parapharyngeal carotid artery is another structure which I must know at this point in time if I have to do something in the parapharyngeal space. So there are so many landmarks. Number one, if I trace this lateral pterygoid plate up, see this? After dividing this lateral pterygoid muscle, can you see this muscle?
Yes.
If I divide this muscle with the cobblator, right up and behind, see this behind, 1 centimeter behind from here where my suction is. Here is the foramen for V3. Oval, right there, at the superior most portion, and this is V2, this is V3 here, see this bone in between? This triangle is anterolateral triangle, and this is the second area of spread of JNAs into the temporal lobe. Okay? So these branches of V1, V2, V3, they run in the floor of the middle cranial fossa coming from the, trigeminal ganglion going out of the respective foramen. So here it is lateral pterygoid. Now behind and below, lateral pterygoid is a superior anatomy. Behind the lateral pterygoid and below here, if I drill away this bone, Below and behind is the medial pterygoid. Running is this direction from posterior to anterior and for up to down towards the angle of mandible is the medial pterygoid muscle arising in the pterygoid fossa. If I drill away this bone, I will drill away this bone. There are two muscles inside this pterygoid fossa. The medial pterygoid laterally and the tensor tympani medially here. Okay? Now from where the posterior end of the pterygoid fossa, see this, let me show you. Ball here. Where this pterygoid process ends behind, see this is ending here. Can you see here?
Yes.
Just behind is the eustachian tube.
Okay.
From this point here, 20 millimeter behind, minimum 20 millimeter, and from the lateral pterygoid 30 millimeter, 26 millimeter behind is the parapharyngeal carotid artery.
Parapharyngeal carotid artery.
26 millimeter. Imagine. How come? This is eustachian tube. This is like mother's lap covering the carotid. This eustachian tube is ascending from here up. See this? Ascending here up towards the horizontal petrous carotid artery and going up to the genu of the petrous carotid right into the front of the cochlea. You know? So eustachian tube, this running up, this is the cartilaginous one here. See this? If I tilt it, I can show the levator and the tensor muscle. The tensor is inside and going up. These two muscles are the landmark for carotid artery. And this nasopharyngeal surface of this muscle, this muscular mucosal surface of the nasopharynx, 1 centimeter deep to this, 1 centimeter deep to this is the level of the parapharyngeal carotid artery. It is lateral to this, 1 centimeter beyond the, the fossa of Rosenmuller, and this is fossa of Rosenmuller. Can you see? At the tip of the fossa of Rosenmuller there, 1 centimeter behind that and 1 centimeter behind this plane, just behind the level where the V3 comes out, few millimeters behind the V3 is the parapharyngeal carotid artery. This V3 comes like a horseshoe leg. Comes like this and put the leg down, crossing the horizontal petrous carotid. The horizontal petrous carotid is going from here horizontally and behind. That is how the anatomy is. And this is the sphenoid sinus. In the sphenoid, this is clival recess. This is the sella, very prominent.
Yes, sir.
Above that is the tuberculum sella. This is tuberculum sella, the thick bone. This is planum sphenoidal, and that is the prominence of the. See the optic nerve. Prominence of the optic is above, and below the optic nerve here is the superior orbital fissure. Just anterior to the paracellular carotid. See this? Immediately in the same horizontal plane. See this?
Yes, sir.
That is the sella. This is paracellular carotid. When we remove the cellular tumor, the carotid is laterally and immediately anterior to this carotid. This is anterior. This is superior orbital fissure. I hope you will never forget this anatomy now.
No, sir. I think we will never forget this anatomy. You have already discussed this anatomy and about this 1 square inch. Now you're showing a case on it. I think it's fabulous, sir.
So thank you so much for your attention. We
Thank
can take
you,
question.
sir.
Our next case is ready. We
Yes.
can take meantime any question you have in your mind.
You cannot hear the applause, but individually all the delegates are really spellbound, Satish. Spellbound. Really beautiful surgical demonstration of a JNA.
See, I hope
90% of time.
I hope this will shatter the fear of everyone.
Yes, yes.
Dealing
I'm
with the
sure it
cavernous
will.
sinus, superior orbital fissure, and for that matter, any area where this tumor goes.
Yes, sir.
See, we have to
Professor,
understand the anatomy. We have to
question.
dissect more and more cadavers.
Yes, sir.
And once you get used to this anatomy, you can remove. See, there is no bleeding. We
Yes, sir.
haven't
Absolutely.
transfused. We haven't transfused. We haven't embolized.
And he is a 13 years old boy.
13-year-old, and see the panoramic view. The biggest advantage of this approach is you
Yes.
never need a radiology unless the symptom warrants. Never read the radiology. The reason is, if the tumor happens to recur from somewhere, you can see with your 0-degree endoscope so easily.
Yes, yeah.
Yes, sir.
You don't need a scan every time. And
Yes,
this area
Satish,
which
can I just
Professor
say-
Sachs pointed out, this
Yes,
area
sir.
which Professor Raymond Sachs pointed out, this is very important.
Yes, sir.
The pterygoid canal and this pterygoid process area.
See this
Yes.
carotid, this is the median now. The normal
Yes.
median now. See the normal median now.
Yes, yes, very clearly seen.
See this? Until you
Yes,
find the
yes.
normal now, you have to drill away this. You have to ensure that the no tumor is infiltrating, because this is one of the commonest site of the recurrence. And this is why he mentioned, because he
Recurrence.
knows his experience, he knows what is the site of recurrence. Thank you, Professor Sachs.
Satish.
Thank you very
He has to say something. Yes.
Satish, I've just got two concerns. Now, one concern is that you make this operation look much too easy, and I don't think anybody must underestimate how difficult what you have done actually is. This is an exceptionally difficult operation that you make look very easy, and that's because of your skill. But I don't think that anybody should underestimate how difficult what you have achieved here actually is.
Very important.
Professor Sachs, in India, a lot of people are doing this surgery. There are certain fears among the people regarding some areas of involvement, and my job was to simplify, because it is not difficult. I always tell everybody, if somebody asks me how you can do it, then I tell them, assume that a person like me, a duffer like me can do, anybody can do it. So anybody can
You
do
make it look
because
too easy,
it's not
Satish.
difficult. The people have made difficult, you can say, but understanding the anatomical principle. That's why I always tell, do more and more cadavers. I am not here to show that I can do it. Believe me, you can do it.
Now, I love your approach, and I thank you very, very much for
If
it.
you are a beginner, keep extra unit of blood. Keep extra unit of blood. Second thing, train your assistant. That is very important.
Yes.
You have to make a team and see that not a single drop of blood now. But though we'll still pack, we'll pack the area for a day or two.
Virtual on the radiology. Don't forget that part. That's what makes it easier.
Satish, what is your post-op management of these cases, Satish?
Pardon?
What is the post-op curriculum or review of these patients?
Post-op is simple. After 2 days, we will remove the pack.
Okay.
After 2 days, we will remove the pack, and then we'll train the patient for a day or two with the ringer lactate irrigations.
Yes, ringer lactate irrigation.
We keep the patient extra day in hospital to train him in irrigation.
Okay.
Then once he starts irrigating, we call him first after 10 days. So there are little bit of the crusting initially, but the patient irrigates, they are minimal. We remove little bit of the crust, and then we call patient after 4 weeks.
4 weeks, okay.
Until then, it almost heals up very well.
Yes.
And we rarely need a CT scan or any imaging unless we have a doubt. If I have a slightest doubt of any residual tumor at this point of time, I will not think twice to warrant order an imaging right away. If I have a doubt of leaving tumor somewhere, I will get CT now done, and I will take the patient again tomorrow and remove that particular part. Why to leave it for future?
Okay. Total mucosalization by 4 to 6 weeks, there will be a mucosalization.
Yeah, it's a continuous process. It takes by and large 8 to 12 weeks, by and large.
Oh, 8 to 12 weeks.
Yes.
Satish, my only other concern, Satish.
Yes, sir. Please, Professor.
Yes,
Yes, my only other concern is that it's nearly midnight in Sydney, and I'm operating tomorrow morning, and I would love to stay and watch you do operations like that for the rest of the night. But I unfortunately have to leave you, and I just wanted to thank you so much. I really enjoyed that. I found that exceptionally
Professor Sachs, so much. We are so indeed grateful to you. Professor Sachs, can I make a request before you go?
Yes.
I want to share the CT scan of the next patient to have your opinion, and then you can leave.
No problem at all. Happy to stay for that.
Okay. Okay, we'll take question. Let me share the CT scan first with Professor Sachs.
Okay, sure.
This patient presented with a proptosis, like inferior displacement of the eyeball, headache, had history of sinusitis, got CT scan done. Let me show you the CT picture first, and you see what is there.
You are using DICOM radiology?
Yeah, DICOM, always. See the CT picture of this patient.
Yep.
Yes.
See this, there is a lot of frontal disease with little osteitis as well. And see this part of the purulent discharge. See here, the pus cavity with no communication with the frontal sinus itself has broken the floor and the collection is down in the orbital roof. Now the question is how to address this. There is no communication with the frontal. Number one, I will show you a better picture. Yes. See this.
There's a communication.
See this. The frontal floor has gone and it has gone right in the upper part. Now I will share with you a very good MRI picture of the same patient. That will clear you everything, crystal and clear. See this. No, this is not the patient. Okay. Yes, this one is the patient. Yes. Now see, this is the frontal sinus. See this?
Yep.
And how this pus is coming to the roof of the orbit laterally, superolaterally.
Yes.
And because of the osteitis and the blockage of the ostium, there is no communication to the frontal outflow.
Very thick bone is there.
How big is the anteroposterior diameter of the frontal medially?
Yes, that's a very important aspect.
Sagittal?
You can see this is the anteroposterior diameter, not very big.
It's not big at all.
Yeah, if you want me to measure.
No, that's okay. I can see that. That's narrow.
Yes, it's narrow 1.3. Now the issue
narrow.
is how to address this, because this is no communication with the sinus outflow. Don't see this. This is not communicated to the sinus. So my approach in such cases is orbital transposition.
Yeah, I think that's the best way to do it. I agree with you, like Paula Casanova described.
Yeah, what we'll do a draft 2 on this side.
Yep.
And we'll remove this superomedial wall of the orbit, completely bony wall, until I reach this and communicate directly and do a good outflow into the frontal outflow.
Yeah, I think that's probably your best. You've got one of two choices. You can either do an external approach.
Yeah, that is the only way out. Other way is external only. But if you do external, tell me, how will you communicate with the frontal outflow to prevent future?
No, well then you're going to have to obliterate, and I don't like obliterations. So because your risk of mucus is so high.
Yes, that's the only way.
I agree with you. I think an orbital transposition is the best way to communicate, because you have got a lumen medially, and I think that if you do get, you've only got a short block of bone between the existing frontal and that mucocell. So you should be able to, with an orbital transposition, access it and drill that bone down so that it's almost paper thin above and below, so that you'll have an opening that's going to stay. Your problem is that with neosteogenesis, you could close it up again, and that's a risk. Even with orbital transposition, it could close up again.
What we do additionally, sometime we go from the opposite side through a septal window.
Yes, well, you have to do that over the orbital transposition, because you need the angulation.
Yes, to get angulation. Because my concern is, if you don't do this and go by, the only thing is the open approach, in that situation, the only option you are left with is obliteration.
Yes, absolutely, I agree.
Professor, these are listed as contraindications for endoscopic approach. Earlier, but now I think this transposition, what Satish is going to demonstrate, and also an additional approach through septum, the new osteogenesis will not obstruct the flow.
Yeah.
Well, you don't know. That's the problem.
Madhu, that's why I mentioned do a draft 2 first.
Yes.
To give a wide access, and then we'll remove the medial orbital wall, superior wall, to access right over there.
Yes.
And then in the post-op period, we'll train him with the irrigation, with the steroid solution reaching everywhere. It will
Yes.
prevent future neoosteogenesis and blockage.
Yep, I think that's a good idea.
Can we have an idea of any putting a silastic stent or a tube so that for 6 weeks osteogenesis?
No. Really, once you do this draft 2 and transposition, you really get a wide access to the area where you are going, and you really
Yes.
don't need to do all that stenting. And
I think as you stress, the post-operative proper positional irrigation will reduce all the problems.
Yes. And see,
And the other thing that's worth considering, but it depends on how much AP diameter you've got, is using a vascularized flap described by Brad Woodworth to try and line that bare bone.
For the healing, we can use that. Now
Yes.
see, on T2 weighted imaging, this is the area where the pyocele is coming down. It is not mucocele. It is little, mucocele would have been absolutely bright, like the intensity of the CSF. And see, this is a pyocele. Now the important thing is why I am saying pus. Why it is not mucosa or polyp. Now you see on the contrast. In contrast, see this? See this hypodense area which is
Yes. Very clear, very
it
clear.
is abscess. It is pyocele. See rest of the areas on both sides. See this mucosa is enhancing. The mucosa is enhancing because of the inflammation, but this pyocele is not enhancing, and this is the clear-cut abscess, and that is how the orbit is pushed inferiorly by this pathology.
This is contrast MRI.
This is contrast. So what you can do with this dynamic imaging, if you have this thing on DVD, you can put all these together. Let me show you three-dimensionally what is the lesion which we are looking at. See, this is with the contrast and T2. See this? This is the T2 hyper intense on contrast, hypodense. See, this is hypodense on contrast, hyper intense on T2, it is fluid.
Yep,
no vascularity. Okay?
Yep.
Now at the same time, what I will do, I will bring two more. No, I will bring this. This is T2 on the axial. See, this is the abscess which is in the roof of the orbit here.
Yep.
And now at the lastly, I will bring the sagittal to show you exactly where the lesion is. See this, how it is pressing from above. So three-dimensionally you can see in all imaging, you have a three-dimensional picture in mind of the area you are going to operate. That is the value of imaging. So never compromise with imaging, get three-dimensional imaging, and you can have a complete 3D picture in mind. Now my entire picture is very clear. I have a Google map what I have to do.
That's absolutely right. This is going to be a great case. Is this going to be available on YouTube afterwards?
It's live, sir. This is in YouTube, sir. Professor, sir.
You can see live on YouTube on your telephone, and you want to see further later on in life, you can always download from YouTube.
Excellent. I'll watch it. I'll watch it tomorrow. It's now midnight.
Pardon?
I said it's now midnight here in Australia, and I'm operating in
it's too late.
7 hours.
We are
And I've got an all-day list tomorrow, so I need to get some sleep.
So grateful to you for enlightening us and giving us such good tips. We are always indebted to you. Thank you so much, Professor, for sparing your valuable time.
No,
nice to have you, sir, Professor, sir. Very nice to have you.
Good night, Rick. Thank you, and thanks to Professor Sethi again for putting my name forward, because I'm always grateful to see you.
Professor Sethi, big thank. Thank you so much. So, Paramita, will you take any question before we move on to the next case?
Yes, sir. So, sir, there was a question. Actually, sir, you have answered almost all the questions.
Okay, you can. We can carry on the discussion during the next case as well.
Yes, sir. Yes, sir. So, only question, Dr. Nikhil Gokhale from Pune was asking that can open cavernous sinus can lead to air embolism?
Not really. Not really. Don't worry. See, it is a honeycomb space filled with venous blood, and it has a communication all around the sella with different sinuses forming a circular sinus. Number one. Secondly, you saw the periosteum all the way.
Yes.
This tumor was pushing into the cavernous, but the periosteum was intact. So there is always a periosteum intact to prevent all these issues.
And so this cranial nerve 6, if it's affected, can we check
Can
it
you
on?
bring the mic? Paramita, just a minute. Yeah, jaldi bhaiya. La. Hello?
Yes, sir. Dr. Jagdish from Oman is asking how to know if the 6th cranial nerve is affected on table. Can
you repeat the question?
Dr. Jagdish from Oman is asking how to know if the 6th cranial nerve is affected on the table.
On the table is difficult unless you are doing a cranial nerve monitoring.
Okay.
Yeah, on the table is difficult, but it should be 6th only, because that's the only cranial nerve which truly passes through the cavernous sinus. Convey my regards to sir. Hello, sir.
Yes, sir.
Sir is always a part of our academic events. He's
Yes.
from Muscat, and that is one of the top center in Muscat. He is working at the Al Nada Hospital. I have an opportunity to visit there for live surgery 2 or 3 times, and what a wonderful experience it was with Dr. Ravi, Dr. Hamdoom.
Satish, is this the next case packing is being done?
Yes, yes.
Yeah. Yes.
So,
sometimes I really get that no electricity, no microscopes, no endoscopes, no drills, and I don't know in 18th century anatomists detailed anatomy how they identify.
Yeah, and that too so long back.
I am thinking 200 years back, all this anatomy was described.
Imagine the Proctor published the book on anatomy of the temporal bone 50 years back.
My God, right.
And that too of the detail you can't even imagine. 300 pages book only on the anatomy of the temporal bone. You can imagine how micro level what he had described. He described the middle ear fold with a 50 pages article published in JLO in 64. All middle ear folds, what we are seeing, there is no change into that since then.
I think we have to salute those people, in spite you showing as an open book everything, and those people are really great.
So one more question, Dr. Pushkaraj Kulkarni from Mumbai is asking, how often do you see pre-op clinical involvement of V2? Like loss of maxillary
Rare. In JNA, rare.
Okay.
That's why you have to preserve it, because this is never involved by the tumor. It can be pushed. See how tightly it was adherent on the tumor surface,
yes,
which we separated, but it is never involved. Now see, once you are planning draft, you have to improve your access. Here I have to do orbital transposition. I have to go from opposite side. So many things are already in plan. So why to make your life difficult? Now see what I am doing. I will trim this middle turbinate as well. Sooner or later I will trim, so I am trimming it right away to make my life easier. See this? Now see the uncinate process. See the purulent discharge here. Can you?
Yes.
What about preoperative preparation in this case?
Yeah, little bit of the preparation, not much.
Antibiotic, any course of antibiotic, any steroid in this case?
Last 2 days we have been. See, this is for the middle meatal line trochmy, and see the purulent discharge?
Yes, yes, yes.
People who say that non-polypoidal sinusitis, they have never seen any indication for surgery. This is for them.
Okay.
And some people, I have seen them outspoken in the biggest forum that the non-polypoidal sinusitis doesn't need any surgery. God bless them.
Right. In many cases, not only this is even maxillary, sometimes you have to do it.
This is the classical example, you see. And for that matter, majority of the orbital complications of the sinusitis are with non-polypoidal sinusitis.
Yes, that's true.
Call suction. You must have seen in your practice. See this? Howsoever massive the polyposis is, they rarely give orbital cellulitis and abscess. But non-polypoidal, see this?
Yeah.
They give.
Very thick pus.
Yes.
Very thick pus.
So all these orbital sinusitis, orbital abscess, cellulitis, you know, they are majority of the time.
More symptoms, more complications. Right?
Yeah. Now this was just to open up the maxillary sinus. See, this part is not the critical part, so I am reaching quickly as we have to save some time as well.
Time is the
Yeah. I have to focus on the key area, so I am removing this very fast.
will you have to trim out this middle terminate off?
Yes. Because you saw the osteitis in this region
Yes,
on the
yes.
CT scan.
Yes, very much.
This is not a simple frontal sinus, this is. At my point, this is a difficult frontal sinus.
This case requires regular post-operative visits, I think, very regular.
Yeah. These are the cases where one can use the navigation system as well to improve the accuracy, to improve the localization, you know. See this? Now, without wasting time, give me the pack. I will start drilling for the frontal very soon for the draft. Super. See this anterior wall of the frontal above. Can you see this region? That is our area of interest. This is our area of interest. See, this is an interesting case in the sense if somebody comes across this situation, scientifically there is no other answer to this problem than this. That is what I was asking with Professor Sachs. Otherwise, you have to go from open and you can't give a drainage to the sinus, you have to ultimately obliterate it and then follow all the problems of obliteration itself.
What are these problems of frontal sinus obliteration symptomatically?
Pardon?
Symptomatically, what are the problems by obliteration?
No issues. It should be done perfect with no mucosa left behind.
Yeah.
See now, I am removing this mucoperiosteum.
Dr. Gautam, you are in that, especially northeast side, any incidence of sinus infection more over there, polypoidal, non-polypoidal, whether any effect over there?
Number one, in the northeast, we get less of AFRS.
What? AFRS?
AFRS is comparatively less compared to, say, your
less.
part.
Less?
Okay.
It is less?
Yeah. AFRS is less.
Okay. See what I am uncovering? After removing this, the anterior wall and the floor of the sinus. With the cobblator, you can do it with
Hardly any bleeding. See this?
Yes, yes.
And this is how you can define your posterior limit of the graph. What is that? Section.
Post olfactory fibers.
First fiber of the olfactory fossa.
Yes.
Level 1 question for all of the delegates. Which is the first structure come across when we dissect it?
Yes, I told in the cadaver.
Those who can give the answer, earliest answer will be awarded. First structure come across when we dissect this area. Or you can remove the mucosa.
Quick, otherwise I am going to remove that.
Yeah. Just don't announce. You just do the dissection. We're waiting for the answer.
See that? What he is asking?
Let's see, on YouTube is with me.
See this? What is he asking?
Yeah.
Here. Now, give me the marrow cell. See this area I am totally uncovering.
Any answer, Paramita?
Goblet.
No.
Not
from my end.
I mentioned several times during the cadaveric dissection.
Olfactory nerve fibers.
No, Doctor. Kipranath, first olfactory neuron. No, this is not the answer.
Olfactory neuron is medial and behind.
First structure comes across.
Frontal beak?
No, sir. It is something related to neurovascular wonder, something with nerve or artery or vein, something like that. Dr. Ravi Shankar, yes, he is right.
Somebody answered?
Yeah, Ravi Shankar, Ravi from our Oman.
Oh, Ravi boss, what is his answer?
Branch of, septal branch of anterothoracic artery.
Anterothoracic
artery, septal branch of anterothoracic artery.
Yes, exactly.
Yes, even Uttam Agarwal from Kolkata has answered.
So both deserve. Sun Pharma give double prize.
Ravi from our old friend, he is our.
See now, I have removed the entire mucoperiosteum from this region.
Sir, can you orient the bony structure now?
Pardon?
Orient the bony structure.
See now, this is see this vessel laterally.
Yes.
This is the septal branch of anterothoracic artery, and see below and medially and behind. Can you see that? Behind and medially, that is first olfactory neuron.
Okay.
Yes, sir.
So medially and behind is the first olfactory neuron, and laterally and little anterior. See this two foramen.
Yeah, that is in your suction tip.
Yes. So correct answer. Now, this is all being done with a 0 degree.
Yeah.
Now I want to drill. So now my drilling will start for the frontal.
Anytime you had to do septal mobilization or septoplasty for want of space?
Yes, not for that. I will do make a septal window.
Okay.
Satish, the patient's position is neutral now. There is no head.
Neutral. Everything being done with a 0 degree. You see this? So there are two techniques. This is the traditional one. What I will see, this is my posterior limit, okay? Anteriorly I can go right up to the skin. Laterally I can go right up to the skin. So what I will do, I will define my lateral limit anteriorly and below. And see the lateral limit. Can you see?
Yes.
The outside skin. See this? See,
Can
this is
somebody
outside
press?
skin.
Can somebody press? Yeah. Yes.
Yes, sir.
Simply this is the lateral limit. Now see, this is cutting like a butter.
What is the speed of the drill, Satish?
75,000.
75,000.
This is same stylus. I am using with a very light hand.
Oh, right.
So that my everything remains under control, and this is coarse diamond.
Coarse diamond, okay.
Absolutely safe as well. If you use the cutting, you will make lot of buttonholes.
Is it 3.2 mm or 4 mm?
This is 4 mm. Generally, I use 4.5. That's why I was asking my assistant why not they opened up 4.5.
Yeah, that's why it looks a bit smaller in size for this area.
I generally see this. This
Yes.
is outside skin. I will follow this skin anteriorly as the
Yeah.
anterior skin as well. Okay?
Yes, sir.
Yeah. See this?
Go.
So Dr. Nageshwar Rao is asking what is the role of navigation in this case?
Yeah, very important. I mentioned that. It is always better if you have it. That will improve your localization. Another technique I mentioned last time which Professor Richard Harvey does is outside in.
Yes, sir.
What he says, once you have seen your posterior limit, why not to go anterior and then come behind?
మల్లికార్జున జయంతి మూడు పొద్దు నుంచి ఒకటే నన్ను ఆయన చెప్పే ప్రశ్నలకు నేను సేఫే అంటారా నాకు భయం లేదు.
For everyone, Dr. Sethi has a talk on 16th of this month in the World Forum. He is talking on his experience of frontal sinus surgery.
What date?
Dr. Sethi.
When sir?
16th.
16th, okay.
I hope we'll get the link.
Yes. This is the junction where the frontal beak combines with the...
See the skin, it is coming anteriorly now.
Okay, right. Because
this is not a very big frontal sinus, we all know.
You showed lot of osteitis, so you must be experiencing lot of bone now to be drilled.
Lot of?
Lot of bone, because the CT scan showed thick osteogenesis or osteitis.
Yeah, see, that's why. This is a bad case for that matter.
Very bad case.
Very narrow frontal.
Because I have seen draft type 3 after 1 year or 2 years almost becoming 50% of its space.
See now what the guide I am using is this outside skin. See this?
Yes, sir.
As long as you stick to the landmark and keep removing the bone, you are in the safe region. See, this is the only surgery in the frontal sinus where you are, once you define your posterior limit, you are away from complication. You know?
Yes, sir.
As long as you don't breach the skull base, there is nothing to be damaged here. Only thing at the most you can do buttonholing, that you can suture. That's not a big complication, you know.
Buttonholing of the skin, you mean?
Yeah.
Yeah.
So Dr. Sachin Sharma from Jaipur is asking, would you like to send this pus for culture sensitivity?
Yes. See, for the purulent collection such, the moment you remove and establish the drainage, you know, your job is done.
Yes.
But yes, for academic purpose, I don't deny. See, now I am with all the time with a 0 degree and where I am working. See now, this is frontal sinus. Can you see?
Yes. Beautiful.
Yes.
Whenever I do frontal sinus, it occurs to my mind name of Ashish Bhumkar. He always explain this concept as a box. Frontal sinus is like a box.
If there is a small communication, if you forcibly irrigate with ringer lactate, if the pus comes out.
Pardon?
If you forcibly irrigate with ringer lactate or normal saline,
yeah, it may come
if
out.
there is a passage, the pus may come out.
Yeah, it may come out, but that will not give the drainage.
Okay, okay.
You saw the drainage was very narrow or almost non-communicating. Almost non-communicating.
Yes, yes.
See now that is the frontal with 0 degree.
Edematous mucosa also.
See, once you remove the part of the beak, you can see with the 0 degree. You remove the obstacle, by removing this beak.
Yes.
Chalo, chalo. Rende. See now?
Yes, sir.
See the interior of the frontal. I am going slowly to show you all the landmarks. Wherever the bone you have to drill, that's it. And this way, if I go medially, I can really widen the frontal medially as well.
Now the cases are difficult to manage post-operatively. They are very irregular. You can say difficult. They don't come in follow-up, and somehow these are need a strict follow-up.
Yeah, for these patients, follow-up is important. Irrigation is important. See, the patency of the whatever opening you give is mostly the long-term patency depends upon the prevention of new osteogenesis.
Later, can you show the exact position for these sort of cases? Irrigation is very particular position so that irrigation goes exactly into the frontal.
Yeah, I always tell. I will show through my laptop, Madhu.
Yes, yes, sir. We want, sir. We want.
Right. So this is the Caroline's window that you're showing, that you're doing.
Pardon?
What is that?
Caroline's window.
Oh, I could have shown earlier. Let me tell you. This is what Richard Harvey presented a few days back in in Dubai. Caroline's window is what? Rather than going from below for the frontal sinus here, what the bone, the mucoperiosteum I removed earlier from above. He raises a flap. And directly make the window over here and come back.
Okay.
That is Caroline's window. See, there are many ways to do the same thing, you can say. Inside out, outside in, like that.
Yes, the advantage of mucosal preservation. That is, I think, plus point.
No, the only thing I find in that is a lot of raw areas ultimately. I have no experience. Richard Harvey does so well. So I can't comment unless we do. But he's extremely good at that. He only devised that outside in approach. Now Caroline's window. He keeps on doing something innovative.
Now the area you are drilling is the beak, isn't it?
Pardon?
Continue to peak.
See now, as I have reached there, I am taking a medial turn. See the sinus?
Yes, yes.
See the thick mucosa in the sinus. Because it was completely blocked. See this? See, this is so bad a sinus, so bad. See, my limit is this bone, this skin anteriorly. I will follow it medially until the anterior skin. And behind the skin, the entire bone has to go. See this? I hope you are oriented.
Yes.
Following the same skin, I am That's why I love this approach. See this, let me orient you. The only landmark I took in the beginning was this skin of the outside skin over the nasolacrimal system. See this? Hello?
Yes, yes.
Yes, sir.
And since then I am following that only.
Yes.
See my frontal came. That is the frontal with 0 degree. And this skin I will follow till medially. The same skin will come here.
You will remove in between some amount of some more projection, that part, midline projection.
Some amount of 60.
That midline projection, a bit bent.
Yeah, this one.
Yes, yes.
This I can remove.
Yes.
Because my posterior limit is very clear.
Yeah,
that is the neuron.
Yes.
Yeah, I will remove this. See, you have to remove all these projections to widen antero-posteriorly.
Yes.
The biggest problem, or I would say contraindication to these approaches sometimes, is the narrow AP diameter.
The book description for contraindication of endoscopic is lateral pathology of the frontal sinus. But you are totally rewriting that.
Yeah, that was old concept.
Yes, that's what I am telling. Old concept, and now you are there is no contraindication for lateral pathology.
Although in endoscopy the concepts are changing very fast.
Yes.
I tell you, the endoscopy is one of the fastest evolving field in the entire medical science. There are so many fraternities, you know, so many
more and more
subspecialties.
indications are coming, sir. More and more indications.
You go to the JNA papers 10 years back.
Yes.
And before, all endoscopy you will find only grade 1 and grade 2 JNAs.
Yes. But you are able to do even grade 3 and much more.
Practically every JNA should be removed endoscopically. You know, I have seen people removing open. Let me tell you. What do they do? By open transpenital, maxillary zinc, whatever.
Yes.
They will remove the tumor finally and then pack immediately. Tight pack because of the bleeding and don't see anything. How can you expect the microscopic removal of the tumor?
Natural. Wow, what a beautiful view we are now having, the lateral, I think, view of the frontal
sinus. It just started coming, Madhu.
Yes. I don't think this will stenose. 100%.
No, it's still equilibrious.
No, Rajiv, I am telling, even after 6 months, even a 1 to 1.5 millimeter patency is sufficient. Regular irrigation.
Once you irrigate with the steroid solution properly,
yes,
irrigation,
this will never stenose. That was the past story when Lothrop was, came to disrepute sometime because of his tendency to stenose.
Yes.
But after this concept of irrigation,
yes,
is no more.
Yes.
See, everything being done with a 0 degree.
Yes, sir.
Where I have reached. My posterior limit is right there. And I am far anterior to it. I have no fear. Got my point?
Yeah.
See, this much.
Sir, which other approach is possible in this case?
Open is you can go by, trans-eyelid approach, transorbital approach, transconjunctival. You can go by trans-eyebrow. You can go by bicoronal. Many.
Okay.
Once you are going open, then everything, wherever you want to go, you can enter. The issue is to avoid open because I am not against the open or close. The issue is how to give patency.
Satish, is there any role of frontal putting a small 2 millimeters nasal feeding tube for irrigation like Trefine?
Yeah, Trefine. Trefine has a role to keep the patency for irrigation for some time.
Maybe 1 or 2 weeks.
You can keep it for a week or two.
Yes.
Number 2,
and adjusting that tip of the tube at the lateral part of frontal sinus endoscopically, so that you will get irrigation to the most lateral part of the frontal sinus.
Yes. And second is the biggest role of Trefine is in identifying the sinus in the beginning. You know.
Yes, yes, yes. Sir, I am a fan of
somebody beginner is doing this graph.
Yes.
And want to be sure that he is right going into the sinus, he can keep on pouring through the.
Yes.
You know.
You can see the passage through frontal triphyne and easily identify the tract.
Yes.
And is your favorite subject? I think yes. I've heard about yours triphining and this area.
Yes, yes. I presented a lot of papers, Rajeev.
Frontal triphyne. Somewhere in Hyderabad, somewhere I think.
Yes. I would like to acknowledge 2 years back, 2018 and 19, Satish was in Nandyal and he demonstrated beautiful techniques of sinus surgeries and everything for all the poor patients of my place.
And you did a JNA also at your place.
Yeah, yes.
See,
you are now almost at the superior-lateral junction of the orbit.
I am going fast. Watch. Let me tell you. Just keep drilling the bone, keeping in mind, keeping in view this skin. See this?
Hello?
See this. Keeping in view the skin, the outside skin. See this? Keeping in view this outside skin. You have to remove all this bone. Can you see?
Yes.
And this is how I am finding my way to go laterally. So this is one of the extremely difficult condition people would think of in endoscopy to reach far laterally. And this, we have now the huge series of such cases, you know. See the frontal sinus from inside?
Yeah, I think we are seeing the most.
I told you this is not a very big frontal.
Yes.
That's why it is difficult.
Not only shallow and lot of osteitis. I mean, maybe the pus, for a few months it must be there.
And see the mucosa even so bad. See the mucosa even so.
Yes, mucosa is very
bad. Yes. Now, in order to go far laterally, I come from opposite side transeptal to get a better angulation for my instrument.
Okay. Right.
Got my point?
So, how much window you make that transeptal for visualization?
2 centimeter, 2 by 2, 2 by 3 centimeters sometimes.
Okay.
On the opposite side, you know, inferiorly. And that is what Professor Raymond Seck said. And this procedure is known as, after draft 2, if you come from opposite side to go laterally, is hemilothops.
Okay, hemilothops. Okay.
Modified hemilothops.
Yes, sir.
Central lothrops, mini lothrops, and modified lothrops.
Yes, sir.
See the space, no? Far laterally. Now this is the time of patience now. Until now was the crude work, you can imagine. So we went fast. Yes. See the interior of the frontal?
Yes.
And the walls are so thick. See this?
Yeah, very thick, very thick.
Even if I try to
drilling.
So once I elevate this, my posterior limit is generally ENT model artery. Posterior limit of
Satish, you read
behind.
Elevation of periorbita. Okay. Yes.
This periorbita I am elevating anterior to posterior. My posterior limit is generally the anterior model artery. Now issue is, if you have to go far laterally, if you try to stretch the periorbita more, your posterior model artery can stretch. See the thick bone I am taking off? Hello?
Yes.
I don't think it is so thick because osteitis is so thick now here.
Yes. See this thick bone.
Yeah.
So if you have to go more and more behind, see this.
Is that place you also this place of superior oblique?
Not really. As long as you stick to the periorbita.
No, I am not saying there is a periosteum, but lateral to periosteum is that place where you get the superior oblique.
Superior oblique. See now, the thick bone. If I happen to remove this bone, I will be right into the lateral part of the frontal. See this?
I think his assistant is retracting.
See this? I am retracting this entire periorbita.
Yes, sir. Yes.
To reach the area where the disease is, and I will communicate that after removing this, and that will be communicated to the frontal then.
I think it's almost 1 centimeter down after the floor of the destruction into the orbit, I think.
Yes. Now see what I am doing. Whatever periorbita you elevate, you stiffen it with the cobblator. See this. Otherwise it falls in, it may get damaged. See what I am doing.
Stiffening the tissues.
Stiffening with the bipolar.
Okay. A cobblator.
Cobblator. See this. It remains elevated easily.
Yes.
Satish, can the 120 rad blade go now from here to the lateral part?
120?
The 120 rad blade, can it go now?
But that is debrider. We want to drill, man.
No. Boomkar is asking, can a 120 degree debrider blade can reach the lateral surface of the sinus?
Not really. That will be too blind. See this. We are not supposed to pass from here like this.
A malleable suction cannula can go, Boomkar.
Yeah, the issue is the communication, boss.
Communication, yes. Communication. It may go.
See where I am reaching. See where I am reaching.
Yeah, it will be an aspiration at best, nothing more.
So now I have elevated the periorbita of this. See this? Completely intact, and this bone, now my task is to take away this a centimeter thick bone. Can you see this?
Yes.
And I will be right in the lateral part of the frontal. Then this obstacle will go away. See this?
So this whole that 1 centimeter thick bone has to go.
Yes, that is the whole task. Now to reach there, I will take the help of opposite side.
Yes.
Since that webinar is started almost 1.5 months, there is a shortage of cobbletor in the market. So many people have purchased it after they seeing these surgeries and everything.
What?
There is a shortage of cobbletor in the market now. Since this webinar is started 1.5 months, they have propagated so much that everybody is buying this cobbletor now.
I think the cobbletor orthocare people should give lifetime free supply of cobbletor blades to Satish.
Oh. Once again, Madhu, repeat.
The orthocare people should be indebted to you.
Orthocare people, please listen to what Madhu is saying.
I think the message goes to orthocare people.
I am recording it personally also.
Thank you, sir.
The number of indications that Satish has made for this, the company did not think about it in the.
Good for all also. They will reduce the prices of the bands actually. It is very expensive nowadays.
Once price can go down.
See, Madhu, about the window you were asking. Hello?
Yeah.
Yes, sir.
It takes only 1.5 minutes.
Yeah, see, this is again with the cobblator, and this is the cartilage,
We are searching for one septal perforation case, I think. Many people want to see it.
Yeah, I will keep a septal perforation case also sometime.
Labs, everything. And this Sunday on 12th, we have a webinar on the cochlear implant and cholesteatoma also.
Yes, Sunday will be cochlear implant, cholesteatoma, and some endoscopic cases also. To add on to the variety. Sunday afternoon.
Yeah, 1:30 or 2 p.m. onwards, not in the morning.
2 o'clock most likely, yes. See this window on this side?
Yes, yes.
Okay, let's make it a perforation. Wait there. I should be able to see the opposite frontal recess from here, which I have created with a 0 degree. Can you see? Hello?
Yes, okay.
Yes, sir.
See, this is a marathon surgery. But for such patient, there is no other correct answer. That's why.
So you had shown us during the dissection time, but few of our doctors are asking where is the exact position of the septal window precisely? Can you show it once?
It should stay anterior to the turbinate. See the turbinate there? Superiorly, you can go as much as you want for the access. But my window is over just a little bit, drill. Little bit of the dimension I have to increase posterior superiorly, and it is done. See how thick is the septum above?
Yeah. It's almost 1 centimeter, even if it's more than 1 centimeter.
Now see what amazing view from opposite side. Give me a wash.
Can get the angle now. Got the good angle.
Our next case is a very, very interesting situation of a CSF leak primarily from the sala. That patient has a high intracranial pressure.
I'll get up.
And then we'll take a microscopic submandibular gland excision for a 2 centimeter big stone.
ये है मेरे सामने वाली खिड़की में.
Now see, my telescope is in the same nose. See this, the same side. Can you see?
Yes.
And my burr is coming from the opposite side.
You are still in 0 degrees. First, that is.
See now the excess.
Yes.
Find out. See Madhu, this thick bone?
Yeah. My son is also watching. I am telling him we should start doing in our place. New technique I am seeing. First time really, Satish. Transposition of orbit for lateral accessibility of a frontal sinus.
Yes.
Is ENT?
See, now coming from the opposite side has made the life so easy.
Yeah, yes, wonderful. And you are still with 0 degrees.
All the time. I am not changed the scope at all.
Yeah.
Wash. Yes. Wait.
What are other indications of this orbital transposition?
Pardon?
Other indications for
nothing.
orbital
Only for the
transposition.
lateral frontal sinus disease.
Satish.
See, it's a modification along with the Lothrop.
Yes.
One of the modification.
Satish, is any anterior to posterior between the frontal sinus walls? There is a bridge of bone.
What is that?
In the lateral aspect, we are able to see two. I mean, you suck out these.
In the lateral side, what?
Of the frontal sinus.
Yeah.
There is a bridge of tissue between the anterior and posterior wall. Is that the osteitis and fibrosis totally blocking the sinus passage?
Neuroosteogenesis you are talking about?
Yeah. I mean, how much time for the pathology will take? Years or months to come to this stage?
After a previous surgery or what?
Is this a revision surgery?
See this, what I am trying to say, there is no communication laterally with the sinus. See, in spite of so much of the drilling.
Yeah.
See, there was no communication to the lateral part of the sinus. Can you see?
Still blocked, totally blocked.
Hello?
No, we can see.
We can see you.
And you will see soon. There. See, this is it's not difficult, it's a tedious job. इसको retract कर. See now, my assistant is retracting the periorbita. Section रखना, चौधरी. See the bone? I hope you are oriented.
Yes.
Where exactly I am working? Can you see?
Yes.
See, I am reaching the disease?
Yes.
Yes. I have to widen it just to show you where exactly I am. Okay? See the disease. See the mucosa. See this cavity.
Yes.
Right.
Ashish. Is Ashish there?
But the bone doesn't look very healthy. Actually, it looks very osteitis and.
Yes.
Just wash. See now, I will widen it. That was the disease, you know.
Yes. I don't think even navigation is necessary, such a costly equipment.
Yeah, navigation is useful.
Sir.
If you have a slightest doubt, see, navigation is not on your anatomical knowledge.
Sir.
But yes, it is helpful in these situations. If you really want to take the help, there is no doubt about it. It will.
So Dr. Ashim Kumar Banerjee from Kolkata is asking what happens to the nasolacrimal duct in this case?
Why it is far away?
Nasolacrimal duct, miles away.
Miles away.
I am
Why
posterior to it, posterior and superior to it. Is Professor Sethi there?
Is online.
See now that cavity. That cavity.
Watching.
Yeah, Ashish.
Hey, Dr. Sethi is there.
Professor Sethi is
Sir?
Yes, Satish, we are watching.
See, I am far laterally, sir.
Yes, I can see that.
And that is my area. Let me show you. क्या चल रही है ड्रिल चल रही है क्या व्हाइट इज नॉट कमिंग कर दे यार झूठ
Sir,
yes.
Dr. Monish Grover is asking, in this particular case, with lateral frontal sinus abscess and the frontal osteitis, how would have been this option of making 3 holes just below the eyebrow and dealing with the disease endoscopically from there?
Yes, and then how will you communicate? This we have discussed several times. The same thing we have discussed several times. How will you communicate?
The frontal is blocked actually.
Yes, it is not communicated to the frontal drainage pathway. That's why we are forced to this to communicate. See what I am trying since then.
Now it is there, we can see.
You see this one communicated to the frontal drainage pathway. Now see the frontal drainage pathway is so big. Give me the drill fast. Still some work is left. Then I will mop up and show you, orient you with the anatomy. I am almost done. Yes.
So he actually meant those 3 holes and plus draft 2.
Pardon?
He actually meant that those making those 3 openings and plus the draft 2 procedure.
So what? Draft 2 is not communicating. Draft 2 I had done half an hour back. See this. Draft 2 I had done half an hour back. See this. The issue was communication of this isolated area of the frontal sinus which burst into the orbit to the frontal digit. See, this draft 2 I had done half an hour back. Yes. It has nothing to do with this. We have to communicate this. See this far laterally. Now what we are going to achieve, this cell now is going to drain into the main frontal pathway. See, this is the main frontal pathway now. Got my point?
Yes.
The issue is the future. That's what Professor Sachs immediately said. This is the only way. Otherwise you have to do obliteration. Now the option second is, if you go by open approach, remove the pathology and ensure that you remove every bit of mucosa from there, every bit of mucosa, and then carry out the obliteration. See, I have reached the most lateral part of the frontal sinus. See the beauty of this approach. See where I have reached. And my periorbita is absolutely
healthy.
Give me wash. Let me show you a little bit of the drilling is left.
And you have more or less drilled away that block of bone that was blocking the lateral and the medial part.
Yes, see this completely. See the opening.
Yeah.
So not only it is not about the draft, it is about the future. Now that cell will not remain isolated, non-draining to give future sinusitis. That is the basic issue.
Satish, are we able to see the beginning of the defect?
Yes, I have opened up, man.
Opened up, yes.
Let me show you again.
Yeah.
That was the part.
See the pus there now.
Pardon?
We saw some pus in the CT scan.
Yeah, that came with the section probably.
Okay.
You were mentioning the hypotenuse in
yeah.
T2 MRI. Acha.
See this now.
Okay.
This is the area now. Drill.
Okay.
60. Now I will widen it a little bit. No, drill. See the cell.
Yes.
Okay.
See that cell?
Yes.
And you're still with the 0 degree.
All the time. I never change the telescope. See, with a 0 degree.
He is coming from the opposite side.
Yeah,
That's why we are
coming
having
from the opposite side. This is hemilothrop.
Yes.
0 degree and right. We have many times, me and Gaurav published a paper, Gaurav ossifying fibroma.
Okay.
From here we reach to the pterion, the farthermost outer limit of the cranium.
Oh.
From here, right to the pterion further. See this? Beyond would be the pterion.
Yes.
Now some little bit of the draining left.
Please let us see from the outside also how much, which portion, where
Yes, sir. We want to see the
external picture.
I think as you stressed, Satish, navigation will exactly tell where you are.
Pardon? Yeah. Just a minute, Madhu.
No problem. Sorry.
Just a minute. Yes, I will tell. Changing to the drill.
Okay.
Bol. Come on. चलो हुआ हो गया Can you see now?
Yes.
See the lateral most part.
Yes.
I am flushing with a cutting burr.
Because this is having more angulation, you have changed this.
Yeah, this is longer tip, little longer tip.
Little
see the last cell.
Yes.
And that is the cell in the base. See now?
Base, yes.
All communicated.
Yes.
Right.
See now?
Yes.
This was the cell which opened in the orbital roof. See, this is orbital roof.
Yes.
Right.
This is medial wall here. That is roof. The entire 1 centimeter bone now you can see, which was earlier there, is gone.
Yes.
Remember, I told you I will drill that 1 centimeter bone. Completely gone. See that?
Yeah.
And now that is the lateral limit of the sinus, and that was the cell. See the inferior most and the lateral most, which was not draining. Now see, see the most lateral aspect of the frontal sinus there. Can you see the cell?
Yes.
And that is the most inferior artery.
Yes.
So now it has given a permanent drainage to this cell, you know.
Yes.
The same protocol had to be followed. Same protocol had to be followed of irrigation, little bit widening further.
Any role of absorbable nasopore with antibiotic soak?
Pardon?
Packing this cavity with absorbable nasopore.
Not really.
Okay.
Why absorbable? See, these cavities generally do not need any packing for that matter.
Yes.
We want the drainage.
Yes.
Now I will show you the final picture. Can you see?
Yeah.
Oh my God. See, this much of the work is required in such a case. Where we started off with a very narrow opening.
Yeah, hardly 1.23 millimeters. Now it's more than 1 centimeter.
Yes, more than 2 centimeter, I think. See this? I removed this low upper part of the middle turbinate. You see that?
Yes.
I mentioned in the beginning so that it doesn't come in our way.
Yes.
That is the area of our first olfactory neuron.
Yes.
See this? It will remain like this.
Yes.
And that area below is the olfactory recess. See that?
Oh,
olfactory area.
Yes.
And this is our now complete drainage. See, from here to here, this is more than 2 centimeter. See, coming from opposite side, you know. And that is the, give me this angle telescope now to show you the interior of the cell. Okay.
So Dr. Jeevan Vedi from Nagpur is asking, is there any role of repeated balloon sinuplasty in such cases?
No way. No way. See, how will you access with such a thick bone? See how much thick bone I have drilled away. What will balloon do?
Yes, sir.
Reaching to the area of interest is such a huge task. Now see with a 70 degree. 70 degree up.
Yeah, yes. Now we can able to see the lower opening of that defect.
Let me show you. See with 70 degree now from upside down. See that?
Yeah. Beautiful.
That is the most lateral inferior part of the frontal sinus cell. And that is the beauty of this approach.
Yes.
See this? This cell. Can you see?
Yes.
This is orbital transposition. See the big opening.
Yeah.
See my limits of the Lothrop is 70 degree now. Since this was not a very big sinus section. See, this was the outer skin here.
Yes.
We went in with the outer skin, following this outer skin up.
Yes.
This is the outer skin everywhere. Outer skin means there should not be any thick bone left beside this outer skin to give the widest possible.
Yes.
We could not give bigger than this because that is the anatomy.
Yes.
See, we reach right to the limit of the outer skin. This is midline, this is anteriorly, this is laterally, and this is the posterior table. That is the region of the, I can reduce this little bit more, you know.
Is this a 4 mm suction cannula?
Yes.
So almost you are having 5 times, 2 centimeters.
1, 2, 3, 4, 5, 6, more than 2 centimeter, man.
Yeah, that's what I.
And this is roughly 1 centimeter.
Yes.
See that? And that is the final opening. Now what all you can do if you want me, I can widen the anterior posterior little bit more.
A small projection.
I'm back with 0 degree.
9 o'clock position.
Yes. Back with 0 degree. Then.
Yeah, this projection. Yes.
Yes. And we'll irrigate, you know, with the solution thoroughly so it doesn't lead to new osteogenesis. कुछ नहीं कर पाएगा.
Satish,
yeah,
can we put a nasal feeding tube and somehow stabilize and use it for regular irrigation post-op?
Pardon?
Through nasal cavity, through nasal cavity.
Boss, we have done so many. Believe me, what all they need?
Yes.
The patient to be trained with the irrigation, the positions.
Yes. Yes.
We train them lying head back position or prayer position, namaz position. They do so well and it never gives a problem.
Okay. I think you have to show us that position post-op.
See, there is a picture with a 0 degree now.
Beautiful. That projection is also now shaved off, right?
Now, whatever this, periorbita, I will further. This is to give little bit of scarring, stiffen it. See that?
Yes.
And that is the real story. This was the cell which was breaking through. Yeah, remove. And now it's completely marsupialized. I don't think this patient will come back with this blockage again. See, huge opening. We'll just do the irrigation in the nose and come out. Excellent camera. So this was all about this. Opposite. Yes. So, any questions here?
Is there any defect in the periorbiter with any orbital entry of pus in this case?
Pardon?
There's a question from Dr. Ahmed from Guwahati. Is there any defect in the periorbiter with any orbital entry of pus in this case?
Periorbiter, defect in the periorbiter?
With any orbital entry of pus in this case. Externally, maybe they are asking about the communication.
No, it was outside the periorbita.
Okay.
It is always outside the periorbita. It is the frontal floor which goes off. And the moment it opens, it sucks out. The content sucks in.
Okay.
So, this was about something on this case.
In need of leaving a stent, sir?
Huh?
Stent?
No. You have given more than 2 centimeter opening. What will stent do? What all it needs is mucosalization now. That's it.
Yes.
And for that,
Satish,
yeah.
Can you show that position for irrigation, patient education counseling?
Okay. Let me show you.
How he should lie down.
I have to
give antibiotic irrigation in this patient.
I will show you Madhu from one of my presentations.
Okay, no problem.
I will show you, definitely.
As Satish says, role of antibiotics is very minimal, maybe about 1 week.
Few days.
To prevent secondary.
What I'm asking is about antibiotic irrigation.
If there is associated infection, if you find, you can add on. But generally, whatever broad spectrum antibiotic and steroid irrigation. That is the main thing, because steroid is here required to prevent the inflammatory response leading to neoosteogenesis. What all we need to prevent now is neoosteogenesis, because a lot of raw areas left behind, and it generally heals well if the irrigation is good.
Yeah, infection is mainly because by the commensals existing in the nose only.
Yes.
Because of the stagnation.
Yes. Now see this next patient. Can we go ahead?
Yeah, please.
Yes, sir.
This patient, is an interesting one. Let me laptop connect karo.
Sir, Dr. C.S. Tingley from Gulbarga was requesting again and again to show all the draft procedures. I think we have already discussed in the
cadaver also.
Yeah, in the cadaveric dissections, we have it on the YouTube. You can go through. And in future, if we have such cases again, I think so we'll discuss it again in detail, because we have more cases lined up today.
Yeah. So as and when we'll keep on posting variety of such cases.
Yes, sir.
Now, are you getting the scan?
We're getting the
This patient came with a unilateral nasal discharge of the right side. See, interesting. On the CT scan, what she got done, see, I am going behind. I am going behind, so far absolutely normal.
Yeah.
And what you find then behind is a unilateral opacity of the sphenoid sinus. We see all walls intact. See carefully. See carefully. Little bit of the here, something like that. Otherwise, all walls intact. Can you see by and large?
Yes.
What will you think of?
Mild thinning there.
Related sinusitis.
Huh? Yeah, one is sinusitis, other is CSF leak, obviously.
CSF leak, CSF leak.
Now you see the coronal, yeah, the sagittal you can take. See this.
There's a ONOD as well.
Yeah. See, by and large, you don't find anything. Micro dehiscences you cannot make out on CT scan.
Yes.
Then this patient was subjected to
CT cysternography.
4 times.
4 times.
She got CT cystonogram. We have pictures. We don't have, because we don't get done. She got outside done.
Okay.
4 times, but didn't reveal anything. Then the MR cystonogram. See now. Now see the interesting story.
Yes.
I told you radiology is something which is game changing. Yeah, it is opening. Now see, an MR cystonogram. What is MR cystonogram? Whereas the background is, suppressed and the CSF is prominent. The signal of the CSF, bright signal, against the suppressed background, so you can pick up the defect. Now in MR cystonogram, it is same like CT cystonogram, no difference. Only thing is, it doesn't require a dye which need to be injected in CT cystonogram. And that to an iodinated contrast.
Without any dye?
MR cystonogram, no dye. It is simply heavily T2 weighted images or 3D cis images.
Okay.
So, what you find here, the fluid means absolute bright.
Right.
And if both in CT and MR cystonogram, try to understand this fact. This will pick up the site of defect if at the time of scanning, patient has an active leak. Got my point?
Okay.
Otherwise,
Understood.
what will happen? See this. Am I going behind? Can you see something in the sphenoid?
Yeah.
Again, how will you differentiate it from a mucocele and a CSF leak?
Because it's equal to the CSF brightness.
But,
Mucocele shadow will be
there
different.
has to be some continuity. It could be a simple fluid also in the sphenoid.
Yes.
How will you differentiate this as a simple sinusitis from the CSF leak? No way. Unless I find a direct communication from here to here. Okay? Which we didn't find even on the MR cysternography. Same is the problem with CT cystonogram. CT and MR cystonogram will pick up, like in CT cystonogram, at the time of, scanning, if the patient has active leak, then whatever dye you inject in the interthecal space in CT cystonogram will appear in the extracranial space, and that you pick up on CT scan. First of all, that is the iodinated contrast with lot of side effects. Second, you literally have to make patient prone upside down with the head down to allow the dye to accumulate in the basal cistern. Third is the CT is a, radiation. And third is that dye doesn't remain in intrathecal space for long. And it doesn't accumulate so nicely, clearly in the basal cistern. So now see on the coronal as well. It's the same MR cystonogram. See this? This patient has a sign of high intracranial pressure because you see this empty cella. But you don't see any communication. What's my point?
There is a
It's still the same thing and it is not resolving what exactly it is. Then we got a T1 weighted image before contrast. Now is the time in this difficult situation of a gadolinium enhanced intrathecal gadolinium enhanced MR cystoscopy. Okay?
Yes. Yes, sir.
There, in place of the iodinated contrast like you place in CT cystogram, here we put a gadolinium which is much freely diffusing in the intrathecal space, number one. It stays for more than 24 hours. And since you have to pick up the dye coming extracranial, so you can keep on repeating, you know, as the dye is there for 24 hours, you can keep on repeating MRI till 24 hours, and since it is radiation free, no hazard to the patient, except the cost.
Yes,
except the cost, there is no hazard. But now you have an opportunity to pick up that dye for 24 hours, you know. In CT cystogram, it washes out so easily. On plain T1, absolutely dark. Now after gadolinium, see this gadolinium stent CSF. Okay? What you see, this is gadolinium stent CSF. Now what you need to pick up, that gadolinium stent CSF coming down in the sinus. That too with a tract to substantiate your diagnosis. Now, this is after the third MRI after the gadolinium. Initial 2 MRI couldn't pick up. 2 hours after that, 4 hours after the gadolinium, and this is, you know, gadolinium diffuses in the intrathecal space in 10 minutes. If there is an active leak at the time, 10 minutes after the injection and you take MRI, you can pick up. But since it was a difficult leak, it was not showing. This was after the third injection, and now see what is happening. Now, see, we saw the pre-contrast and there was no dye, nothing below. Absolutely dark. Now with contrast, you see the contrast flowing in the CSF space. And now see the contrast coming down. Can you see the contrast coming down?
Yes, sir.
How will it come down unless there is a defect? How will the contrast come down unless there is a defect? Because this is not T2 weighted image. This is T1 weighted. In T2 weighted, the fluid will appear bright.
Yes,
this is T1 weighted contrast. A simple fluid will not appear bright. What my point? A simple fluid on contrast imaging on T1 will appear dark. Now see the same consistency of the gadolinium after the third MRI. After the injection of gadolinium, this is the third MRI, and now it has showed the accumulation in the sphenoid. And see where.
Yes.
All these 3 are done within 24 hours.
Yes, sir.
Okay. Hello?
Hello?
Is my voice audible?
Yes, your voice is audible, Dr. Madhusudan, sir.
That means all these 3 MRI scans are done within 24 hours.
Within 24 hours, yes. Okay, because the gadolinium stays in the intrathecal space
for 24 hours.
Yes, for more than 24 hours. And there is no radiation hazard, as he mentioned.
Yes.
And it also... Hello, Satish sir? There has been
there is some block in the transmission also, Paramita.
Yes. And while discussing it last time, he had also said that this dissolves in the CSF space easily.
But getting an idea to take 3 MRI scans or necessary 4 scans in the same day, it's really a brilliant idea. It's not that simple to get that even that idea.
Madhu, can you hear me?
Yeah, now there was some transmission block.
Now is it clear?
Yes.
Now what I want to say, after the first gadolinium injection, 2 hours after the first gadolinium injection, we found the same, this dye in the intrathecal space, but nothing below, absolutely nothing. The dye was not coming out because at the time of scanning, there was no active leak. Got my point?
Yes. What I would like to say, at this stage, most of the surgeons or radiologists will stop But why you have insisted for 3 scans? I mean, you are suspecting.
That is the value for all these difficult, leaks.
That's what I am telling. The credit.
Gadolinium enhanced intrathecal MRI, intrathecal gadolinium enhanced. So after the second MRI, again it was blank. There was nothing.
Yes.
Yeah.
After the third one, when the leak was there at that time of scanning, we found the gadolinium coming out of the intracranial space, and this was the site of communication. See this?
Yes.
It was the empty sala and it has given away, and this side of the sphenoid sinus was full of contrast.
Yes,
now this contrast which we injected in the intrathecal space and coming out in the sphenoid sinus, what does it mean?
It is having a communication.
Yes. Because try to understand, because on the plain MR cysternography it was appearing bright.
Yes.
Because that was plain. Now after the contrast, T1 contrast, if there is a simple fluid in the sphenoid sinus, it will not appear bright.
Yes.
Only the contrast stained fluid will appear bright. Got my point?
Right.
Those who have a slightest doubt can confirm. If some people are sick, they don't want to understand the value of this MRI. God bless them. I have no words. Only thing they need to understand the value, the science, how this gadolinium enhanced MRI has come, the enhanced CSF has come with this continuity coming from here. Can you see?
Yes.
Now I will reconstruct in 3 planes. See this. See this. Let me. Can you see this area?
Yes.
And if I bring my cursor, you can see everywhere the communication. See in the axial plane. Can you see this communication?
Yes.
Yes.
See this communication? And now if I show this communication, you can see in the coronal plane as well. See in the coronal plane this communication. See this? This is the sella, and this is the communication, how it has filled up from the sella. If anybody has a slightest doubt, can come forward.
Yes, sir. I think it's clear, sir.
Satish,
if still somebody doesn't want to understand, God bless them.
No.
This is such an important investigation.
Yes.
Believe me.
Satish, what is your take-home message in such suspected cases? Means gadolinium cysternography.
Yes.
And we have to search
the problem, Madhu, why the problem arise?
Yes.
You have a leak.
Yes.
It is not continuous. Otherwise, if it is continuous, you do any MR cysternogram, you will find in continuity.
Yes.
Like our next CSF leak today, as a cribiform leak, we did a simple MR cysternography, non-invasive, and we found in continuity the CSF. Why do you need all this?
Yes.
Now, but that can pick up only if at the time of scanning, the CSF is coming out.
Yes.
At that point of time. Now, in situation when there is intermittent leak, I find such lot of situation in my practice when the patient say, I had a leak last week, then this week I got up in the morning, 2 consecutive days I had a leak from the right nose. He got the very small leak, got the CT done, the MR cysternogram. At that time of scanning there was nothing. Now if you ignore a skull base defect, there is always a possibility of meningitis.
Yes.
Secondly, such situations come post-operative. You have done some skull base surgery. As patient comes post-operatively with this complaint of an intermittent small leak on one side, you put your endoscope, you see everything, you have done a good reconstruction and don't find anything. Now the CT scan has no value because you have done a reconstruction of the skull base. You get MR cysternogram, CT cysternogram. At the time of scanning, if there is a leak, you will find out. If it is a small intermittent which is missed at the time of scanning, again there is negative. And what you will say to a patient, once you operated, nothing was, I told you, there is nothing. But the patient is still at the risk of meningitis. We get so many such patients from the neurosurgeons, from our colleagues, wherein it is difficult to establish a leak. Now, to establish the leak, we need certain investigation which can pick up intermittent leak. Intermittent leak means the best is like CT cystinogram, you inject the dye and it should come out. It looks fascinating. But how many times you can repeat CT scan? That is hazard, radiation hazard. Other thing about the CT scan is, for the CT scan you have to put an iodinated contrast. That doesn't diffuse so freely in the basal cistern. And it has a lot of, incidents of reaction. You go to the literature, even the deaths reported with the CT cystonogram. I have seen patients having convulsions.
Yes, we have also experienced.
Yeah, so that is never safe. Gadolinium is ultra safe. It remains in CSF space for 24 hours.
Yes.
Since MRI is radiation free, you can repeat during that 24 hours again and again.
Yes.
If the patient passes that repeated MRI 24 hours with a gadolinium in the intracerebral space, intracranial space, and yet you don't see any dye coming out after 24 hours with repeated MRI, you can label as no CSF leak. What I believe, this is the strongest investigation on the planet you can think of.
The ultimate take home message: intermittent, inconsistent CSF leak suspicion.
Yes.
Best is gadolinium.
Suspicious, difficult. Yes.
Do 2 or 3 MRIs, no radiation exposure, and certainly you will find if there is a leak, the same contrast brightness will be seen. Very good message, Satish. Very nice.
That is the thing. Now, somebody will come. I tell you the exceptions. Why people are not accepting. Somebody will come. I got a CT cystonogram and I found the leak. Good. You can find the same leak if you find on CT cystonogram. Because at the time of scanning, the leak was there. I could have found on the MR cystonogram without giving the dye. Why the hell you are giving the dye to the patient?
Yes.
You could have get the leak on the MR cystonogram as well without the need of injecting the dye if the leak is there at the time of scanning. Got my point?
Yes.
Sir, Satish sir, there is a coming a black, sir.
Pardon?
It's coming a black, sir. Black RI, sir.
No, there is a transmission.
Oh, no. I am getting the CT.
Sir is operating his laptop. Don't worry. Now.
So the bottom line is, we have to understand the science and follow it.
Yes.
We have so many cases we have established the leak. So many cases we have ruled out the leak on the basis of this investigation. You go to literature, I can give you 20 publications. What I am saying is pure evidence based.
Yes.
If somebody accepts or not, it is his problem. But that is absolutely non-scientific. No words.
But regarding CSF leak, today is an ultimate take-home message, Satish. Very nice. I think most of the people who are observing must got the message what Satish is giving.
The next leak, the next case CSF leak is a straightforward. We got MR cystonogram and showed the leak. Why to subject that patient to CT cystonogram with the invasive investigation?
Yes.
So in the present context, if you go evidence based, there is no role of CT cystonogram. It's been almost 8 years for me to get any CT cystonogram done. And I will never.
Yes, sir.
If I can get a leak on CT cystonogram, I can get on MR cystonogram as well. As simple as that. Without injecting the dye.
Yes.
If I can't get, then I have to go with this.
Okay. Yes, sir.
But how many radiologists are aware of this fact, Satish?
My radiologist is very well. I have, hours and hours of session with my radiologist.
That's where the counseling, the bridge between the surgeon and the
He was not believing in the beginning, then I provided him some articles.
Okay.
Then first time he injected on my request.
Oh.
And then we found the result. He was happy. I gave him number of publications. He confirmed. He did, and now this has been a standard investigation for us.
So your first investigation for suspected CSF leak is MR cysternography.
Yes.
MRI.
Both a CT scan, simple HRCT.
Okay.
Because if there is an obvious bone defect, you can get. See, sometimes it is a straightforward situation, Madhu. It's not always. A patient come to you with a road traffic accident.
Okay.
And coming with a unilateral right-sided nasal discharge.
Okay.
You get a CT scan done and you find a defect in the cribriform roof.
So
what else you need?
Yes.
What else you need?
Yes.
Not even MR cystonogram. It is so obvious.
Yes.
So in 80% cases we get this.
Yes. So it is not always the MR cystonogram is needed.
Yes.
Do not know where is
Sometimes there is a defect. Suppose you are suspecting a defect, and in that region, in the ethmoidal cells, some opacity,
Yeah.
There could be some sinusitis, and that defect could be the old one with fibrosis.
Okay.
So to confirm now whether it is a leak which is filling up the ethmoidal cell, now you need MR cystonogram. That will show you in continuity the CSF space in continuity with that cell. That is the need of MR cystonogram. See, every investigation has a value. It's not that all of a sudden you order all the investigation at the same time. When to get CT, when to get MR cystonogram, when to get gadolinium enhanced. They have their own indications, not all at the same time.
What are the presenting symptom in this case? How we present it?
Unilateral nasal discharge.
Because sphenoid, usually we have a post-nasal drips and sort of post-nasal drip life.
Yes, if he has a strong history, something coming in the throat for long.
Yeah, post-nasal drip like that.
Yeah.
Satish, what is your opinion on multiple anatomical site leaks?
Multiple, yes. That happens in the situation of high pressure.
Okay.
In high pressure, the CSF leak is many a time a manifestation of high pressure. In a closed cavity like brain, if the pressure is, building up, where it has to give way someplace. And the weakest place is going to go. That's how they present, and the pressure is normalized. In this patient also, see all the signs of high pressure. See this, I will show you. This is important question.
High pressure?
This is important question, Madhu, you raised.
Yes.
All the signs of high pressure. Number one.
Yes.
Number one, see the optic nerve sheath. Can you see, everybody?
Yeah. Yes.
See, the optic nerve is carrying all the three layers till the sclera, till the globe. Not sclera, till the globe.
Yes.
And see, if there is a high pressure in the brain, this sheath is extended with the fluid.
Oh. Okay.
That is a classical thing of high pressure. I will show you certain more signs. Now, as you go behind, see the empty sella.
Yes, sir.
Yes.
That you can see best. What is empty sella? Because of the high pressure, see this. This arachnoid is prolapsing in the sella, and sella is pushed behind as a very small structure, and the entire sella is replaced by arachnoid pouch. Because of the ongoing high pressure. Got my point?
Yes, sir. Yes, sir.
Now,
so this is usually seen in high pressure because arachnoid herniation because of high pressure.
Yes. So yes, empty.
Yes, arachnoid herniation into the sella through the diaphragm.
Yeah.
Through the diaphragm.
Yes. So
Now see.
Yes, sir.
What is this? This is enlarged Michel's cave. Can you see?
Yes, sir.
These are Michel's cave because this is a CSF containing space, and because of the high pressure, they enlarge. Now see the optic nerve sheaths on both sides.
Okay.
See this tortuous optic nerves.
Wow.
Why tortuous? This distance from the posterior surface of the globe to the apex is actually much more than the distance. This distance could be 27 millimeter, but the distance is much more. The length of the optic nerve is much more. So what happens? When the fluid is there in the sheath, it gets elongated and tortuous. That is classical of high pressure. And if you see the coronal section, I will show you. If you see the coronal section, see this coronal section, you will see this vertical buckling of the optic nerve because of the high pressure. See this? This buckling. Because of the high pressure, the sheath is tortuous.
Yes. Otherwise, it will be
sometimes it pushes the globe from behind. Pushes. That is protrusion into the optic nerve head. So all these are signs of high pressure, and this is important to know, like in this patient as well. We always counsel these patients, this is the manifestation of high pressure. This is not your primary disease. But since this is a defect in the skull base, it needs to be repaired on priority to prevent meningitis. The moment we repair, until now, this leak is working as a wall to relieve the pressure.
So then,
moment we close this leak, again the pressure may build up.
Okay, so then post-operatively, will you keep a lumbar drain? So post-operatively, will you keep a lumbar drain?
No, I will tell that. Is the case ready? I will tell the protocol. Let's go ahead with the case. I will tell you the post-operative protocol and the management of the high pressure.
And so one more thing, use of fluorescein, as you had last time said that it is banned in India anyway. So can we use topical fluorescein?
Yes, topical is very good. If anywhere the CSF is coming, you take the topical there, it will turn the yellowish green. It is a brown material, it will turn yellowish green, and that is a sign of, confirm the diagnosis of CSF.
I mean, intranasally just application.
Yes, intranasal application is very safe. You can borrow from your ophthalmic friends.
Okay.
Okay, sir.
Okay. So
that will
let's go ahead with this case. Let's go ahead with this case. Meantime, you carry on questions. Our next case is also being induced, and that is a microscopic submandibular gland excision, and then the rest two cases will come on.
So wonderful radiological knowledge you have given.
Yes. Dr. Vivek Agarwal from Guwahati is saying he is a Sherlock Holmes of ENT. Satish sir?
Yes.
Sir, there are few requests for me that I can share your email ID. So can I do that?
Yes.
With your permission.
Yes, please.
Okay.
No issues.
So there's a question of Dr. Abhilash Alex from Calicut is asking, what if it was a vascular malformation of sphenoid sinus with secretions?
What is?
What if it was a vascular malformation of sphenoid sinus with secretions?
Vascular malformation will always enhance, Vascular malformation will not be so bright of the same intensity like CSF on MRI, T2 weighted. Vascular malformation will show, what you call that salt and pepper appearance, not like a plain fluid-like appearance on T2 weighted MRI.
Okay, sir.
For last 2-3 days, I asked this patient, there was no leak. I said fluid is coming. Day before she said little bit, today not.
Okay.
Now see the story which I am going to uncover. So now the area of interest is right sphenoid sinus. Okay. See this, the area of the ostium.
Right.
Area of interest is the right sphenoid sinus. So first of all, my axis. And see the biggest problem in the axis on in this side is the middle turbinate. See this?
Yes, sir.
So I will trim this side middle turbinate, the lower part, the interior part, to give me additional access to park my endoscope and for instrumentation. Secondly, I will raise a rescue Huddard flap. Rescue means in case needed I will use. Okay? Because that has to be raised before by means of preserving the pedicles. Otherwise, while doing sphenoidotomy, you may injure the pedicle and then you can't use it.
Okay.
Number 2. Number 3, if I find that I am able to remove the entire sphenoid mucosa, if I can ensure when the sphenoid is not very big, not very something like compartmentalized with a lot of recesses, I can remove the mucosa completely. And that is the boom, then you can obliterate it. That is the additional security. But that is possible only I do in very few cases unless I am 100% sure that I have removed the mucosa completely.
Not very safe actually.
Yes. So this is how you have to plan. Otherwise we'll do a standard multi-layer repair.
The most common site of CSF leak in sphenoid actually.
Pardon?
It is the most common site of CSF leak in sphenoid sinus.
This one?
No, most common site otherwise.
Otherwise mostly in the lateral recess.
Yeah, lateral recess is the most common site.
We'll keep a case of lateral recess next week. So that will cover our CSF series, you know.
Yes, yes.
First case we demonstrated was, the meningoencephalocele. Then this is sphenoid from the sella. Then the third one would be from the cribriform now. And the fourth one would be from the lateral recess to complete this series of CSF.
That is the most awaited site actually. People want to see that site.
Sir, while you were operating on JNA, there was a very interesting question which I did not ask you that time. Dr. Ravindra Bansal from Gwalior wants to know how you control your anger over staff at this type of condition.
How you?
Control your anger over staff at this type of condition while you were operating on JNA. It was a very interesting question which he had asked.
For that you have to come to theatre.
Carotid suturing. That was the main time. That most patients require the carotid repair.
So boss, for that you have to come to theatre.
He should be, his staff should be awarded with so many gifts and so many prizes.
See now, the staff and my assistant who is assisting me, he has assisted me in almost 50,000 procedures, you know.
Just tell the name of your...
He is with me for last 20 years.
My God.
He knows my moves. He knows my each and every move.
Yeah, we could see on that day, carotid repair, he just came with the within millisecond with the...
If I don't put the suture in time, he will put the suture.
Who is he? Who is he?
You know.
I know.
No, it's a teamwork.
It is teamwork.
Yes.
Teamwork.
See now I have taken this anterior part of the turbinate. I am just simply, my final plan will be after I open up the sphenoid.
Yes.
The first thing is the axis. In any skull-based surgery, whatever you do, you know, it is the exposure, axis which are most important things. See, every time I don't remove the endoscope out, he will immediately push the saline.
Yes. So Dr. Sandeep Karmarkar has sent a message to you, absolutely magnum. Satish Boss is an absolute and thorough ENT scientist with a mind like an encyclopedia. These webinars are becoming an international rage much more than Netflix and Amazon.
Netflix.
Yeah. And also to everyone who is asking for the email ID, it is jainsatish3@gmail.com. Sir, actually many have started operating, many want to discuss these cases with you, so for them it will be very beneficial.
Yes, feel free.
So that
I feel happy somebody is calling in the middle of the case, he is stuck, I will be happy to help you out if I can.
Yeah.
No issues.
Yeah, so it is jainsatish3@gmail.com.
Have you come across the Sternberg canal, that is CSF leak cases?
That is again a big, myth. You rarely find a Sternberg canal, leak. It's a fascinating name, and a lot of people have published in the name of Sternberg canal. That is actually not the Sternberg canal.
Put some light on that.
That is the lateral craniopharyngeal canal.
Yeah.
Can you see the leak here?
Yeah.
See this?
Yes, sir. Yes, yes.
Man, see the leak.
Yes.
See what is gadolinium enhanced MRI.
At 11 o'clock position. 10 and 11 o'clock.
Almost close to 12.
Yeah.
Yeah, that is the leak. See this, I will show you.
Yes.
What an interesting, straightforward. The misdiagnoses are so common, that's why I always emphasize on radiology.
Sir, in the previous case, how will you address the septal window? Many have asked this question.
Many a times we don't, and it is not symptomatic. In case required, you may have to just mobilize advance the rest of the septal flap, easily. Easily, it's not difficult.
Okay.
We'll keep a case of, for everyone, I have so many people who have asked me, and next week or so we'll keep a case of septal perforation closure, endoscopically.
Very useful, Satish. Don't miss that.
Yeah. I will definitely keep, and I will keep two cases, one endoscopically and one by open rhinoplasty approach.
Sir, Dr. Dhirendra from New Delhi is asking, with all these efforts, still what if we don't find the site of leak? And if it is confirmed that it's a CSF, then what will you do?
See this? See the site of leak here?
Yes.
Yes.
See this?
Yes.
That is exactly where I showed you on 3-dimensional MRI.
Yes.
From the antero-inferior part of the sella. See that?
Yes.
This is typically where the leak is coming. See this? See this?
Yes.
Very obvious?
Very obvious. Will this not close if you concentrate on reducing the intracranial tension or?
Pardon?
Do these leaks get closed spontaneously if you concentrate on reducing the intracranial pressure?
I didn't get your question. For these spontaneous leaks.
No. Can these leaks be closed? Can they close on their own spontaneously? If you reduce
No. That can happen, Madhu, with the fresh leaks.
Okay.
Like, I give you an example. We have many patients referred by neuro people. The patient met with an accident and started leaking. That is a fresh leak. What you do in order to enhance the healing, sometimes they settle down on their own, but not all. What you can do, you just put a lumbar drain to divert the CSF and they heal very fast. Because they are fresh, traumatic, small leaks, you divert, just lumbar drain is the answer. That's it. Without doing anything, because those are fresh leaks. See, this is my leak.
So, in this particular case, the root cause is benign raised intracranial pressure.
Yes, 100%.
So, what is the
you have all the signs of benign intracranial hypertension. See this?
I understood. But the root cause we are not attending. You are closing the leak now here. The pressure is still continuing. It can be
See this leak?
Yes.
Arachnoid pouch?
Yes.
Couch section. Now this sphenoid is so big. See this?
Yes.
Now if I try, I told you, if I try of something like demucosalizing the entire sphenoid, It is too big. See this?
Yes.
Not recommended here.
And it is, traumatic. The reason is I don't know the optic carotid. I have to bring out from everywhere. The mucosa, and if somebody is doing, may traumatize the optic nerve or carotid. That is number one. If you are good, you may avoid traumatization, but this is too big a sphenoid. For a smaller one, you can think of. See the CSF?
Yes.
See the arachnoid pouch coming?
Yes.
Yes, said that, no? And now what I am going to do? No. Straight section.
Sir, so here the question of Dr. Madhusudan Rao, which is there, that what are we doing for the raised intracranial pressure? Because what if this
see this arachnoid pouch? See this arachnoid? No. See this arachnoid and the CSF coming?
Yeah. Very clearly the droplet is seen coming down.
So now the closure is very simple. Uday.
We not lumbar drain in this case because we have.
Now our protocol, like what Paramita asked about the post-operative or the high pressure management. Carison.
Yes. That's what I am asking. We have to tackle the root cause.
So now what is our protocol? Let me tell you, standard one.
Okay.
Number one, since this until now was a leak with a high pressure, and the pressure was neutralized or maintained by this leak only. Now the moment this CSF, the CSF dynamics, we have a total volume of CSF around 150 ml.
So here you can just explain the step first, what you are doing.
I am removing the surrounding bone
with
the small Carison punch.
Yes.
In order to expose the leak better. This is overhanging bone I am removing. My leak will be stopped with the cobbletter only, I tell you in advance.
Yeah, that's true.
My leak will stop most likely with the cobbletter only. Give me. See this.
I think bipolar is one more better, I think, option over here.
Let's see. Give me the drill also. Drill ready. I will use the drill also to flatten this bone,
Achievement is in the diagnosis. Many lesser models would have just let the case go.
Pardon?
Volume, please, volume.
People would have just given up after one or two investigations, thinking that this is not a CSF leak. It is so good that you have persisted and insisted on the repeated scans, repeated MRI scans. Because otherwise, many people would have missed it.
This can be easily missed. See now with the drill what I am doing. Flattening the surface, Come rak. See, all overhangs I am removing at a very controlled speed under high magnification, and see the bony defect now. Can you see the bony defect now?
Yes.
Hello?
Yes,
sir. Yes.
What you were finding there was a mucosal tube.
Yes.
What was that? It's a submucosal tube, And this is the bony defect. Is Ashish Bhumkar there? The same leak I did at Ashish's place, that was little lower down from the clivus. And the same story was there. The leak was obvious, but when you started operating that was a tube, and the bony defect was farther from the area where the tube was. See, this is the commonest mistake people can do. This is not for here. Anywhere, if you are operating on a CSF leak, always go to the level of the bony defect. Not the mucosal defect. That will not allow you to seal the bony defect.
But here the bony defect is very small.
Yeah, that's why. See this?
Yeah. Hardly 1 millimeter
Madhu,
or 2 millimeters.
this is classical with the high pressure leaks. The defects are always smaller.
Okay.
Our next patient has a cribiform leak spontaneous. That is again high pressure. High pressure leaks are mostly smaller defects with meningocele coming out.
Okay.
See this defect? Now the entire science of this surgery is all about exposure. Closure is same like any other leak. It is so simple. That's my point.
Yes, sir.
But exposure is more important.
Now see, there is nothing in the closure. The simplest of the leak one can think of, you know, it is all about exposure. And you will see, I will show in the cribiform leak what kind of exposure is needed. Once you expose properly, then closure is the child's play, I tell you. See the bony defect. I hope it is clear to everyone.
Yes, sir.
Sir, can you just put a ball point near that leak?
Yes. Ball probe.
Ball probe, see the measurement. Ball probe is usually 2 millimeters or 1.5 millimeters. Ball
To gauge the size of the leak, you mean, sir?
Yeah.
See this? Madhu, this is the defect.
Yeah, very nice. Beautiful demo.
See that?
Yeah.
Yes, sir.
So now this, I am going to close it. Next case ready. Next case is ready. So this is going to be over. Now what I am going to use? The glue there. Fisher. Okay. So what I am going to use? See, I am going to use first layer as the fat which is soaked in rifampicin.
Why?
Huh?
Why rifampicin soap?
Rifampicin is the best, anti-staphylococcal agent, which is required to prevent this airborne infection in the fat. Because if this fat get infected, it is a disaster.
So every time if you use a fat for closure of any
always,
defect,
you always see me,
rifampicin.
Always.
No, you get rifampicin in the form of capsule.
Yeah, what we do?
Yes.
We take like 5 to 6 ml of this thing. Saline.
Okay.
And take 1500 milligram of rifampicin. 6 ml, then you can take 6 or 7. That's 3 capsules of 600 milligram, 1800.
Yes.
So coming around 250 to 300 milligram per ml.
Yes.
And then soak this, in this solution. And then I will wrap this rifampicin, this fat, I will wrap this in the surgicel.
Oh, you again wrap it in surgicel.
Yes, that is something. We are taking the side effect of the surgicel here as an advantage. Surgicel is known to induce fibrosis.
Yes, that is well understood. Surgicel.
Yeah, that is what we want here. See this.
Yes. Yes.
Secondly, this is too big. So that is too big. So what we want, if you try to push the fat here in this area, the fat is so soft, it is difficult to negotiate many a times.
Yes, or it may totally get escaped. But
Yes. Best is to wrap in surgicel. It gives you stability and then push in and push into the level that it should go half in, half out of the bony defect. To plug it.
Right.
To strongly plug it. It's too big.
Wormhole's bark plug technique like.
No, that is different. That you have to put a suture and pull it.
Yeah, that's a laborious process, but I also.
That is for a little bigger defect, not for this.
Yes, yes. So now you are putting surgicel soaked in rifampicin there with fat.
Yes.
It has come out, man. Sorry. Smaller the defect, bigger is the problem, I tell you.
Yeah. The same.
नहीं ये निकल गया इसमें से दूसरा दे
So, sir, what is the advantage of Surgicel you said with the fat?
First of all, the application of the fat is much easier.
Easier, okay.
With the Surgicel as a carrier along. And second thing, Surgicel induces fibrosis.
Yes.
Which we want here. See this, I am trying to put this half in, half out. See this?
Yeah.
It is self-retaining now.
Yeah,
See this?
The fat gone inside gets expanded.
Yeah, self-retaining, you know.
Yes. Yes.
This is self-retaining. See this? See this? Half in, half out.
Yes, sir.
Now see, it is self-retaining.
Yes, yes.
I have to ensure, give me Merocel. Smaller defects are notorious, you know. Sometimes you feel like you make bigger and then close it.
So fat was harvested from which side?
And sometimes in such difficult situation, you know, what happens? The muscle proves to be a better solution. Muscle gives a good scar. Give me other one.
So fat was harvested from which side?
Thigh. Always thigh. The thigh fat is more knitted than the abdominal fat.
And so for how long is the fat kept in rifampicin? For how long will you?
15 minutes.
Okay.
Submerged, totally submerged.
Okay. Leak is there. Still some leak is there.
Okay.
See what a difficult defect to pick up, a difficult defect to seal.
This is the best instrument for this.
Can we do bath plug in this case? If you have this doubt.
Pardon?
Can we do bath plug in this case? You just said some.
No, bath plug for you need to have a bigger defect. What is bath plug? Small. Then you have to pass a thread through it. You have to pass a thread through it.
That you need a
and
large.
Then the thread on the other side of the fat, intracranial side, and then you pull it, so it spreads the graft above.
Actually, the lobular fat is taken in a tubular form, and Warmold has the technique of passing through and pull it out, just like any wash bath plug.
Yes, now it
as Satish said, this is very small defect.
Yes.
Doesn't need.
See now it is sealed.
You put anything in the sphenoid sinus like.
Pardon?
You put anything now in the sphenoid sinus?
Yeah, I will press with the Merocel.
Merocel, that's what.
First of all, let me apply it tightly.
Right.
Curved
So
suction.
there's a question from Dr. Piyush Verma, Noida. He's asking, what about biochemistry
Curved
of
suction.
CSF?
What about?
Biochemistry for CSF, do you usually...
Yeah, if for your diagnosis, if you want to prove, yes.
Okay.
That means the CSF will be there to collect.
See now,
in a lake.
No more CSF?
Yes, perfect.
What I will do now, just press. Give me Surgicel. I told you, smaller the defect, more notorious they are.
Yeah.
For tissue glue?
See, once you find that it is sealed completely, see this?
Yes.
What I will do? I will pour a little bit of the tissue glue. See that?
Okay.
Yes.
Just to add on to the seal. Now, okay. A small fascia. See, I made the surroundings raw, if you remember.
Yes.
All around.
Denuclealization.
Yes. See, the only thing works in closing the leak, you know, is the straight the patla. The only thing works is the initial layer of fat, you know, nothing else. Only initial layer. Rest is all reinforcement.
Yes. So first you denuclealize the
See,
area.
what I am using, this fat, fascia or anything, is reinforcement. See, it has already closed.
Yes.
Okay. So now what I will do,
it's almost like 5 layer. First surgical, fat, surgical.
the initial layer of the fat provides fresh fibroblasts to the defect to seal.
Okay.
And this is the simplest of all the defects you can think of. Only thing, it is very small.
So pinna lobule fat is better than thigh fat? There's a question from Dr. Rajendra.
Pardon?
Is the pinna lobule fat better than thigh fat? Or Dr. Rajendra?
What?
Pinna lobule.
The adipose tissue from which area is better? Same?
No way. The best is the fat from the thigh. There are a lot of histological work has been done on this.
Yes.
And the thigh fat is more knitted. Understand? And it is
This
more
fascia is from where?
than the abdominal fat. And for this purpose, this is better than anywhere the fat in the body. See this on the raw area. So I created 1 centimeter raw area all around. So this is just to reinforce. See, all this is reinforcement. Whether you do or not is different thing. Always better to do. This is nothing, something which is going to be very, very crucial for the patient, you know.
This is abdominal fascia, Satish?
Thigh.
Thigh fascia, okay.
From abdomen, when you take the rectus sheath.
Rectus sheath.
See this?
Yes, sir.
And
so, which is the instrument that you used for pushing the fat? You used a probe?
This is a very special fine crocodile, the Glexley.
Okay.
Very fine.
Even
the same thing, the glue. The leak was stopped by the fat only. Yes. This is all, you know, reinforcement.
Satish, you soak even this fascia in rifampicin solution?
Yes.
Yeah.
Fascia as well?
Always better. Whatever you are using. So my first layer of antibiotic was rifampicin, number 1.
Yes.
On the fat and the fascia. Then the glue. And now what I am using, so that I can pack with my Merocell like this. This is the gel form. See now, the gel form has a value. Once it is, you know, once you swell the gel form with something, it takes up, it swells up more than 25 times of its volume. You see this?
Yes, sir.
And it gives a smooth, you know, compression.
Yes.
Smooth, even compression. And this is what I am using is the ciprofloxacin simple eye drops. This is again a different antibiotic.
Okay.
So many antibiotics. And now what I am using, since I will not remove whatever I have put so far, is all absorbable.
Yes, all are absorbable.
Now what I am putting, I have to keep it pressed with the, you know, Merocell. And I need to interpose something. My Merocell should not stick to the underlying things. Otherwise, while removing the Merocell, everything can pull out. See my Merocell? And I wrapped in the silastic.
Yes. Yes, sir.
See this? Now, this is going to press everything. Can you see?
Yeah. Beautiful.
Now, everything remains pressed for 3-4 days. Forget about it.
So, when do you remove the Merocell?
So, we will remove the Merocell and the silastic. Not behind. And see, this will give this will give smooth pressure. This will give
smooth pressure.
Yeah.
So when will you remove it?
After 4 days. Until then, the fat, fascia, everything will settle down.
Yes.
See now, smooth pressure it is going to give on the gel form. And that gel form will give smooth pressure over the rest of the layers on the fascia and the fat. And this gel form will remain pressed until outside. Can you see this?
Yes, sir.
So this will be from skull base to the interior layers, a complete assembly pressing on everything. We'll keep it pressed for 3-4 days, 4 days minimum. See this?
Yes, sir.
And that's it.
Okay. And you remove this Merocell with elastic sheet under endoscopy?
Yes. After 4 days. Now what our protocol is, we have to treat the high pressure as well. So we have to counsel these patients.
We are interested for that.
The closure of the leak, pressure, super dressing. Closure of the leak is one phenomena that is required. The most important then is the pressure management. Ready? Microscope. So now, what do we do? I told you the CSF volume is 150 ml.
Yes.
You घुमा दो यार इसको. Hello. CSF volume is 150 ml.
Yes, sir.
And the CSF circulation per day is around 500 ml. So in 24 hours time, the CSF circulates more than 3 times of its volume.
Okay.
Now with the persistent leak where the CSF is depleted, after the sealing we give 24 hours time for the CSF volume to be replenished, the normal physiology to establish. And after 24 hours we do a check lumbar puncture and measure the pressure with a manometer.
So you check the lumbar pressure post-operatively after 24 hours.
Yes.
Okay.
That will reflect us a true intracranial pressure.
No, if the pressure is high, then even after
then we divide. If the pressure is up to 20 is normal.
Okay.
If it is up to 25, 27, something like that.
Okay.
Or even up to 30. Our first management is Diamox, Lesilecton, all those things. Then weight reduction, all those conservative measures,
As a prophylactic, why don't you use Diamox post-operatively for few days?
No, why to?
What is the harm?
See, once the pressure is normal, why are you creating a hypopressure situation?
But you are telling this is a case of intracranial hypertension.
Yes. So that's why, obviously the Diamox has to be started, but decision making is up to 30 millimeter of pressure, you have to start Diamox, and 30 means if it is about 25 or so, we have to counsel that they may require stenting in future, shunting, diversion.
BP shunting or
lumboperitoneal or BP shunting, whatever. That is the neurosurgeon's call, because both shunts have their own advantages and disadvantages.
I remember you talking about repeated lumbar puncture.
Yeah, some people used to do to start recirculation of CSF by repeated lumbar puncture. It works sometime, but in a persistently elevated high pressure, it cannot work for long. That is short-term phenomena. Then, keeping the patient on Diamox, counseling for the possible need of shunting, we get this, the fundal pressure, the fundal check done, eye checkup done to check the fundus every 15 days to 20 days, whatever. If the fundus remains normal, we don't take a call. If the pressure remains high, the fundal changes are there, in spite of all this Diamox and that, then is a call for shunting. Now, on post-op, if the pressure is very high, about 30, 35, then is the indication for getting MR venogram.
MR venogram?
Yes, to rule out venous sinus stenosis.
Okay.
Many a patient we have found,
venous sinus stenosis and got them stented. You know why? The CSF is produced in the lateral ventricles, coming through the foramina Monro in the third ventricle. You saw in the cadaver.
Yes.
I showed the lateral ventricles, foramina Monro, third ventricle, then through the aqueduct of Sylvius to the fourth ventricle, and then through the foramen of Magendie and Lashka, and then towards the the large sinuses where the arachnoid villi, where it is absorbed. So the CSF is absorbed by the arachnoid villi in the larger sinuses through a pressure gradient.
Okay.
Now, if the sinuses are blocked, there is a negative pressure gradient towards the sinus, towards the CSF, you know.
CSF, yes.
And it doesn't get absorbed, and the situation of the high pressure remains. And if you find that on venogram, that is the final answer. We have found patients with transverse sinus stenosis and got them stented, and they do so well. Because
Then
that is the answer of the original problem.
Okay.
What you have repaired is the manifestation.
My question, Satish, you have done hundreds of CSF leaks. In how many patients this problem you have identified?
Last year only we found 4 patients.
4 patients?
Yep.
Oh.
Not so common, but this is one of the reasons.
Okay.
But that is a very costly treatment, because stenting in the dural venous sinuses by the intervention radiologist, he has to be very good. Stents are costly, although they have to take anticoagulants. There are so many things associated with that.
In your
When you give Dimox, how long you will give post-operatively?
3 to 4 months, and then what we do on a regular, fundal checkup, we have to monitor. The most important thing
like
which was
3 times a day, 2 times a day, once a day, tapering Dimox?
Depending, if the pressure is high, we can increase the dose even 500 milligram 3 times a day. But generally we keep on lower side, keep on getting the electrolytes done, because it may reduce the potassium.
Yes, yes, that's what I want
So
to
we
ask.
always take the help of physician to monitor all that.
Fundus examination like once in a 2 weeks or
3 weeks. And see,
once in 3 weeks.
Once in 3. The initial is after, the first one is after 3 weeks, then according to the symptom and all. The most important thing which works in majority of these patients is weight reduction.
Weight reduction.
Weight
yes.
is one of the most important factor, as a persistent high intra-abdominal pressure in obese patient leads to the high central venous pressure in the brain, and that is something responsible for the high pressure situation. And weight reduction is one of the major modality to prevent future problems. And many of the centers in the world are advocating bariatric surgery to the obese patient if they are undergoing CSF leak surgery. And that is so valid.
Before or after?
After that, obviously. Once leak, see, once there is a CSF leak for any region, the first priority is to seal the leak to prevent meningitis.
And I think calcium and vitamin D also been supplemented in these cases, I think.
That you have to give as a, adjuvant.
What about attending about constipation?
Yeah, you have to give laxative, obviously.
So
all these things of weightlifting, straining, all those things you have to advise patient as conservative measures. But the most important I mentioned is the weight.
Weight.
Many of the patients, even we have asked them to undergo, bariatric surgery if you can't.
Till you remove the merocell and celastic sheet, you keep them in the hospital admission.
Yes. 4 days.
Okay. Sir, use of lumbar drains in spontaneous versus traumatic leak, what is your experience?
See, for such patients after skull base reconstruction, the indications of lumbar drain for us are very clear. For not all the CSF leaks, if we are doing a major skull base resection close to the bigger systems like transclival, transplanum, then you have to repair and put a lumbar drain, because then there is a high possibility of a CSF leak afterwards. So it is better to divert the pressure for some time until the seal is taken up. Number
How
one
much
is
amount of CSF will be drained in when
5 to 7 ml per hour.
5 to 7
And we
ml.
use a regulator for that
to drain 5 to 7
that's what
ml
is
per hour
regulator.
persistent on a constant basis. Second is, once you are repairing a large defect which needs a good,
Okay. In which cases will you use Hadad flap, sir?
same are the indications for Hadad. Difficult, like large defect. I will tell you in the next defect of the CSF from the cribiform, I will show you a mini Hadad for the regions. It gives you primary healing so fast because you are bringing ready-made vascularized tissue.
Yes.
So the indication you have to define yourself. Rather than putting the free tissue every time, which will take time to heal up, you are bringing ready-made vascular tissue. So in large defects, high pressure, you know, in after the large skull-based defects, post-RT, all those difficult situations, you can use Hadad. And if it is your gut feeling for any defect, if you want to use it. It is always better.
Satish, any role of anxiolytics, because CSF leak means something brain connected to nose, they gets very tense and anxious.
It's better to give. If you think like your patient needs it, give it.
Yeah, just to make them feel comfortable.
Yes, yes.
Like wonderful demonstration.
Yes, a wonderful demonstration.
Not only the leak, especially the MRI cystoscopy and gadolinium, and the way you demonstrated 3 to 4 days, avoiding radiation. It's amazing.
That is something which has helped us like anything in our practice.
Yeah.
It has
So many
brought us
are
out many a times from difficult situations.
Yes.
The many are asking the same question again. What solution you put on the gel form? It was ciprofloxacin, right?
Simple drops, ciprofloxacin. It is a topical solution antibiotic. And then finally was the Merocel, which we soak in, betadine. Povidone iodine is another antibiotic. So right from the skull base to the anterior nares is the full layer of different antibiotics.
Yes.
You have to call for traumatic CSF because there is when you recommend, at what site you recommend, and how much you wait for the repair.
Traumatic, yes, if it is a small defect, you can wait. I told you, if you are lucky, if you get a patient early, because post-trauma, they are mostly admitted in the neuro units, you know.
No, waiting means how long? 2 weeks, 3 weeks?
Yeah, 2 to 3 weeks. And if you are lucky, many times you get patient within 7 days. And if it is a small leak with a trauma, cribiform, we put a lumbar drain. And many a time it heals.
Okay, so
A small fresh leak. But if it is a bigger one, comminuted fracture, larger defect, better to repair and put a, if you want, you can put a flap. But those are very rewarding because there is no pressure phenomena associated with them. It is all mechanical. You have to repair in multiple layers and forget about it. That is something rewarding.
Satish, in non-traumatic cases, what is the role of conservative management of CSF leak?
Ajay, next CSF leak. Yes, Madhu, what?
Yeah, in non-traumatic cases, what is the role of conservative management of CSF leak?
That is something, that's a very, very important message, question, and I'll give you my gut feeling. That is pure evidence based.
Really, very useful.
A lot of people think that there was a small defect given Dimox, the the frequency has reduced and it looks like stopped.
Yes.
Sometimes patient may not perceive with a high dose of Dimox and other measures that the leak has stopped.
Yes.
Believe me, that is a disaster because that doesn't seal the skull base defect. It doesn't prevent the incidence of meningitis even if it is not leaking.
Okay.
So that is the most difficult situation you are pushing the patient into.
Yes.
What's my point?
Yes.
So you never be in an illusion that your spontaneous leak has stopped and you don't feel like repairing. If it is a skull base defect, you have to reconstruct to prevent CSF, prevent meningitis.
Yes.
So what about leak from the lateral recess?
Pardon?
Lateral recess?
Yeah, lateral recess is mostly a manifestation of high pressure because that is a more pneumatized space with a thin bone surrounding where the temporal lobe is sitting above.
Yes.
And with a constant pulsation of the temporal lobe, it gives away and leads to brain prolapse in the temporal lobe. And we'll keep probably next week that case of lateral recess leak.
The purpose Paramita
Then will you go for the
exposure in lateral?
Yeah, the trans-pterygoid approach that I think.
Straight away with 0 degree trans-pterygoid. See this angiofibroma, what it was in the paramedian area. All difficult temporal fossa, we did everything with a 0 degree. Only thing required was the access. And this paramedian access was given by Dankers. In the lateral recess leak, what is lateral recess? At the expense of that pneumatization is at the expense of pterygoid bone.
Yes, sir.
So you go head on with drilling the pterygoid, you are in the lateral recess, simple. And once you are in the lateral recess, you can seal like any leak. See, for any CSF leak, ultimate sealing is same. For sealing any defect, it is the exposure which matters.
Yes, exposure is
every time the reason of failure is the lack of exposure. That is what I am going to emphasize in the commonest of leaks we find from the cribiform, which we have a case today. That kind of exposure needed in the cribiform, you can almost get 100% results if you follow it, almost the protocol.
Have you ever operated bilateral cribiform leaks?
Yes, multiple. I have operated a patient at the 6 sites of leaks.
My God.
High pressure. And that was needing a complete skull-based carpeting. Sort of
what I observed.
Yeah, this can happen.
I think that's on YouTube as well.
Yes, I think.
How do you diagnose the site of intermittent skull-based leak? This is a question from Nepal. Dr. Chandan is asking.
Site
of intermittent skull-based.
You saw the gadolinium just now. Intermittent is gadolinium. And I can see Dr. Sandeep Kumar from Bareilly. Boss, good evening. Good evening. So we are ready for the next case. Do I go ahead?
Yes,
so the next is a very interesting case. It's a very interesting case in a male patient. I tell you, this is this one. This patient had a history of, this been for more than 1 year, history of swelling in the submandibular region whilst, swallowing. And that, the history pertains to a stone in the submandibular duct when the patient develops swelling while swallowing. Sandeep boss, I remember your workshop you kept on a, he organized a workshop in Bareilly on a very amazing topic, that is benign head and neck lesions. All benign head and neck lesions. I loved that workshop. I still remember that. He kept 14 cases of benign head and neck lesion, and what not the variety he kept. He kept parotid, submandibular, the thyroid, then the hemangioma, a lot of lymphangiomas, preauricular sinus, branchial sinus, thyroglossal, branchial type 1, type 2, what not. And that was amazing, including angiofibroma was a benign lesion. So this patient presented with that swelling in the neck on swallowing in the submandibular region. On palpation in the oral cavity was hardly anything. Couldn't find the stone. On a deep palpation towards the gland was something like that. Then had a CT scan done. Can you see something?
Yes. Yeah. Big, huge.
The huge stone in the submandibular region. There are so many modalities to diagnose the stone. Even a simple ultrasonography can pick up with a sonologist if it is very good. And sonography, the only lacuna, it cannot detect below 3 mm or so. And sometimes it defect in the anterior part to pick up with the sonography. So this was with this thing, and he was advised, by someone the intraoral stone removal. With this big stone, right in the most posterior part, see the angle of mandible, deep into the gland. How can you remove intraoral? First of all, maybe. For that matter, there are many ways to remove these stones. I will come on that. So now, coming to the investigation modality, if you ask me the single best modality to diagnose the salivary gland stone, maybe parotid or submandibular, not only stone, you need to find out the reason behind it, any parenchymal lesion in the gland itself if it is. Because if you do see this CT scan diagnoses the bony conditions, It doesn't diagnose the soft tissue lesions. You cannot characterize the, the soft tissue of the gland, what it is behind the stone, the reason behind stone and so many other things. And for that matter, the ductal architecture cannot be picked up by CT scan. So this is never an investigation of choice. Unnecessarily advising radiation, and that too it cannot pick up the radio. It can pick up only radio dense stones. You can miss a lot of other stones which are not radio dense. So for us, the investigation modality of choice is MRI. And MRI with spatial sequence of MR xylography. Now, let me show you something. This is so interesting. We have picked up in many of such patients who were diagnosed as negative, no stones. Being not radio dense, they were turned out to be negative even on CT scan. People get occlusal view, radio, if it is not radio dense, it will be negative. CT scan negative. Ultrasound is operator dependent, So the only investigation, there are two more investigations. One is a digital subtraction angiogram. That is good, but that is invasive. Yeah, that is invasive. You inject the dye in the duct and then you get a CT scan done. That is good that you get the information of the ductular architecture, but that is, you have to inject dye and get a CT scan done. Invasive, radiation, and if the patient has an allergy, something like that. If patient has active infection, you cannot do that. There are so many lacunas. So the single best modality which covers all the aspect of diagnosis and rule out all the problems, again, is one and only MRI. See this. Let me tell you first about this case. First this MRI, and what you find on this MRI, see this. Can you see something?
Yes.
Flow-void like situation. Stone. On MRI, the bone, the stone, bone is always dark. Yes. And see such a big stone on MRI. Yes. Now, what you find on this particular sequence, T2 weighted, is the stone. This MRI is very useful. You can pick up, see this T2 weighted MRI. This is your parotid gland. See, this is your parotid gland.
Okay.
See, this is T2 weighted, so you can pick up even the duct of the parotid so well. Going here, opposite the second, opposite the crown of the second tooth. This is the parotid duct. So MRI is a good investigation. See this, to pick up not only the stone, but it gives you the complete architecture of the soft tissue of the gland. See what is happening in the submandibular gland, if it is getting atrophic, if it is getting, any changes at the, at the cellular level, you can pick up on MRI. See the difference in both glands. Can you see on MRI? I will tell you the reason, the significance of this. This gland is normal, and what is happening to this gland is completely atrophic. See the intensity because of this stone. So if the gland has gone atrophic because of this large stone, forget about all modalities just to remove the gland, to get rid of all this. Your endoscopy, your intraoral removal, even if you happen to remove this stone, by all means you are heroic, and you could do it by intraoral, external approach, whatever. What is going to, what are you going to gain? This gland has gone atrophic. This gland which has produced 2 centimeter stone. Do you believe that this will never produce the stone again? Yes. There is no point in keeping this gland, and this is a straight away indication for gland excision. Now, the best investigation, best sequence for this, I tell you, is a MR 3D xylogram. Now see this. Xylogram is nothing else but a heavily T2 weighted MRI. Simple. Where the fluid is bright, like you saw on MR cysternography. It's similar MR xylography, non-invasive. But what you find, the ducts will appear, see, so bright in the black background. See this? This is the flowoid stone. Can you see? With inflammation surrounding, and this is the distal duct. Yes, yes. And what you see, there are 2 more flowoids. Can you see?
Yes. Yeah.
Yes, yes.
Not only this big stone, there are 2 more small stones which were otherwise not picked up by any other modality. Can you see? This is so important. I'll tell you the reason why it is important to know all the stones to prevent future problems. See, 3 stones you can see on this MR xylogram. One, this flowoid, and then 2 small flowoids, and this is the duct. Can you see very clear?
Yes, sir.
So that is the beauty of the MR xylogram, that you get to know the exact information of the salivary gland. See, this is the parotid gland. See this parotid gland on both sides, how it opens, and if there is a stone in the parotid gland, you can pick up so well as a flowoid. That is the value of MR xylography, and it is absolutely non-invasive. That is the beauty. If there is any changes in the gland architecture or anything, you can pick up on this very well. So for diagnosis, it is the best investigation. For decision making, for treatment, if you have a distal stone in the Wharton's duct, you can remove by xyloendoscopy. If you don't have a xyloendoscope, just make an incision on the duct and remove the stone intraoral. It can come out well and it heals so well. But xyloendoscopy is the advantage because you can see inside the duct if there are any small stones remaining, which you otherwise don't see with the open approach. If you divide the duct, you can remove only that stone and come out. So xyloendoscopy is better, and then you can flush the entire duct well. You can see the entire ductal architecture inside, is any stenosis or anything. Got my point? And for that matter, for proximal stones in the hilum or the gland, then decision making is important. If your gland is healthy, you can still attempt, if you are experienced, through the intraoral approach with the xyloendoscopy if somebody is exposed, or you go by the open approach, remove the duct and put a stent in the duct and come out and preserve the gland. You can do all that. But if the stone is in the gland itself, that much big with the gland atrophic, forget about everything, and the gland excision is the answer.
Yes, yes.
Is that clear?
Yes,
Satish, one question.
Yes.
If you have to ask one radiological investigation for salivary gland pathology, what do you advise?
MRI. I told you.
MRI.
With MR xylography.
No, MR xylography. That's what. Right. Number 2, for this case, to attain 2 centimeters size, must be for a very long duration without much.
Yes. That's why you see symptom depends upon as long as the salivary flow is going on. Patient may remain asymptomatic.
That's what I am. Because they land up in recurrent.
This is not a 2 centimeter stone in the duct. This is in the gland.
Gland. Okay. So there is some passage.
Yes.
There is some drainage process going on.
Yes.
Okay. Right.
So
otherwise, in the duct, patient cannot stay for such a long time.
Yeah. So the answer is. The answer is submandibular gland excision.
Excision, yes.
Now there are many approaches to the gland excision.
Yes.
Nowadays with the endoscope in practice,
yes,
everybody is trying endoscope for everything.
Satish, hello. If there is any,
sir, what about
the xylogram, where we are putting the dye in the submandibular duct?
No, not really.
Not really.
Yeah. I will tell you the theory of the duct, what exactly is required. So what I was telling, with the endoscope in practice now, everybody is using endoscope for everything. You ask any procedure, somebody will attempt with the endoscope. Similarly, the endoscopic submandibular gland excision have been reported many times. You know? Are you getting the picture?
Yes.
What I am showing is with the microscope. This is anterior, this is posterior, this is inferior, this is superior. Can you see?
Yes.
Yes, sir.
Now,
so what about USG? Like for us, if any cases like this come, we generally get an USG done. What is your say in this?
USG is a primary investigation, good investigation, cheap investigation. I mean economical, and it can pick up. It is an operator dependent investigation. So the sonologist has to be very good, number 1.
Okay.
It has a limitation in detecting the stone in the most proximal part of the duct where the sonography cannot pick up and you miss the stone. It has a limitation in detecting the stones of less than 3 millimeter diameter.
Yes, sir.
So you can miss a lot of things.
In fact, we are still doing X-ray, means floor of mouth, means orbital occlusal view. That is also very good.
Occlusal view. Occlusal view, yes.
Yeah.
But if the stone is not radio opaque, then?
Yeah, that is an issue. It's very common in submandibular.
Yes.
But as per today's webinar, the indications of MRI in ENT is increasing like anything.
Madhu,
Yes, sir.
the CT scan gives only bony details, you know.
Yeah.
For bone anywhere, the CT is the choice. Now even for the bones, for many regions, the MRI is the choice.
Because
you know, previously in the oral cancers, you know, I give you so many examples.
Okay.
Oral cancers, the involvement of the mandible was assessed with the CT scan as a choice, you know.
Okay.
To me now, the MRI is the choice. Because MRI can pick up the marrow involvement, which CT cannot.
Okay.
So indications of CT are reducing.
Yes.
And that is a radiation hazard at the same time.
Yes.
MRI is versatile in terms of giving more than 1500 sequences. And every sequence has a value, you know, in terms of picking some or other thing.
But I think it needs a lot of discussion with radiologists.
Yeah.
Because
the problem with the radiologist many a time is in their training. See what I am doing. After this regular incision, submandibular incision.
Yes.
You give such a big incision or normal, just for demonstration?
It is not big. It is looking big under microscope. See this.
Okay.
And it will suture it subcuticular. It will not be visible in this crease.
I thought it's just for demonstration you are taking.
Now see, yes, sometimes. See now I am. See first of all the advantage of microscope. The things are so clear. See this? What I am doing now, I am going through the platysma. See this? See through the platysma. Like any other neck surgery, you go through the platysma. Simple. Let me know if the picture goes out of the focus, please, Paramita.
Yes, sir. It's clear.
See now the important thing here is in this surgery you have to preserve a lot of structures. I'll come to the discussion of the endoscopic and open approach, the debate.
So maybe you can focus little, sir. Focus little more.
Pardon?
You can focus little more, sir.
Okay. Yes. Better?
Better.
Okay.
Yeah, better, sir.
Now see, the first and the foremost important thing is, as we have to preserve lot many structures, neurovascular structure. This is a very fascinating surgery that you have to preserve lot many things. The first and foremost advice is to stay just underneath the platysma, not deeper than that, because as you go up, your marginal mandibular nerve you have to preserve. See this? Hello?
Yes, sir.
Yeah, see, just hugging the platysma. Utha ke rakh. And it is your assistant which is important to keep it, give you counter traction.
Yes.
Pardon me because I have the habit of doing everything with the cautery in the neck. I am so used to cautery. See this? Just hugging the platysma. And I have already given you several times in these webinars the point, the most important landmark for the...
Don't give them, just let the people give the answer.
Okay.
So this angle of mandible.
Yes.
What is scientifically known as?
What is this structure here? What is this structure here? That is greater auricular. Okay? Yes. That we don't have to do anything to it. And this is the inferior flap. You can now...
So angle of mandible is known as?
What is this point at the angle of mandible posterior inferiorly?
Yeah, let them give the answer. So you have told I think 2-3 times.
Yeah, ऊपर से लगा रहे इसके ऊपर.
I'm waiting for the answer from all.
Oh, it's a prize question?
Yes, a prize question.
Oh. What is this point at the angle of mandible which I I've mentioned several times in the webinars for
Gonion. Palanappan has.
Now see, what is the value of Gonion? Madhu, you can, is Madhu there? See, there are a lot of people trying a lot of indirect ways of preserving the marginal branch.
Yeah.
Yes.
You know, indirect ways are always indirect. You never know you are preserved or not.
Yeah.
And once you have to work in the neurovascular region, will sometimes bleeding happens to occur and you never know what has happened to the nerve. And this is so important a nerve for the patient.
Yeah. But present, if you injure means.
I give you the simplest way again. Whoever is watching.
Yes.
Can you see my nerve?
Yes.
This is my gonion. See this gonion.
Oh.
Within 1 centimeter vicinity of the gonion.
Okay.
You have the nerve. See this.
Yeah.
So, congrats Kripa, Mayor Nath, Anukaran Mahajan, Ankur Wali.
Palanappan.
They are on YouTube.
Asmita Patel.
Kripa Nath Gunian, you are the first one to give the answer on YouTube. Because
Correct
YouTube
answer? Correct answer?
Yes, correct answer.
So what is the price from Sun Pharma?
They will get it.
Singapore trip.
Nowadays, next 5 days, they can go.
See now, see the mandibular branch. Can you see? So clear?
Very nice. Very nice.
Yes.
What else you need?
Yes.
So once you can find it and see, it goes deeper. It is coming from the parotid superficial. You can see that. And now you can leave that deeper behind and you can elevate your flap. See this? This is the simplest way of identifying and preserving this, structure so easily. See this? And my goal during the entire surgery is to keep it away.
Yes.
I don't have to do anything with it. This gonion is the point. See this? 27 millimeters from here anteriorly is the site of facial artery in the vein. See this? See this here?
7 millimeters.
Yes. This gonion is very important point. And see, this nerve sometimes have bifurcation, trifurcation. It is going towards the angle of mandible. Very vital nerve, supplying many of the muscle, 4 or 5 muscles there. And it is very, very important for the surgeon to preserve this.
Why can't you give incision 1 centimeter much below and lift the whole flap up?
Yes. See this and my incision is almost 2 centimeter below.
Yeah.
Because sometimes variation in the course as well. Sometimes this nerve is little below. It's not always at the same level, but majority of the times, you'll find this nerve where I said you, easiest, most superficial to pick up. Now I told you, during flap elevation, see this platysma. This lies immediately in the deep fascia, deep to the platysma. See this?
Yes.
If you don't hug on the platysma during flap removal, you can easily injure the nerve.
Yes.
What my point?
Yes, sir.
Now the removal of the submandibular gland or clearance of this area in the malignancy cases is different than removal in the benign situation. Now can you see this facial vein?
Yes.
Yes.
This I will take. You can put a clip or you can tie this. Now removal of this gland will involve preservation of certain more structures like hypoglossal nerve,
yes,
like lingual nerve, like facial artery.
Yes.
Artery.
We have to preserve the facial artery as well. In malignancy is a different situation. Facial artery is an important vessel, and nowadays it has become more important for one of the preferred vessel for anastomosis.
But many people say that sacrificing facial artery doesn't affect in any way.
Doesn't affect is different thing. Why to sacrifice once it is not, facial artery is not a culprit number one?
Yes.
Our disease, our goal is not the removal of facial artery?
No.
Not.
See now, I am at the inferior to the gland. Can you see?
Yes, you are in.
Yes.
See my next landmark. What is that? The tendon of digastric.
Yes.
Yes.
inferior to the gland. पकड़ इसको ना वहीं से बोल. See this. पकड़ना यार. How's the picture?
Very good, very good. Is it 4x? Magnification.
Pardon?
Microscope magnification, Satish.
Yeah, magnification is how much?
4x?
6x.
6x, okay, right.
See this? This is my next landmark. And I will follow it anterior to the gland as well.
Okay.
पकड़ लेना उससे यार. तब पकड़ ले. वो ले लो. एक ले लो, है ना? उसका ना काम कर. First चालू करो मामूस. See this, the digestic all the way?
Yes.
All the way. See this?
Yes.
So you mean to say, sir, even Dr. Sham Somani is of the same opinion, is asking that preserving the facial artery, you do this routinely or whenever possible? What is it?
Almost always.
Okay.
In my practice, almost always.
But many head and neck surgeons say that in submandibular gland excision,
why
ligate the facial artery at 2 points, both lower and upper.
Okay.
See now?
Yes.
This is the posterior inferior edge of the gland.
Yes.
See this, and this is the facial artery here. Can you see this?
Yeah, yes.
See this facial artery?
Yes.
Yes.
Now, where is our nerve? See, nerve is there up, far off.
Yes, far off.
So, and now I will separate this tissue posterior to it to keep the nerve further away. See this?
Yes, yes.
Very clear?
Yeah.
That will keep my nerve now miles away.
Miles away, yes.
Agreed?
Yes.
See how you can simply preserve the vessel. The only thing is, you need to have a microscope, number one, because there are a lot of glandular branches from this vessel. Hey.
So you always do submandibular surgery under microscope?
All. I showed you that in the neck dissection under microscope.
Yes.
Now see, this is your artery. See this?
Yes.
Going up and it is going here. This artery has a relationship only with the posterior superior surface of the gland.
Posterior superior surface of the gland.
Only.
Okay.
And it gives lot of glandular branches there.
Can you show the facial artery once again?
Yes, yes, yes. See this vessel here?
Okay. Okay.
Let me show you better. Okay.
Yes. Now it's much better. Yes.
Can you see this?
Yeah. Wonderful.
See this? It gives a lot of glandular branches, and one very important branch it gives off is the submental artery. That is the basis of a very important flap, submental flap.
Yes, sir.
Yeah. Bipolar. Pani.
Is this submental branch?
No. This is not submental. I will show that.
Will be anti-water.
This is glandular branch only.
Yeah, many. I will show you.
Yeah.
I will show you. Let me. Can you see the vessel very well?
Yeah,
Yes,
very,
yes.
very nice.
Now, if I reflect this vessel here, you will find a lot of branches. See the glandular branches from this side, and see this.
Satish?
Can you see the branches here?
Yeah, yeah.
Yes, sir.
Can you
We are
see the
able to
branch
see
from
it.
the gland?
Yes,
Yes,
sir.
Let me show you under magnification. Can you?
yes.
These are the glandular branches, you know?
Very clear, very clear. Small, slender branches.
Yes, going to the gland.
Satish,
Yeah, I will bipolarize them. Yes, yes, man.
can you just show the place of calculus? Just like palpation.
Yeah,
Very
I
appealing.
will show. I will not reach. That is in the depth.
Okay,
Deep,
right.
insert deeper.
I will show. See this glandular branch I have ligated or coagulated?
Yes,
Can you
yes,
see
yes.
a
Yes, sir.
bigger branch now anteriorly? Can you see a bigger branch now?
Ah, yes.
Can you see that?
Yes, bigger branch,
That is a
bifurcation.
submental. You know, submental flap is a robust flap
Mm-hmm.
for the oral cavity reconstruction and many other things.
Yes, sir.
I am into head and neck, so we always look for the flaps. You know, wherever possible, some flap can be made. We go for it. See, my nerve is there in the view. See this?
Yes.
Yes,
That is the
see?
beauty of keeping the nerve all the time in view.
Right.
See that?
Yes.
And this is, see your facial artery.
Yeah,
Yes, sir.
very nice exposition.
This is a very important vessel, you know, in the free flap surgery. One of the preferred vessels, you know. See, it takes your 5 minutes extra. I would have been through by now had I not preserved this vessel.
Yes.
Because here it is the sialoadenitis which is the culprit, not the vessel.
Dr. Sambhaji Chintare from Aurangabad is asking marginal mandibular if cut can be re-anastomized.
Yes, I mentioned in the facial webinar various ways to, you know, rehabilitate the marginal mandibular. Various. And in one of the case I showed that, you know, DLI resection as well. Anastomosis, primary anastomosis with the, you know, ansa hypoglossi. Then the digastric flap, you know. See, lot many intraglandular branches. See this?
Yeah, yeah.
All these intraglandular branches. I am dividing. See this?
Yes.
And the biggest one is the submental artery. See this? See this?
Yes.
Yes.
That is the basis of submental flap. It's a very useful flap, you know, for many of the intraoral small lesions, no? If you have to reconstruct, you can use this flap. See the vessel I am leaving behind.
Yeah, beautiful. Really.
And that is a submental artery. See this?
Wow, very nice, Satish. The submental artery. This is not it.
Thank you.
See, this is not malignancy. In malignancy, I would never preserve all this because there are lot many lymph nodes around the vessels.
Yes.
And if I am doing a supraomoid dissection for oral cavity or other lesions, this is the primary Schillen area. You cannot afford to, you know, to resect them en bloc. So there I will never take a chance. See this?
Yes.
I hope now you can preserve this vessel.
It's amazing, sir. preserving the
Give me the
facial
tooth
artery.
forceps and
ENT radiologist and ENT anatomist like Dr. Satish.
oh, many of us, we are learning from each other.
What's the name of the doctor asking from Pakistan?
Dr. Raza.
Raja?
Dr. Raza.
Okay.
Okay, one Dr. Riyaj Afridi is also there. He is also.
No. I was confusing like R-A-J-A, Raja.
No, R-A-Z-A. Z-A.
Okay, right.
Raza.
Okay, right. R-A-J-A means it's with Indian name. That's why I was
Yeah.
So Riyaj Afridi, Dr. Sayan Hazra, so many from.
If any Olympic person is there, what is the attendance now for this webinar?
Sun Pharma,
sorry.
They are 1 second. We have the latest one.
Sir, it's more than, I think, 5,000.
1 second. The final figure is there. 1 second. Where is it designed?
See now.
291, 294 and 5,500. 5,400 something.
Sun Pharma has got enormous amount of popularity by arranging these beautiful webinars. Thanks and a lot of heartfelt thanks to Sun Pharma.
Yes, surely.
See, all these are intraglandular branches I am sacrificing. See this?
Yes, sir. Yes, sir.
So many. That's how, if you avulge one of the branch, you know, these are all intraglandular branches. So many.
So there is a
And
question
now I will
from,
take this submental artery, you know.
Yeah.
I will take the submental artery to release the vessel.
So Dr. John Shadow from Australia is asking, wouldn't something like the old thunder beats be better than bipolar in cutting, sealing gland vessels?
Yeah. Harmonic is best. Pakdiyo. Harmonic.
Now head and neck harmonics instruments.
Even I prefer harmonic scalpel.
Yes.
Harmonic is good. It expedites your process because the same step you can coagulate and cut. See now, so many branches.
Yes.
Well, see now from the inner surface. See this, so many glandular branches. See further.
Going to what Dr.
Cut like it. See, this is the submental branch cut.
Yes.
And this is, yes, you are saying something?
Yeah, going to what Madhu has said, the company has no doubt done a very good job of arranging your webinars. But I must also congratulate Rajeev Pachauri for
big. Only because of him.
You have done a great service to ENT fraternity actually.
Yes.
Dr.
Rajeev needs
Pachauri
patting on his shoulder.
Thank you, sir.
Rajeev Pachauri and Dr. Paramita has done great job.
Yes, Paramita has been throughout there. They have done great
See
job.
now, this is the facial artery and this is the final branch I am segregating. See, the entire facial artery is separated. See this?
Yes.
Yes.
So nowhere you are now close to the facial artery for any region. See this, chote. See this artery now? Well, such a tortuous course. See this?
Yeah. Yes.
This is your nerve, this is your artery. Okay?
Right.
Now few more structures. See, this is all stone.
Yes. That is
I will
stone.
tell you some interesting story about the stone, how they can form even after the gland excision.
Yeah. The stump.
How the stone can form after the gland excision, and this was, revealed by a very important person's work. You know, the ductules of the submandibular gland was studied first by a German, anatomist, Ravenus.
Hello.
And then a Danish anatomist has revolutionized. I'll tell you how the clinical implications are. Now see, I am elevating the duct on this side, a gland on this side. See this? Everything from behind done?
Yes.
Now on this side. What I need to see now in 5 minutes time we'll be through and the next case is ready. This is your gland. This is your, what is this muscle? Mylohyoid.
Mylohyoid muscle.
What is this muscle where this gland is sitting? That is hyoglossus. See, let me push something for the blunt dissection here and now you see what is there. The muscle below is hyoglossus and this nerve going is the
yes, that
hypoglossal.
Yes, sir.
And then if I retract this myeloid, see this gland is going deep to myeloid. See this?
Yes, sir.
I will find some more structures. See, as you retract the myeloid, इसको retract करना है. Yes, retract कर वो लगा ना. Yes. See this? Some new structure is coming. See underneath. What is there? This one. लगा मेरे को दे. पतला दे. Yes. See something. Can you see some now there?
Yes.
Yes.
Let me show you better. See all this tissue now, once you have seen below, you can remove so easily. See now it is coming out. See this now below. Let me clean this tissue to show you. Now. Yes. कहाँ क्या करता रहता तू? हटा हटा सब उधर दिखा ना. चल retract कर. Now see, after retracting the mylohyoid, see some nerve there in the depth. Take out the retractor. Two things you need to see.
Yes.
Well in the duct.
Hata.
Digastric.
Two things. See now. Yes. One thing you have seen below is the hypoglossal.
Yes, hypoglossal. Yes.
Let me show you better with its vena committens. You know.
Yes.
This is hypoglossal here.
Yes.
Okay. Hypoglossal. I'm not disturbing the vena committens. Once they start bleeding, they are so frustrating. Better not to disturb them. But this is the hypoglossal going, you can see. Okay. Now above this if I reflect, there are two structures. One above another. This here is the duct.
Yes.
This one.
Yes.
And this will above. See this? That is the lingual nerve.
Yes, sir. Lingual nerve. Yes, sir.
This gives the postganglionic fibers to the gland that you have to resect. This lingual nerve carries the fibers from the chorda tympani. See this?
Yes.
And see this? This I am separating. And I am separating these are the postganglionic fibers. See this?
Yes, sir.
Cutting them to keep the lingual nerve away. See the lingual nerve is away now?
Yes, sir.
It is left above. See that?
Yes, yes.
It is retracted above.
Yes.
See this?
Yes.
That is the lingual nerve. Well above.
Below.
Okay?
Yes, sir.
And now the entire specimen is hanging on what? Duct.
Duct. So below it
Now
is
my
the duct.
question, what I was coming, what is the need of ligating this duct? Once you remove the gland, what is the future problem? How will the stone form? Anybody?
Stump stone.
How come?
There are some glandular elements
there, na? Some.
Even on the duct, maybe some glandular elements are there.
Not really. See, first of all, we all know the stones are commonest in the submandibular gland for the reasons we all know. Because this gland secretion is more mucinous. The duct is, see, so long and it goes up in the floor of the mouth. Anti-gravity.
Yes.
Anti-gravity. It is an angulation here at the mylohyoid. That further gives the possibility of stagnation. You know. And the secretion is more alkaline, more contain calcium, phosphate, so many reasons to it. So now, I have to ligate this duct, okay? Before that, what I will do,
you pointed out through small
I will
stones
palpate
also
the
in
entire
MRI.
duct. I will palpate the entire duct.
Yes.
From both sides, you know. See my finger, I can palpate on both sides to see if there is any other stone in the gland. I can feel here. So now this is the point beyond which there is no stone, and I am going to clamp it. You know, I told you about the German scientist, German anatomist, Ravenus, who discovered most of the ductal anatomy for us. And now I will, you know, see this. You were asking for the stone, Madhu?
Yes. 2 centimeter stone, a big stone.
Oh. See this?
Oh.
See this? Then two more stones, small, see here. So this is such a big stone.
Yes, very big stone, very unusual.
This is another stone. So this stone, see this dimension.
Yes.
Yes, sir.
That too right in the gland, see here, not in the duct.
Yeah.
Yes, sir.
Can any endoscopy or anything can remove this? No way.
No way.
No way. And see, finally we will ligate this duct over there. Ligate kar di? Ligated here. See this?
Yes.
And this is our field. Now see, I'll come to the duct part. This is your hypoglossal.
Yes, sir.
This is your, you know, lingual.
Lingual.
Here is the lingual. See that?
Yes.
This is your lingual. This is your hypoglossal. The duct is here. This is hyoglossus muscle. This is mylohyoid muscle. This is digastric.
Yes.
Now deep to the hyoglossus runs. Above the hyoglossus is the facial artery. Deep to hyoglossus is the lingual artery.
Lingual artery. Yes,
And
sir.
above and parallel to the lingual artery, deep to hyoglossus is what? Glossopharyngeal nerve.
Glossopharyngeal
So
nerve.
this is how the anatomy in this region. So what I was saying, that our next case is ready. The German anatomist, you know, Ravenus, he described the ductal architecture as the submandibular gland is drained to the Wartel's duct, and there are more than 20 ducts of Ravenus through which the sublingual gland drains into the mouth, oral cavity. 20 small ducts, those were given the name of ducts of Ravenus by that anatomist Cunismus Ravenus, the German one.
Bartholin duct also there, no?
Now after that, this is so important to understand. After that, a Danish anatomist from the Denmark, his name was Kasper Bartholin. He diagnosed in his long series, in 39% cases, one of the big ducts from the sublingual gland opens in the Wartel's duct. What's my point? One of the big sublingual duct that was given the name of Bartholin's duct. That opens in the distal Wartel's duct. What does it mean? It has both way implications. Even if you ligate this Wartel's duct, you know, still the stone can form in the Wartel's duct after the gland excision. You know why? the saliva is coming through the Bartholin's duct. Number one. Number two, if you don't ligate this duct after the submandibular gland excision, the saliva can come in the submandibular space through the Bartholin's duct draining into the Wharton's duct. What my point?
Yes, sir.
That's why the ligation of the Wharton's duct is important, number one. And second, there is no guarantee that the stone will not form again. Don't give your patient guarantee once you remove the submandibular gland that the stone cannot form. Still it can form. That's why once you are removing the sublingual gland, sublingual gland excision is a very common procedure for the ranula. Ranula is because of sublingual gland. So when you remove ranulas, you have to remove sublingual gland to give patient a cure. And in that situation, the Bartholin duct ligation is very important. Otherwise, if you leave the Bartholin duct open, again the ranula can form. In spite of a great work done for the ranula, still the recurrence is imminent. So this ductal architecture which is given off by the Bartholin is so important to understand in our clinical practice, that we need to understand this ductal system and why to, when to ligate and what to tell patient for the future. Everything is important. Any questions?
Okay, sir.
Wonderful
So when will you do transoral removal of the stone? Any?
Transoral. Yes, there are many ways to remove the stone for that matter. You can remove.
Which cases will you do, sir?
Small up to 7-8 millimeters duct stone in the distal duct you can remove easily. But rather than transoral, silo endoscopy is better because then you get a opportunity to inspect inside the duct. You have the opportunity to flush the duct from inside. You have the opportunity to inspect if any other small stones there, which you otherwise miss.
But if you do your MRI scan, you cannot miss.
You don't have.
Yes, MRI is amazing.
Yeah.
Yes.
Yes, sir.
So intraoral stone you can remove by endoscopy, but this was the ideal indication for submandibular gland excision when the gland becomes atrophic because of the stone within the gland, that too so big. Even if this stone had been in the gland in the proximal duct, I would still recommend a gland excision because the gland which can give rise to the situations there giving rise to this kind of a stent, there is no guarantee that again it will not give the stone again. What my point? So
Yes,
stone
sir.
removal itself is never a final answer for those situations, particular those situations.
Okay.
Learned a solid point today that all these years I was just asking for ultrasound
Ligating.
or CT scan. But now I have decided MRI is the best diagnosis radiology.
Madhu, you have to read MRI yourself. Your radiologist is not going to help you.
Yes, yes.
You have to sit with him
Yes,
to get more information. Normal HRCT temporal bone. This is normal. We want anatomical details for the autosclerosis. They will never
off
give.
the line, Satish, radiologists are not having that much time to spare.
But I think MRI we can recommend for revision cases or complicated cases, but MRI because everybody cannot afford. So I think ultrasound is of course the basic.
And better to afford MRI rather than a revision surgery.
That's true.
Thank you.
So, but it was an amazing demonstration, sir. Submandibular gland excision. I think for all the juniors, we just need to know the few landmarks and preserving the facial artery. And it is such a quick surgery, which sir has shown it so easily.
No, that is because he is demonstrating. Otherwise, it would have been half the time what he has now taken.
True.
Because he is explaining everything A to Z to us.
True, sir. True. So the next case will be of CSF.
Yeah, next case is already started by my colleague for the exposure to save time.
So what is the case?
Radiology.
This is a cribriform plate CSF leak.
Sir, so before you start the case, for the previous CSF case, there were a few questions I would like to ask you, which have left. So, Dr. Naushad from Riyadh is asking, what about middle turbinate flap for CSF leak repair?
See, for CSF leak, there are so many flaps. Middle turbinate is never a first choice flap. It is never a robust flap. All these flaps you can think of once you don't have, the good flap available like Haddad flap or something like that. Then you can think of. But yes, vascularized flaps are always the choice, and that's why I will show in this case a mini Haddad. How not only I am mandating that for the that it is essential, but it gives you primary healing. That is so quick. That prevent infection in the region, which can be another source of meningitis. Surgery itself is a source of meningitis sometimes, or which you are operating to prevent that.
Yes.
So the primary healing is always welcome.
Okay, sir. So Dr. Sharad from Azamgarh is asking what to do if post-op the previous case which you showed gets mucocele or infected in sphenoid.
Mucocele, what would I do?
Yeah, post-op if there's mucocele formation or if there is an infection, then
you just marsupialize. That's it.
Okay, sir. And there's one more question from Dr. Manjurul Alam from Dhaka. That
Bangladesh, convey my regards to him.
Yes.
A very senior man and is always so academically oriented. Yes, sir.
So he's asking, do you use bone dust like hydroxyapatite in CSF leak repair?
Not really. We don't use all those fancy materials, number one. And number two, no, structural reconstruction of the skull base, except in a very large defect with high pressure situations. The structural defect in a normotensive situation is never indicated in a small defect. So, simple, this multi-layer reconstruction along with the flap. Most often we do with the flap. This was too small to create and apply a flap for this. Was not warranted otherwise. This case I am going to show you a small, mini Haddad.
Yeah, radiology.
Any questions?
No, sir. I think we can move on with the next.
Okay. So now, this is another interesting situation. A spontaneous, CSF leak in a patient with a nasal discharge on the left side. All of a sudden, no history of trauma or anything. And what you see on the CT scan, can you make out?
Yeah, anterior artery,
this opacity continuing through the cribriform plate.
Yes.
And that is good enough to diagnose. And as compared to the opposite side, if you see, because all these high pressure leaks are almost always associated with the finding of meningocele or meningoencephalocele. So, in this patient, we have got his MRI as well. And you see on the MR cysternography is what? T2 weighted MRI. And here you see a very important finding. See this?
Yes.
The basal cistern here.
Yes, sir.
And now on the left side, see this continuity of this leak over here, down. See this here. Yes. Here, till here. Can you see this opacity here?
Yes.
Here and here in continuity. That is classical of a CSF leak on this side. That is. And if I reconstruct in a, the same thing in the sagittal plane, you will find. That is a classical example, the commonest situation of the CSF leak we see. Yes. And that is at this level, and you see on the coronal, in the sagittal. See this, where we have come? Can you see this leak in continuity?
Yes, very clear now.
That is the meningocele. Complete white means fluid only. Had there been a mixed ecogenicity of a brain tissue, kind of a brain tissue, intensity would have been a mixed one meningoencephalocele. This is pure meningocele. And this is a classical finding of the classical CSF leak from a cribriform in a high pressure situation. So
we
once
consider the Kiros type 3?
Pardon?
Should we consider the base of skull Kiros type 3?
Kiros type 3 I have not seen. If you want to see.
No. Base
CT
of
scan. On CT we can.
Yeah, let me put.
Yeah.
Not really. Not really.
Not really. Not really. Okay, right.
You can say type 2.
Type 2, yes.
See from here.
Yes.
Here to here.
Yes.
It's not type 3. Yeah, it is type 2 only. See this.
Yes.
Yeah, Satish, there's one thing I want to clarify. You have said that it's when we write MR cysternography, it basically means the T2 weighted image.
Yes, simple, non-invasive.
So even if you write MR T1 and T2 weighted image, will that be enough, or we have to specifically?
T1 is not required. T2 sometimes you can miss, because I will show you the T2 also of this and show you the difference between T2 and the cysternography. Cysternography is heavily T2, means the background is suppressed.
Okay.
You know, for the bright CSF image, the rest of the background is suppressed. That is heavily T2. And T2 is a regular one where the background is not suppressed. Let me show you the difference. See this.
So should we suggest these radiologists that
even in the T2, you can see this continuity of the CSF. Can you see here?
Yes, very clear.
But here, see, the background is not suppressed.
Right.
In the heavily T2, see this, the background is suppressed and you can pick up the defect much better. That is what, you know, that is what the drive sequence or the heavily T2 weighted sequence.
Right.
So should we clearly mention that we need heavily T2 weighted MRI scan to know the CSF leak?
Yes.
Yeah.
Heavily T2 weighted. That is the need to detect the CSF leaks without any invasive procedure. And that is MR cystonogram. And if it is done with the CT, that is same CT cystonogram, but that is invasive, where iodinated contrast has to be injected in the intrathecal space. Because both will give the same information. If at the time of scanning, if the CSF leak, they will pick up. That's it. If CT cystonogram pick up, then MR cystonogram can also pick up. If that time is no leak, active leak, at that time both will not pick up.
Right.
As simple as that. So now, the goal in this surgery is exposure. Now, what kind of exposure is required? We have to see the entire cribriform plate. You know, in a high pressure situation, sometimes you have to explore the entire skull base. Otherwise, you may miss another leak behind anywhere. So, in order to expose the entire ethmoids, you have to do a complete ethmoidectomy. Now, these leaks are very close to the frontal outflow, you know, close to the anterior-ethmoidal region. And you need to have a surrounding 1 centimeter area raw. So, in order to seal that, it may offset the frontal outflow. So, what we do, we open up the frontal sinus as well. Similarly, when you expose till behind the posterior ethmoid and you may have to seal it, you may have to have distance from the sphenoid ostium as well. Otherwise, may lead to sphenoid sinusitis. So, the goal is multi-pronged. Number one, exposure to see all leaks. Otherwise, you may seal one and miss the other one. So, you have to explore the entire skull base. Number two, in order to prevent sinusitis in the future, you have to make sure the ventilation and drainage of all the dependent sinuses in advance. In advance. Otherwise, you'll have to cut a sorry figure later on, and then in a situation where you have repaired the leak in the vicinity, if you are going to do any sinus surgery in the future, is more troublesome. So what we do, we get exposure like we do a proper sinus surgery, where all sinuses, you know, you open up wide, do a complete ethmoidectomy, and then I will resect the middle turbinate and explore the entire skull base. I will make the surrounding at least 1 centimeter area demucosalized, number one. Not only demucosalized, absolutely flat. If there are bony elevations or something, I will flush with the drill. Otherwise, my flap will not stick to it properly. Because why you need all 1 centimeter around demucosal lines? So your seal to stick to it. For your seal to stick to it and flat so that it remains completely flushed. It doesn't remain elevated in between, so it doesn't stick. So all this is required. Number one, a complete exposure is the key. Not only of all sinuses, patency ensuring, but a complete exposure of the entire skull base, not only cribriform. Why this? If you do something less than this, you may sometime get a problem. Sometime you may have to go back, you may have to go with complication, you may miss the leak, or your seal, whatever you do, if you try to plug it like a puncture repair, it may not work in long run. So once such cases come to you, you have to do a complete job. And this complete job will require a complete unilateral sort of a fess, extended fess with flushing the middle turbinate, cut it flush with the skull base, make surrounding 1 centimeter completely raw and even with the drill, and then we'll repair in the multi-layer fess. Then it is simple like a cakewalk, like any leak. We'll do the same thing what we did to the previous one. We'll do half fat in, half fat out along with the surgery cell to seal it and reinforce with multiple layers till the anterior layers. Then the rest of the course is same. Got my point?
Yes.
Agreed?
Yes, sir.
Yeah, Satish, you mean you mean prophylactic frontal and sphenoid sinusotomy is a must
to prevent future problems.
Yes. So
because I will show you. I will show you how this cribriform plate leaks once you seal. They are how close in the or how they are in the vicinity of the frontal outflow. So you have to do that.
So always frontal and always sphenoid.
Pardon?
Always frontal and always sphenoid, or
always. I'll tell you the reason. See, I can repair this leak like I go medial to the turbinate and do something like a puncture repair. We get so many revisions because of all this work. Believe me, this is one of the most rewarding thing among the CSF leaks, the cribriform plate, and all it requires is a good exposure. For that matter, in any skull base cases, you have seen all the way, exposure is the key. Anything cut short, you may invite problem. As simple as that.
Can I dare to ask one question?
Yes, please, Madhu.
Some people say that all this doesn't, it's only a big thing. Just go there, take your bipolar cauterize half or 1 centimeters around that leak, put a fat flap and it will close down. And they show the beautiful results.
Well, and see, then ask them their long-term results.
That's what I am just asking. Long-term results we do not know. I mean, people.
They are the big source of referral to many ENT surgeons.
Yeah, that's what they somewhere they may not come to the original surgeon, but they land up in some other place. What is the AP diameter, AP length of this leak now? Sagittal, anterior-posterior length of this leak?
Leak is very small. I told you, high pressure leaks always have a small, defect. Hi, Amit.
Hi, sir.
Great to see you.
So, Dr. Arshad, sir, have you harvested the fat already? If not, then can we see it?
That my assistants have already done. The
fat
is harvested, the glue is ready, the exposure is almost done. Now I am going to go and seal it fast. To save time, because our other case is reduced. CSM with facial palsy quick.
Sir, can you comment on the optic nerve halo, sir?
Optic nerve?
Halo, sir. There is a CSF around the optic nerve.
Yes. That is engorgement of the optic nerve sheath. So this is a classical sign of a high pressure.
Yes, sir. And maybe we can see the empty cella sign.
Yes, all that I showed in the previous case.
Yes.
Amit, I showed all the sign. Even in this case, you can see.
Yes, sir.
See this. See high pressure symptom. See the empty cella.
Yes, yes.
So good. Now, see this optic nerve. See this, so tortuous dilated.
Yes.
So tortuous, dilated optic now it is.
Tortuous, sir. Tortuous in both sides. Yes.
Yeah, this is classical.
Yeah, see the left side is very
Classical. And if you see the orbit, see this, the buckling of the nerve, see this buckling.
Yeah.
Classical.
Upside down buckling of the nerve, this is classical. See the sheath is engorged so much.
Yes.
See the size of the sheath, this is classical of high pressure.
So this is only visible in heavily weighted T2.
Yes, that is bad. See the Meckel's cave.
You can see in
Look at the size of the Meckel's cave.
Yes, sir.
Look at the size of the Meckel's cave. Amazing.
Yes.
This
So the
patient
same can be seen in CT cystosonography if that is available. I mean, in any case, if the MRI is not done. But in this
none of these will be seen on CT cystosonograph. None of them.
Yes.
Sir.
None of them. Any single thing you cannot see on CT cystonogram out of these.
We better seen here, but we can make out that. And sir, in these kind of cases, as you said, that the one of the sinus will be blocked. So we get MR venogram. Now in every case when we see this, so a special sequence need to be run for that, because sigmoid.
So it is always better. It is always better for spontaneous CSF leaks when you are ordering MRI to see high pressure signs. At the same time, you recommend MR venogram also, because that it can be done in no time at the same time, rather than ordering later on as a separate investigation, because it gives you full idea beforehand about the status of the venous sinuses.
Exactly.
Instead of fascia, what about your opinion on using middle turbinate mucosa?
Yeah, you can. That is a free tissue mucosa you can use rather than a facial art and all.
Facial is also a free tissue.
Yeah. But Madhu, why to use free tissue? Use a flap in the vicinity. There are so many flaps there.
No. You are going to show the mini Haddad flap.
Yes.
Otherwise, like previous case, you have used the facial atta.
Yes. So that is a free tissue. That will take time to heal, number one.
Yes.
And without vascularity, it can acquire infection also sometime.
And sir, in our experience, when you use for a spontaneous CSF, we try to use a mini Haddad.
Yes, that is always better. You are providing not only vascularity to the area for faster healing, you are providing a ready-made tissue, vascularized tissue for the primary healing.
100% what you are telling is good, but when we are using a free flaps like what you have used, middle turbinate mucosa is in vivo, same place, same site, same nose. You can use the middle, anyhow you are sacrificing the middle turbinate.
Yes.
So peeling off the mucosa from the turbinate is, and you get more than 1 to 2 centimeters of mucosa.
Yes, you can remove that mucosa. And more than that, the security, the sense of security, sense of security of healing is so good with a flap.
Yes.
And we have like a lot of patients from long distances,
Yes.
We just apply the flap, we discharge them after 5 days. And we ask them to irrigate for a month or so. It heals like anything, You don't have to see them again and again for that local healing and cleaning and all that.
And sir, what is your experience?
When will you advise?
Yes, Amit.
Years later, we have seen few patients, around 4 or 5 in our series, that they have CSF leak from the other side. This kind of patient with increased intracranial tension.
Yes, so that's why I mentioned in the beginning, you have to keep it as a part of counseling to the patient once they have a spontaneous leak, because whatever this leak is, many a times or majority, it is a manifestation of a high pressure.
Exactly.
You are not treating the primary pathology by closing the leak. You are provoking the high pressure. So after this leak closure is mandatory to prevent meningitis. At the same time, the primary management is high pressure, and that you have to take a call.
When will you advise?
I agree with Satish, because majority, what I also see, they are associated with obesity, and they have to be counseled that reduction of weight is mandatory.
Yes, weight reduction is mandatory for that matter for all these patients.
So when will you advise irrigation post-operatively for
after 5 days.
After the repair?
After 5 days.
Okay, sir.
Ringer electric irrigation.
You advise irrigation even for CSF leak repairs?
Yes. So what do you advise them?
What is the chances of washing out?
What do you advise them? They can wash their nose, but they are not supposed to blow hard. In terms
Satish,
for removal of the solution, they are not supposed to blow hard.
Okay.
You just bow down and it comes out.
And so another point that if you are very confident of repair, in initial 3 days, sometime when the pack is in situ, the patient complain of watery discharge, and sometimes it is just the tears which get collected.
That is the secretions, retained secretion and all that.
So many a times patient complain, but when you are confident, you have to have, and you just squeeze the Mirocell or the whatever pack, and then you just observe later on. It's fine. So
many surgeons contraindicate nasal wash, or because the material which, like whether gel foam or fat or whatever it may get washed out, because we cannot rely on the patient, the way he is pumping in, how much pressure he is pumping in. So better not to advise nasal wash or irrigation.
We advise nasoclear, sir.
Nasoclear is okay, but even with mucus sucker or available now naso wash, people, we do not know how much force he applies.
Hello?
Yes.
Sir.
Hello?
Yeah, we are with you, Satish. Hello?
Yes, hello.
Yeah, we got the endoscopic picture.
Hello?
Yes,
Satish.
Hello?
Yes, hello.
Yes, are you getting the endoscopic picture?
Yes, Satish. We are with you and we are getting endoscopic picture.
Madhu, let me tell you what has been done.
Yes, please.
See, this primary exposure has been done, and I will show you. See this, I told you a sort of, terminate nahi kaatna.
Yeah. Your assistants have done majority of the exposure for you.
Sir, what if in few cases, like even the CT, MRI, whatever we have done, still we can intraoperatively on the table, what if we cannot find out the leak? Then what will you do, sir?
Very good question. Satish, please answer. And you post the case, open the nose,
and we don't find
the
leak.
What will you do?
You put fluorescein dye in and then put in the reverse tendon position. It is very good.
You may provoke sometimes a smaller leak. You may have to provoke the leak.
Okay, like
by means of Valsalva, by means of any ways of raising the intrathoracic pressure,
tubular pressure, etc.
But it is less likely that a good CT and MRI will not tell.
In spite of all these things, there is no leak found on the table, Satish. What shall we do?
Yeah, that is a question ahead. Better question.
Change the surgeon.
No, but in my experience, if you put fluorescein, it usually sew up. But we should not take a patient on table without the evidence of leak either in MRI or CT. If you assess, and if you are not able to find, see the lateral recess, see the clival recess.
See, first of all, look at the radiology, look at the symptomatology, and define everything. What is your plan? Okay.
Yes.
Now, are you getting the picture?
Yeah.
See, this is the primary exposure. See all sinuses.
Yes,
wonderful dissection.
Wonderful.
Okay, see, this is the lamina, this is the skull base, and that is the frontal recess. About this is with 0 degree and the sphenoid. Wow. Now, I will go with the 70 degree to the key area.
Who from your team did this exposure?
Dr. Shavendra, he is amazing. And see that frontal, everything done.
Yes.
Allows. Yes.
But the first formula is very wide.
The fluorescein, the point that he's making about fluorescein is to be kept in.
See, this part of the turbinate has been partially resected.
The vertical lamella.
So, sir, it is 11:20 at night in India, and to the whole world, whoever is watching, we have more than 6,000 viewers who are watching your surgery.
Still?
At this time.
Yes.
Yes.
Oh my God, so crazy.
Even if you continue, everybody is ready to watch till the morning.
Now see, I will show you a very interesting finding. Can you see this? This meningocele. Here is the meningocele. Give me the this thing. Merocell.
Sir, have you any time seen leak in the middle turbinate itself? I mean,
And the attachment of the middle turbinate, just close to the attachment, because the middle turbinate is attached to the junction of
medial and lateral lamella.
Medial lateral lamella, curved.
So it can be medial lamella, lateral lamella, in between, interlamellar I call it. Or can be.
These cases are usually iatrogenic?
No, these are spontaneous cases.
These are mostly spontaneous.
Satish, can you show anterior ethmoidal artery? In radiology, it was very prominent.
Yes, see this vessel.
This is
okay,
very well.
right.
Can you see?
Yes. The space between the posterior table of frontal sinus and anterior ethmoidal artery, very first.
Very big.
That's what I was.
So clear. And most of the leaks in the cribriform are in the vicinity of the anterior ethmoid, because this vessel goes towards the cribriform to pierce the lateral lamella, and that is the weakest point.
Yes, exactly.
See, now the most important thing is, hemostasis.
Today only in the morning I repaired one CSF leak after post-septoplasty.
Post-septoplasty?
Yes. So, after a very long time I have seen one case of CSF ranula. It was exactly at the same place.
That's right, you are interestingly asking that question, because the septum and where it goes, and they would have fractured the junction.
Exactly.
So, Dr. Palaniyappan from Tiruchirappalli has been requesting you to say or talk about the manometry of CSF pressure monitoring. Do you have it with you?
No. I tell you the simplest way. As the patient lies down at the level of the lumbar puncture, when you put your cannula, keep it up and see from the level of the lumbar puncture how high the CSF ascends. That you measure in centimeter, and that is your pressure.
Okay.
Simplest,
Yes.
That is the site of leak.
Commercially available one, we have one in the department.
And see, such leaks, they are very tiny leaks and most frustrating as well. So what you need to do is, you have to completely denude this area, completely. See, once you are sealing,
bone all around.
Yes, there should not be any shortcut in these, These leaks can be sealed very easily with the bipolar, with the cobblator, but that is not the. Can you see the site?
Yes, very well, sir.
Very good.
Just an attachment of the middle turbinate.
Yes.
So that's why removal of middle turbinate here, the part of it is key.
And I will tell you, see here, once the defect is very small, you don't need something like to push anything. I will carpet the skull base here. I will show you. But the prerequisite is surrounding raw area and the flat area. Now see the first thing what I need to do is demucosalize this area.
Yes.
There are two ways of demucosalizing. Either to remove this mucosa completely,
or cobbling.
Removal of this mucosa completely is very difficult, Can you see the site of leak? Hello?
Yes, sir.
Yeah. We are able to see.
Removal of this mucosa is so difficult, you know. So what you can do, simply you can devitalize the mucosa. Why we remove the mucosa? So that the mucosa doesn't remain underneath and doesn't lead to mucocele. Okay? So what I am going to do now, see this. I am devitalizing the mucosa.
Yes.
That will serve the same purpose of mucosa removal. Got my point?
And no bleeding, so that you have a leak.
At the same time, no bleeding. See, this raw area created by the cobbler is as good as demucosalization. What an amazing tool it is. See this? Completely one can devitalize the mucosa.
So can you take a small ball probe and show the limits, I mean the bony limits, because now it will be very visible.
Yeah, I will show that. I will show that.
You are using the same setting 9 and 5?
Yes, same. Same Madhu.
Yeah, okay, right.
So I am creating at least 1 centimeter raw area all around. See this?
Yes.
All around the cribriform.
Yes.
Sir, but have you noticed that, I mean, the patient of a sponge leak complaining of the anosmia from the operated side?
Yeah, from the operated side, yes, but since the other side is intact, they rarely complain of.
Yes.
See, this is the site.
Yes.
And what I am doing, I am cobblating it itself seal the defect. Yeah, this is 70 degree.
This is 70 degree. So, if one want to use 0 degree, then they extend the head.
See this demucosalization on this side?
Yeah. We are able to see very clearly.
See now the bare bone.
Yes.
Now the bare, see the mucosa I have removed from the ethmoidal artery as well.
Yes. The artery is now very clearly exposed.
Actually creating raw area,
all this, you know,
fibrosis
excess
and that
mucosa I have taken away. See this?
Yes.
Excess mucosa. See all this excess mucosa. And see my frontal sinus pathway is not far off.
So that was a supraorbital cell, right?
Frontal, yes. Not supraorbital. Yeah, this is supraorbital.
Yes. What is supraorbital? Frontal is the above.
Yeah, the frontal sinus outflow is not far off. See this?
Yes. You can see the posterior table of frontal sinus.
So all this excess mucosa I have elevated. See on this side, and this side is completely denuded. So now we will check everything again.
So actually, sir, in these spontaneous cases, we give Diamox, as you mentioned in the previous case. We give it for 4 to 6 weeks with.
No, it may. Sometimes you may have to take longer.
Slowly.
You may have to take longer, depending. Every patient has a different high pressure profile. You cannot, segregate so. See this raw area. Now, in order to improve this raw area better, I have to do some more. I will give it such a seal that, because these cribriform high pressure are notorious leak. Don't consider them simple leaks, because the high pressure is the etiology behind, and sometimes there are multiple small defects. I will do a sort of carpeting now, or whatever elevation depressions, I will settle them. See all around the raw area. Drill. थोड़ा कम ही रखना.
This kind may seem radical to some, but it is very important for long-term success.
Yeah. So whatever elevated areas, I am flattening them.
Flattening it. So
So Dr. Nageshwar Rao from Vizag is asking about the Paul Casanova flap.
Paul Casanova flap. I mentioned during the cadaver
Dissection.
that is the anterior ethmoidal artery based flap. See the flat area covered, cleared. See this?
Yes.
That bony overhang has been taken care of. So that is the anterior ethmoidal arteries in different situation very soon to close. And there are many ways to close. See now, absolute flat area. Can you see?
Yes.
My defect was here, which I have completely coagulated, because these are small defects, and majority of the time they heal well. They close with the coagulator only. Now let me clean the area, absolutely dry or bleeding. Okay. Now I will analyze the entire skull base now. The next step is complete scrutinization of each and every area right from the frontal to the sphenoid sinus. Close up in the situation when there is no bleeding. See this now. Close up I will show you to analyze. Just a minute. The next phase is already induced. The postural खुलवा दे. No, flap मत उठाना. कुछ मत करो. Bye. मत खुला. देख.
Your husband will finish the case otherwise, sir.
Yes. See now. How's the picture?
Very good, sir.
Now see the close up. After mopping everything, close up with the marrow cell and close up view of the skull base. See this?
Yes.
This was the site of leak. See that?
Model artery also.
Can you see the still a little bit of the leak here?
Yeah?
Yes.
Now it's more clear.
See now?
Yeah.
Yes.
Little bit of the leak here.
Seen.
And rest of the skull base is pretty perfect.
The posterior model artery, sir.
Yeah. Yeah, here it is posterior. Here anterior. And see on the close scrutiny there is still a small. You see the CSF coming from here. Can you see?
Yes.
So that is the value of close up. Close up.
Sir, your tip of no bleeding should happen when you start handling this, because if the bleeding happens, you lose the track of.
Yeah, see now I am removing some more bone surrounding the defect. See this?
Yes.
See this? All this bone in this region has to go to make this defect more clearer.
Because sometimes very tiny defect like 1 or 2 mm is difficult to repair.
Yeah. That's why these are so notorious.
But sir, still various paper and textbook mentions the success rate quite variable. But I think nowadays.
See, in endoscopy, the textbooks and the publications are past. It is evolving so fast. It is evolving so fast that the present techniques what have been being done are not even mentioned earlier. So results have totally different. Indications have been defined. Now see the area. Can you see better?
Yeah, very clearly.
I will do carpeting. I told you.
Yes.
Because this is not a big defect. These defects are never big. And see, after removing the bone, what I am doing?
By pulling the.
Yes.
Coagulator.
Coagulator is key.
Coagulator in coagulation mode works like bipolar. The temperature is not that.
Yes.
So it take a bit of time to get
Now it is closed.
instrument, but it is very wonderful tool.
Now it is closed. It looks like.
Satish, now you are using all Process Max, no EVAC 70 roll?
Only Process Max.
Only
This, the beauty is,
yes,
the suction channel is wide, so it doesn't get clogged.
Ah, yes, yes.
And we make it more wider by removing the titanium tip in between. The titanium plate, so it makes it bigger. Because once if it gets clogged frequently, it frustrates you.
Yes, naturally. But Process Max channel is certainly wider than EVAC 70.
Yes.
How to break it has to be learned by sir. Otherwise,
yes, he has a special instrument of technique, like a goldsmith.
Now see, again, the area. See, now the area is so flat.
Yes.
Recipient of any flap you give, this is little bit of the oozing, but see now, the leak which was coming from here is completely gone.
Yes.
Yes.
See now, completely gone.
Yes.
Yes.
No leak at all. Can you see?
Yes.
Earlier it was from here. I removed the bone. You see the bone pieces I removed? And now it is completely gone. See that?
Yes.
Now I will carpet this skull base. See, the leak has been stopped.
Yes.
And then I will put a flap. So now 0 degree. I will harvest a mini Haddad. And quickly rotate there and finish it off. That's it. The fat has been harvested. The next case is ready. The last one. See this. See what I will do. What is mini Haddad? Not a classical one, but I will, now knowing the anatomy of the vessel, you can modify your flaps. Extended, mini, whatever. Now see, the vessel is here. See that? Yes. And our area to be rotated is there. See how flat area it is.
Yes.
See, completely, demucosolized knife. And what I will do, see this, the pedicle is here, so I will take the lower incision there and come anteriorly like this, not going to the floor. See this?
Yes, sir.
Not going to the floor. And this upper one is taking at the edge of the raw area.
Yes.
See this? Not going further anteriorly to the classical Haddad position. See this?
Yes.
And the good point is that if you want this flap, I have used in one case, after using mini, we can use again a typical Haddad flap.
Yes.
Because of the
Whatever support.
Yes.
It's about 1.5 centimeters vertical height.
Yeah, that is good enough. See what a flap it is.
Yeah.
And we didn't inject anything for that matter. So just
yes.
see how this flap is coming. Quick, in no time, 2 minutes time, you can raise the flap.
Yes.
And this will give amazing, primary healing. Yeah. Now these days we are doing more and more this for the primary healing to that area.
Look.
See this?
Yeah.
See this? Uthai.
So what will be the last case now, CSOM, with
facial nerve decompression?
Facial nerve decompression.
We'll quickly finish off.
Okay, sir.
Tired?
No. they still want to glue to the screen, so they're asking what will be the last question. Many viewers are asking.
No, we have already induced. See now, what I am trying to show you. सक्षम करना है यहाँ इस पे. What I am trying to show you, the dimension, how it is going to reach.
We thought this year we will miss ENT live at Agra.
See this?
But we are having the similar run.
Yes. Thanks to Pachauri boss. See now, this flap is being rotated up there to the area of interest. Can you see now?
Yeah, super.
Yes. Very well, sir.
Beautiful. Very nice.
Come on.
Dot Nani.
See now, this is coming so easily, so nicely, and that will cover everything. I can increase the dimension, length according to the need. Okay?
Yes, sir.
Now give me cobbletter first for the edges which are bleeding. See, these are the edges of the incision which commonly ooze, and what I will use is the coblation. Okay. Okay. Now back to 70 degree for the final closure. Give me flat. Okay. Whoa. Flat kar de. Okay.
Yes, sir.
And we have to now just carpet the skull base and come out. That's it. Last 5 minutes job on this case, and this will ensure
peace of mind for both patient and surgeon.
Yes, great peace of mind. Believe me, you do and forget about it. Because imagine a patient coming for the revision which you have done. It is n number of times more difficult, you know. Now can you see? Get the Merocell.
Yes, the leak is very evident, sir, now.
The leak is already stopped.
You use rifampicin, na? So this is rifampicin soaked?
Yes. By cobbletter.
And from the edges we can understand that how vascular this flap is.
Yes.
Because the vessel is going through this.
Now see the final picture of the bed. See now?
Yes.
Completely, this was the area of the leak which I have completely settled with this thing.
Yes.
Tissue glue.
Yes.
That's it. Tissue glue has an additional ability besides the sticking, purpose. It induces a strong fibroblastic reaction. That is important. Supplying the fresh, recruiting the fibroblast to the area. Now, having done this, my next goal, see now, the closure of the leak has become a cakewalk. Hardly anything. See now?
Yes.
It was the exposure which was important.
Right.
See now the role of creating the raw areas. We have such a big series of these leaks, and this is our standard way of handling them. See, why I created this big raw area all around.
What is the role of fat? What is the role of fat over here? Because we could have put graft directly over there.
No. Fat is something which provides the fresh fibroblast. See now, why I covered, why I needed the raw area. See this surrounding?
Fat survive even in low vascularity.
See what area?
Yes, sir.
Yes.
And see how close it is to the frontal. That's why we need to ensure that it should not block. Unless and until we don't open this frontal recess widely, how we can have idea?
Are you following this prophylactic sinusotomy right from the beginning or changed nowadays?
Change. No, couple of years, not these days, couple of years now.
Couple of years, because I have seen your old videos. This, I can say, prophylactic sinusotomy was not done, and good. Yes, it's a futuristic management.
Sir, you are using Baxter glue, sir?
Yes, that's Baxter.
Yeah, that
Now see, having used this is a complete, now see, where is the cribiform, how can the CSF leak can come? See this?
Never.
See this? Completely the entire cribiform carpeting is done. See this?
Yes.
And now the next step is some more glue is left behind. I can use it.
Gel foam.
Sir, the Baxter now have a double lumen cannula.
Yes,
so I am
yes.
using it since last 3 years.
Last case I get the same one.
Yeah.
Very good.
Yes.
So it's very good and it can be reused also. I mean, and
see now the same.
1 ml is enough.
Same, you know. Give is rifampicin inside, glue. Now, see this for the constant uniform pressure.
Yes.
Yes, sir.
This is important. This is soaked in ciprofloxacin. And this is what our,
Sir, what is your post-op protocol for antibiotics in these patients?
in these patients, topical antibiotics have a bigger role. See the frontal. So good. Sometimes if you have a narrow and if you have a doubt, you can put a temporary, tube working as a stent.
Yes.
Got my point?
Yes.
Yes.
Do I show you?
Not needed simple, because we can keep it over there.
Yeah. What you can do simply, you just cut your, IV set, the drip set. Take a 5 to 7 centimeter tube, put one end there and another end in the maxillary to keep this sinus draining for 5-7 days until whatever time keep this, things in place.
Satish, the lockdown in Agra in UP from tomorrow. I think many states have. They're asking we can keep the surgery every day.
Lockdown in Agra?
Yes, in UP.
Even in Kolkata. Even in West Bengal.
Again, started for next 3 days.
Lucknow, Patna. This is
full UP, all UP.
So see what I've done. I'm pressing this, gel foam with this. And that will exert the uniform pressure over something which is already exerting a uniform pressure, and now I will make it swell up with the betadine. See now it is constantly pressing upon.
Since the Celastic is more expensive, we can use the gel. We use the gel
Yeah, this is actually not Celastic. What I am using is that it's the same from the packet of gel foam. You need to interpose something which is, non-sticky. The idea is to interpose something which is non-sticky.
On the pack it does not.
Whatever is there.
Yeah, so when you remove this, your gel foam and other things should not come out. See this?
You any experience with artificial dura for the graft? Those who are very...
Duragen is there. Duragen is quite good. We have used
Duragen you can use. That is good.
Yeah,
and see now to keep this in place. Keep this in place.
It's like a substitute of facial atta.
Yeah, facial atta. It's very available also in market also.
You can use Duragen. And costly.
It's very expensive. I used 1 or 2 cases.
3x3 cost something around
12,000.
Sir, what is your experience about CSF otorhinorrhea?
Yeah, we have seen couple of times as patient presenting with otorhinorrhea, I tell you a very interesting story from an ENT surgeon. Some patient presented with a fluid behind the eardrum. He went to an ENT surgeon, he put a grommet. And that led to CSF drainage starting. It was a CSF rhinorrhea which was collecting behind the eardrum. At the moment the surgeon put the grommet, it started coming out. And that patient started blaming the surgeon for the CSF discharge. That he has given a CSF leak.
So actually there are some natural areas.
So be careful. Be careful for such situations because CSF otorhinorrhea is not uncommon. CSF rhinorrhea coming and going to the Eustachian tube to collect behind.
Very common.
In the next week or so, we'll be keeping a case with a temporal lobe prolapse in the ear, where we are going to use the middle cranial fossa approach. For the
do you remember first case in our workshop?
Yes, in Agra, I remember.
Yes.
Yeah.
Big cases. He is doing very good.
Okay, so any question or do we move on?
So you can move on, sir.
Amit?
No, sir. We can move on.
The last one, quick.
Yes,
This patient is a young male. I will show you his first of all picture.
Many people are waiting for this case actually.
Yeah.
Oh, where is that?
So in CSF leak, sir, we give antibiotic, usually the ceftriaxone 2 gram BD.
What is your choice?
Top, because that has the maximum penetration of in the CSF space.
Yeah, ceftriaxone is a good penetration. Where is the downloads? Yes, I will show you. I'll show you this video of this patient. First of all, see this.
Yo, man.
This patient has a history of ear discharge for long, intermittent ear discharge, and now for last 1 month he had developed this facial weakness. See, on close inspection he has a deformity. It becomes obvious even on the without expression he has a deformity. See this face, this side.
Yes.
It's less expressive, as compared to the other side. So this is, to me, is grade 4 facial paralysis, and we have a CT picture of this patient. See this. Now on Sunday we'll discuss in detail about the radiology, I think, of the such cases, because cholesteatoma and other CSOM, they need to be evaluated in detail by CT scan. CT scan is game changing in otology, particularly in cholesteatoma.
Agree completely, sir.
It gives a lot of information, anatomical details, and those anatomical details are important in decision making. Intraoperative course in finding difficulties pre-op, preventing complications, planning approach, canal up, down, so many things, issues can be resolved with the CSO, with the pre-op CT scan, the status of tegment, this plate, ossicular status, any abnormality, everything can be seen. Now this patient, I'll quickly come to the point because we'll discuss this in detail on Sunday on cholesteatoma case. We'll have a cochlear implant and then cholesteatoma. So here, what we see in this patient, if we come from above downwards, this is the the superior canal here. This is one of the ways to find the pneumatization. You see, beyond the superior canal, medial to the superior canal, there is no pneumatization. These are the patients which are considered as hypopneumatization. This is one of the ways. Then as you go down, at the level of the ossicles in the aortic, see, ossicles have gone.
Yes, sir.
There is hardly any ossicle. In the name of ossicle, I can see something here like a stump of head of malleus or something, otherwise nothing else. And see, at this point, if you see the level of the sphenoid sinus, the sigmoid sinus, you can assess again the level of pneumatization. There is no pneumatization beyond the anterior wall of the sinus behind. That is again a hypopneumatization. And see, this is a small mastoid, you can say contracted mastoid.
Yes,
see,
sir.
very small space of the mastoid in the axial section, and this patient has a complete opacity in the middle ear,
Mastoid cavity.
completely, and this opacity is extending into the exotic canal.
Yes.
Obviously, the eustachian tube recess and all that is
Yes.
affected. But the more important findings that need to be directly seen, number one, the lateral semicircular canal. See this completely intact.
Yes, sir.
Yes.
Then the facial nerve. See, this is the facial nerve going there.
Yes, sir.
See, this is the facial nerve.
Yes, sir.
The first genu, and now see the course of the facial. Now this is completely swollen.
Yes.
Mugged up in factory.
You see, as compared to the opposite side, let me see the opposite
Yes.
side facial nerve.
Yes.
See the difference. And this side facial nerve
Real
is,
facial canal bone is gone.
yes, see the bone is gone, and it is complete. There is no bone over it, and it is
Yes, the mass is encroaching the.
swollen
Yes.
up to the geniculate ganglion.
Yes, sir.
Now, if I follow it later, if I follow, this is the facial nerve. See where my cursor
Vertical.
is. Where
Yes,
my
sir.
cursor
There
is.
also.
This
Yes,
is the facial nerve. This is the facial nerve vertical segment. See this?
Yeah. Yes, sir.
And that comes out through the stylomastoid foramen. This is stylomastoid foramen. So
Yes, sir.
if I follow it back, this facial nerve. Now see,
Vertical part.
at the second genu, the facial nerve is uncovered. If I follow the entire tympanic segment, is uncovered, and it looks like fused with the this opacity completely, and this facial nerve is enlarged, and this is something completely swollen up.
Is there some lateral canal fistula also?
No way.
Looks the bone looks to be little
There
eroded.
is no way. See the thick bone around the lateral canal. Can you see? This is the lateral semicircular canal, the signet ring. This is vestibule, and this is the lateral canal, the the ampullary and the non-ampullary end, and forming the signet ring. This is complete lateral canal, which is laterally, it is completely intact with the bone over it. Can you see the bone over it?
Satish, maybe it is thinned out. It is thinned out.
But this is good enough. There is no fistula. There is a clear
No
cut bone
fistula.
over it.
Mhm.
And the opacity, yes?
Satish, at 2 o'clock position of the signet ring, there is some amount of demineralization and.
Now see.
That you have to see dynamic. See this dynamic.
No, it's okay. Yeah.
In one plane you may not find. See this? So we have seen the facial nerve canal relevant to this case. We have seen the lateral semicircular canal. Many a time this is eroded when the facial is, affected by the disease.
Even on the opposite side also there is
pathology.
Pathology. Eventually.
Pneumatization is very less. See the canal and see the facial nerve is very distinct, very important, very clear.
Yes, sir.
And this is the vertical segment. This is chorda tympani here. See this chorda?
Yes.
And this is the round window, and all these things, the opposite side is normal, but it is hypopneumatized. Now these things, just quickly before the case is ready, if I see on the axial, certain anatomy is seen better on axial. Now see. First see on the normal side. Normal side, see the ossicular chain, and this tape is going into the vestibule.
Yes.
Okay.
Yeah.
Very clear?
Yes.
Here. Now see here. This is your vestibule. Now one by one you can see all canals. First go by superior. See, follow it. There is a thick bone over it all the way.
Yes.
See this? Then come the lateral canal. See the lateral one? And there is a bone over it. See this? Can you see?
Yes.
Very clear. And similarly the posterior canal. See this? That's the lateral intra-aortic canal. So all these semicircular canals are nice. There is nothing, this is the posterior canal. This is the posterior canal.
But the
This is posterior canal. See this? This is intact completely and forming the crus commune with the non-ampullary end of the superior canal. Can you see this?
Yes, sir.
This is the non-ampullary end of the posterior and the superior, and forming the crus commune. So now at this point of time, this is the intra-auditory meatus and this is the facial nerve which is emerging.
Yes, sir.
And here is the facial nerve. And if you see the lower down part, this is the vertical segment of the facial nerve.
Yes.
And as I go, vertical segment of the facial nerve. See, the facial nerve is completely fused in this opacity.
Yes, totally
Completely fused. We don't know, and this is extending to the intra-auditory, the extra-auditory canal also. For last 7 days, this patient was on, antibiotics and steroids. Had a lot of discharge, which is quite cleared up. Has a granulation tissue coming out of the tympanic membrane, and what is there going on inside is a mystery. So, majority of the time it is because of cholesteatoma, but in India, many times we see the same findings in the tuberculosis also.
Yes.
Tuberculosis you can make out by the classical osteomyelitis it gives. Absolutely unpredictable, unrelated symptomatology of the tuberculosis, out of proportion. Many a time patient with tuberculosis present with sensorineural hearing loss. This patient has a 70 dB bone conduction loss as well. Out of proportion sensorineural hearing loss, out of proportion facial palsy, out of proportion all these symptoms are classical of tuberculosis. Many times out of proportion pain, out of proportion discharge, sometimes very scanty discharge, very painful, sometimes very copious discharge. It's so variable, tuberculosis is. And this now such a case, the surgery is a big role, and not only that, to treat the condition, but to confirm your diagnosis behind this facial palsy. The etiology, whether it is cholesteatoma or tuberculosis, if it is, we'll take the tissue for histopathology, and if it is tuberculosis, obviously the ATD is the mainstay of treatment. So surgery has definitely a role, and which may be followed on by other things if required, like medical treatment or so. So the goal is exploration, okay, and let's see what it turns out to be.
What about the haziness on the right side also? Some amount of haziness?
Right is okay. Right looks okay.
Yeah, some amount of opacity. Not very normal. But otherwise, right side, the middle ear is good. The ossicular chain is so good. See this? The scutum is good here.
Yes.
See the male ear, incus, stapes, everything is good. The scutum is good, otherwise no erosion. See the scutum. And the middle ear is aerated. Even the semicircular canals, everything are good. The facial nerve is absolutely normal. See, this is the facial nerve. This is the horizontal facial nerve. Here.
Yes.
Left side scutum, Satish, diseased side.
Disease side is partially, it looks like eroded, not very eroded. See the scutum.
Yes.
Not very eroded. Again, this goes against the diagnosis of cholesteatoma.
That's what, because so much amount of facial palsy and scutum is still relatively good.
Classical signs of tuberculosis, sometimes you go to the, some of the patients, they have a complete opacity to the extra-auditory canal with the scutum intact, and sometimes even the mastoid ear cells are normal with the disease limited to the middle ear segment. That is classical of tuberculosis sometimes.
How old is the patient?
He is a young chap. He is 18.
How often you see tuberculosis mastoid?
Very common.
Here we see quite often. And I have the sixth sense smelling the tuberculosis here.
That's
with
what
a classical osteomyelitis. Classical, the osteomyelitic bone, and many times if you are not very vigilant, these patients present post-op, like you have done a mastectomy, and after some time the patient coming with a osteomyelitis picture in the cavity and presenting with facial paresis or something like that, and then you have to immediately start ATD without even waiting for the histopathology. Sometimes even the histopathology, in spite of good tissue, it doesn't prove tuberculosis, and many a time you have to give empirical, because for the pathologist to prove it, they have to see AFB, which are not seen.
So therapeutic trial you can start.
Yes, many a time on the clinical grounds, empirically you have to do ATD.
Pathology, plasma cells, and
corroborative findings. There are so many. Rather, we always take the tissue for the histopathology and RT-PCR as well.
You subject tissue in every mastoid for histopathology?
Not every, but whenever there is suspicion.
When there is suspicion, okay.
Yeah. See, these patients have
out of proportion symptoms. In
How
terms
far
of
RT-PCR reliable?
in terms of osteomyelitis, facial palsy, hearing loss, discharge, whatever, pain, then you have to be careful in sending such granulation and such tissue for histopathology, both for HP and RT-PCR.
Yes, 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 yes. Same thing I think I discussed in morning. Same case I did in morning. That's 50-year-old lady. She saw grade 5 palsy. I opened it and it was a cholesteatoma involving the horizontal as vertical portion. Decompressed it. Let's see how she behaves.
So now, hello?
Yeah.
Hello?
Hello?
We are with you.
Yes, sir. Satish, we are with you. We can see you.
Oh my God, not yet opened. We thought that somebody has given the incision and opened it.
No, I'll do it quickly. I didn't want to because the findings here.
Go inside out because this mastoid is very less pneumatized and almost no mastoid air cells. Or you will do usual outside.
So this is a clear-cut bias towards a canal down.
Yes.
Once you have such a narrow mastoid,
no doubt.
We'll discuss so many factors which are important in decision making in cholesteatoma surgery. I will enumerate so many n number of factors before taking a decision, and the final decision is on table.
Yes,
So this is one of the factors, like Amit mentioned, a narrow mastoid. You know, this is a strong bias towards performing a canal down, because here you can avoid the problems of the canal down, which is because of a bigger cavity, which you are not giving anyway.
Yes,
And avoid the situation of a second look straight away. Now, this is a section. Find out.
So, sir, actually, this will be the first case in our webinar, which will be an otology.
Pardon?
This will be the first case in our webinar, which is an otology case.
This was today.
Yeah.
Today is supposed to be the first case, huh?
Yes.
Yeah.
People are waiting since 4 p.m. for this case.
Oh my God! And I'm sorry we didn't discuss in detail as well.
Yeah.
Today is now 10th.
But we'll discuss cholesteatoma in detail on Sunday. Cholesteatoma is one of the most fascinating surgeries in otolaryngology, I tell you.
Yes.
Every case is different. You have to do a lot of decision making in cholesteatoma, that too on the table, finally on the table.
Yes.
Paramita, the best speaker is always given the last chance, because everybody will wait. The same way, everybody is waiting for this case.
Otology, yes.
Okay.
Yes, sir.
All are glued to the screen.
All are glued, yes, sir. I got a message from John Shadow from Australia. Who it's 4 a.m. in Australia and he's still watching.
Morning there.
Yeah.
He is, I think, our best friend. I think since first webinar he is with us. He's seeing all
last time one guy, I saw the message from one guy that Dr. Satish Jain is the cause for my divorce now. And probably the way they're going, I may be blamed.
There are so many, including few of us also.
Including me.
Everybody is cursing Corona, but I am telling thanks to Corona, because of coronavirus he is conducting so many webinars.
So Dr. Devang Gupta from Ahmedabad is conveying regards to you.
Boss.
He is our.
Good evening, Devang sir.
We appreciate him every day.
Hello.
Devang sir is my teacher.
Achha, really? Okay.
Is Dr. Devang there? See, why I am showing from the beginning is, in every case, the policy is to create an inferiorly based flap.
Yes, sir.
Which may be used or not. If not used, we'll reposit it back. But this gives you a lot of opportunity at the end of the surgery to reconstruct your cavity.
Yes, sir.
See, this is undermining behind.
Yes.
So, sir, while you're doing this, you can as well tell us about the intact canal wall and canal wall down. When do you decide?
Yeah, that's what I told you. We'll discuss on Sunday. There are more than,
Many
20,
points.
30 factors which you need to mop. You need to take into consideration to decide. You cannot be biased towards pre-operatively performing any particular approach. See, our terminology is different. Intact canal or canal down is a traditional terminology, but there are a lot of things in between. You are doing a canal down and then you reconstruct the canal. What will you name it as?
What?
Nothing.
Doing it what?
You have done a canal down and then you reconstruct the cavity. What will be?
It is an exteriorization of, I don't know.
So our policy, our terminology is interiorization or exteriorization.
An exteriorization, yes.
That is the correct terminology in the sense.
Yes.
Interiorization means when you are giving a ear dependent on the Eustachian tube for its aeration.
Yes.
Can you repeat?
Interiorization is a terminology wherein you reconstruct the ear to the level that your ear is dependent on the Eustachian tube for its aeration. Interiorization.
Interiorization.
So it depends on the middle ear mucosa as well, right, sir?
And exteriorization is the terminology
Where you
when you remove all the air cells.
Yes.
Exteriorize towards the exterior, and you are not really dependent on the Eustachian tube much.
Yes.
So these are two things.
Yes.
Now, if you are doing a canal down, and if you find that your Eustachian tube is good, and your mucosa is good, you can still interiorize by means of reconstructing. So that's an intraoperative decision.
Yes. So you are planning to take a interiorly based flap here?
Yes. That is most important. See this? This is such a vital flap. In case I give a cavity, this will be needed to line the cavity. So once you are giving a cavity, don't leave raw areas to discharge.
Yes.
And see such a big flap that reduces the cavity, it lines the cavity. It is robust flap based on the occipital artery.
Yes.
It has many advantages,
Yes.
And if you don't need it, suppose I will resuture it.
Yes.
So there is no harm in it. So what I was telling, Paramita?
Yes, sir.
Interiorization and exteriorization. So what is interiorization? What I was saying, when
depends on the Eustachian
tube. Now what does the Eustachian tube do? It delivers the air intermittently to the ear. Because the air is absorbed continuously by the mucosa.
Yes.
Okay?
Yes.
So, if you leave the middle ear mucosa intact,
yes,
and your Eustachian tube is good, your interiorization will work.
Yes.
Okay?
Yes.
See, both techniques are good. The issue is to be executed properly and for proper indication.
Yes.
So, the technique should be executed properly and for proper indications.
Yes, sir.
So, like, for example, why I am saying so? If you have a good Eustachian tube function, but during the surgery, you end up removing all mucosa.
Then
what is the fun of interiorization? Then what you will be doing? Blowing the air in the bony trumpet.
Yes, sir.
Without any mucosa for the air exchange.
Yes.
And what will that intact canal do? It will be an utter failure.
Yes.
Then what to blame? What to blame? The intact canal procedure. First of all, it is not properly executed and not properly for the indication.
Yes, sir.
What my point? If during surgery,
that's where we need breathing mucosa.
Yeah, for the gaseous exchange.
yes. So when you think of interiorization, this is an intraoperative decision
Yes.
Whether at the end of the surgery you have a good healthy mucosa left behind for the gaseous exchange.
Yes.
That is only when the interiorization will work, you know.
Yes, sir. Yes, sir.
Not for every case you do. See this robust flap.
Yes.
And beauty of this flap is, see how the vascularity. The vascularity comes from the depth. From the depth here by the occipital artery which comes from deep.
Yes.
So the artery is always preserved when you elevate it from surface. See this, what a robust flap.
Yes.
Now if I need to use this flap at the end of the surgery in case needed, if not needed I will deposit it back. Simple. If needed to introduce into the cavity, I need to remove the mastoid tip. Okay?
Yes, sir.
We can take superior flap also, sir. You taught us required if you don't want to remove the mastoid tip.
But inferiorly based is more popular and easy
Yes,
to
because
manipulate and
you can swing in like a curtain inside.
This is such a robust flap.
Yeah.
It works so well, suction.
Yes.
That's why I'm raising the right from the beginning. I'm showing.
Yes.
Okay.
Yes, sir.
See, this is so simple to elevate.
Yes.
It's not difficult at all. This suture laga maan. And I will reflect it.
So do you get post-operatively necrosis, I mean discharge because of these flaps anytime? If it's said that excessive use of cautery can lead to hamper the
Not
blood
really.
supply?
If the vascularity is good, they do very
artery
well.
is a very big artery.
Yeah. So you have to respect the vascularity, understand the vascularity concept, and then use. Okay. Periosteum. So the cholesteatoma surgery is one of the most fascinating surgery, right from the decision making to execution of the technique. So like if you are doing exteriorization, you have to do every possible thing to exteriorize the cells. Because then if you leave the cells behind, they will secrete.
Yes.
And then cavity will discharge. The patient will have a discharging ear. So if you are doing canal down, it's a wonderful procedure if executed properly.
Yes.
If doing intact canal is a wonderful procedure if executed properly, means preserve the mucosa.
Yes.
It is the proper indication and the proper execution of the technique which is important. See, many a times you will find in the conferences unnecessary fight which technique is better.
Yes.
I fail to understand why. Both techniques are good. To me, this question doesn't exist which technique is better.
So
In no
this,
sense. In
these
no sense.
concepts are not known to many, sir, about interiorization and exteriorization.
Yes, that is important when to do and how to execute. So in the coming webinars, we will be keeping a lot of cases of cholesteatoma,
Yes, sir.
different situations, you know.
Yes, sir.
See the thick flap. Thick flap is a sign of ongoing infection,
Infection.
Yes,
inflammation. See this thick flap. This was a buttonholing that will suture if we don't do a canal down.
Not a good sign.
Otherwise, this will include in the canalplasty, metoplasty. My God, so much of inflammation. See the status of the cavity, the canal.
Yes.
So Dr. Satish Jain, sir, is a common name in each and every household now. There's a message from Dr. Rajendra, Jodhpur.
What message?
Dr. Satish Jain is a common name now in each and every household. Each and every family member of each and every household knows this name, Dr. Satish Jain.
To blame.
to attend sir webinars. I have
Villain to blame. Circular. ये इसके retractor लगा. See this excess thickness I am removing to improve my access. See this?
Yes, sir.
Otherwise it was so difficult to visualize inside. वो देना उल्टा दिया.
Have you seen external auditory canal cholesteatoma presenting like this?
Yeah. There are a lot of terminologies to that. See this polypoidal. Give me the knife, Dana. 15. See this, I have thinned out this flap. Let me settle this like this. See now? Now we have a good view inside.
Yes, sir. We can see that.
And see, this is the polypoidal.
Pale, very.
And
pale.
see what is this?
Yeah, this looks like tuberculosis only.
Yeah, osteomyelitis. See this? This is osteomyelitic bone. Classically green bone. See this? This is very common in tuberculosis.
Yes.
See this?
Yes.
And the kind of, I told you opacity extending into the external auditory canal, that is again going in the favor of. And see, there are a lot of granulations inside.
Need much, but this one is quite.
What is the role of starting therapeutic trial of anti-tuberculosis 1 week or 10 days before surgery?
But how will you suspect?
No, there's nothing harm if you do the when tuberculosis reduces the vascularity and gives you a much better picture.
Yeah, you can do that, but see, once there is a facial palsy, you can't wait for long, man.
Yeah, I agree. Yes.
The sooner you do, better the results are. This is most likely to be tubercular. I tell you, बढ़ा देना यार, wash कर बढ़ा दे. इतना बड़ा नहीं यार.
Will you send that lying inferiorly for the palsy?
So do you obliterate the cavity in tuberculosis in these cases also if you do a canal one?
No.
Yeah.
Depending upon the situation. Let's see now. This is little bit of, I just remove this granulation there. And see the amount. See this bone.
Yes, sir.
This is classical of tuberculosis, such kind of osteomyelitis. See this?
Yes.
You know Rajeev Jain from Lucknow, Satish?
Cotton ball. What was?
Dr. Rajeev Jain from Lucknow, a student of Amit Kesri. He just wrote me, my wife says you take Dr. Satish's name more than me in 24 hours.
Rajeev, tell him he's not alone.
I think very soon I have to hire a lawyer.
Yes, many people will.
We are making some arrangement to arrange some lawyers for this thing also.
Yes, Satish, boss.
Hi, dear.
Ashim.
Hi, boss.
I listen listening to your name, sir.
Champion is there.
I have been seeing you actually since early evening, but I was on the Zoom. I was not on Zoom. I was on the experts meet.
Oh my God!
Awesome work, boss. Awesome work. I'm telling you, you are one of the best ENT surgeons on the planet. I'm telling you.
Oh, come on.
Ultimate.
This case is best for you, boss.
Yes.
I remember the last case you did in our workshop in Jaipur. That tuberculosis otitis media.
Ultimate.
See, whenever we do otology workshops in Jaipur, all bad cases are designated to Ashim Desai by default. Ashish will always say, ganda case hai, Ashim ko de de.
That is, Dr. Devang has joined us.
Hello.
Dr. Devang?
Hi boss, how are you?
Fine,
Haji,
fine.
how are you?
Sir, all well sir. आपके आपके चमत्कार देख रहे हैं?
सबको नींद से उठा दिया.
नहीं नहीं जग ही रहा हूँ मैं.
I
देख
just
रहा हूँ आप.
messaged him. I just messaged him. Yes, since if you are awake, then join us.
नहीं मैं
See
देख ही
now,
रहा था.
now two things are clear in this case. First of all, he has a very narrow mastoid.
Yes, yes.
Second thing, this looks like tubercular. Now let us open from behind to see what can be done. Because I'll take a good tissue for the histopathology here. See, this is the chorda here.
Yes.
Lateral to the chorda and entering into the middle ear. See, lot of full of granulation tissue. Full of granulation tissue. So tuberculosis is a bad disease, and these cases are bad. They are going to. इसे एक साइज बढ़ा दे section. Cotton ball, cotton ball. Ashim boss, you did in Jaipur.
Yes,
case.
yes, very similar case.
Oh my God! See this osteomyelitic bone. Everywhere you are finding the same bone.
Yes, yes, yes.
Necrotic bone, greenish necrotic bone, is classical of.
Very classical of tuberculosis.
Yes.
But these patients are very good patients. They respond very well.
Yeah, they will respond
Yeah,
well.
they will respond very well. Yes,
Yes,
as you
yes.
said, anti-tuberculous you start, they
Yeah,
will
yes.
really respond very well.
But now we have to see, the most important thing is we have to see what has gone wrong with the facial nerve. There
What
could
is
be
the
four
duration of
situations,
ATT
you know.
you give? What is the duration of ATT you give in these patients?
No, I have not started yet.
No, no, no. If at all it comes tuberculosis.
Yes, at almost 12. We sent to our physician.
Okay.
He gives, I think, for 12 months. I don't know.
That's what, it's a bony tuberculosis.
Bony tuberculosis is more resistant.
Actually, we give for 18 months.
Really?
Yeah. We extend it a little bit longer.
But all four drugs or 4 drugs, 3 drugs?
No,
and
no, no.
2 drugs?
Four drugs for 4 months.
Okay.
And then taper down to 2 drugs.
Okay. Now, regarding the facial nerve, there could be 4 situations. There could be edema of the nerve, there could be compression of the nerve, swollen nerve, there could be, thin fibrotic nerve. That is a clear-cut indication of a resection and osmosis. So let's see what turns out to be. What is your take, how it is going to be in this case, boss?
Boss, I feel that this is going to be an exposed nerve. I don't think I expect a thin and fibrotic nerve. I don't think the duration has been that long, right?
Sir, while taking biopsy, will you take like 2 different biopsies, one from the middle ear differently sent separately and one from the mastoid cavity separately?
Yeah, you can take from the most representative tissue you feel like.
Okay.
See, in this patient, like earlier Amit said, I am biased towards a canal down situation because of the narrow mastoid. Let's see inside what it turns out to be. Because if not a big cavity, I can take it down quickly.
Satish, I would tend to agree with you.
Yeah. Regarding taking the canal down?
In this kind of a case, yes, I saw the CT scan, it was extremely sclerotic.
Sclerotic, yes.
Yeah.
And we can justify
You
him
will need a 270
cavity because
So then you don't do an inside out technique or?
No. Inside out is more blind in my hands, but I don't know. Satish also does not like to prefer inside out.
Inside out, I like if I have a MRI. If I am doing for a cholesteatoma inside out, MRI will tell me how far it is extending. Because in inside out, if you go finding that the cholesteatoma has come and then you stop, you may miss the cholesteatoma behind. Number 1. For that matter, there is no debate inside out or outside in. You have to follow the according to the situation. There are so many unnecessary debates.
Unnecessary debate, exactly. Sir.
True.
See the sinus plate, so narrow a cavity.
So what about the hearing in this patient? Hearing status of this patient?
Hearing is 70 dB sensory neural loss. Show the audiogram. See this? This way the surrounding soft tissue too. This soft tissue from surround all inside. See this?
Yeah.
And here the same thing.
I think, sir, do you still publish those post-operative advices? I would see them while I was doing my residency.
Gujarati, English, Hindi, and
Marathi.
Marathi, yes.
See, so sclerotic it is. So sclerotic it is. There will be hardly any cavity, you know.
See you again after such a long time.
Yeah, Ashim, I didn't hear your voice. I'm just seeing you now. You are there. No, Rajiv, never did. See, last step is certainly I was there.
Awesome. Very awesome. I mean, Madhu, you're setting an example for us all, Madhu.
Yes.
Very awesome.
Just work for almost 14 days in a day, I think. I just heard.
Because I am working in a rural area, because this area, and we... Yes.
Diamond.
What if you do this work in the last? Any advantage?
You can do either way. You can do.
Yeah, that's
but since we are now coming,
rather than doing it after, what do you say, Satish? Rather than opening the facial nerve after, it's better to open up all the air cells.
Whatever I may. In our technique, I mean, what we follow is we do the saucerization in the last.
In the end.
Yeah.
See, here I am simply doing this because
target-oriented surgery for this. So you are doing the saucerization, making much easier in the last time. Leave about this tuberculosis suspicion and all these things. What is the role of soft wall reconstruction for posterior canal wall?
I told you there are so many variants of the mastoid surgery between canal wall up and down. That's a complete removal of cells.
Yes.
So you reconstruct the part of that area where the cellularity is down the Eustachian tube, and it works well. It's a good idea in certain situations. Because once you are down the Eustachian tube, you have two options. A lot of people are doing. They reconstruct a middle ear. They include the middle ear.
Yes.
Around the perilabyrinthine cells.
Okay.
Because that is difficult to remove all cells around the perilabyrinthine space.
Okay.
So if you include that in the middle ear and then reconstruct down the Eustachian tube,
okay,
they can prevent the post-operative draining cavities.
Why this is claimed? Because the 3 W's, wiping, warping and weeping. Most of these cavities, they will be going on weeping or...
And see that same septal wall reconstruction is done by different people differently.
Yes.
Ashim does differently.
Ashim, what's your opinion on soft wall reconstruction?
He does differently.
We, Satish and me, follow very similar principles for soft wall reconstruction.
Okay.
Typically, what we believe in is that when there's excessive pneumatization of the mastoid, it is essential to aerate the perilabyrinthine cells down the eustachian tube.
Yes, agreed.
Now, the level and the height of the posterior canal reconstruction is varied in every case.
Yes.
There is no hard and fast rule that you must replace your cartilage exactly where you took down the bony canal wall. Because after all, a bony canal wall is a surgical construct. It does not exist in nature.
Yes.
So what happens is that you decide where you find the maximum pneumatization and that area should be aerated down the eustachian tube.
See the granulations?
To prop up the graft with cartilage.
See the granulation, man.
Is beneath the cartilage.
See the biopsy.
He's sending this for interview and the biopsy.
Yes. Biopsy and RT-PCR.
Yes, sir.
You routinely send all for suspected tuberculosis for RT-PCR and HPE.
Yes.
Yes.
So with HPE, is it difficult to get?
Difficult to get AFB. Oh, very good. This will get it otherwise.
In spite of a confirmed tuberculosis patient, you may not find AFB because the pathologist will declare tuberculosis only when they see AFB.
Yeah.
Now these all RT-PCR TrueNet machines are used for corona.
Yes, nowadays.
Yes, nowadays.
Diamond.
Coming back to the sclerotic mastoid, sclerotic mastoid likely material to do a soft wall reconstruction.
Yes, very much I agree because it's a highly cellularity is very low in this case.
And one more thing is when you are doing the reconstruction, the idea is that you must have a vascularized flap.
Yes.
Just a random flap, when you put it in, there will be a lot of sloughing after your surgery.
Yes.
So even bone dust for that matter is a good material to
No, we are actually not, Paramita, because what happens is bone dust is avascular. One of the commonest causes of persistent mastoid cavity problems is the fact that the avascular bone dust has got infected. And the second commonest cause for recurrent infections in a properly done mastoid is actually when there is not adequate irrigation. What you cause is localized osteitis due to heatal damage, and that area will always continue to be. So, excellent irrigation is a must.
But usage of bone dust has come down drastically. Maybe
absolutely.
And so, what about cartilage? I think
cartilage is wonderful as a scaffold. You know, it's like I was just telling Madhu a little earlier, we use the cartilage to support your vascularized flap so that it doesn't stop and block all the air cells.
Second, it
holds the vascularized flap above the air cells so that there is aeration down the
See the granulations?
Yes, sir.
Yeah.
These are most representative. See this?
Yeah,
a lot of osteitis.
Also, na?
A lot of osteitis, you know.
Yes.
Yes, sir.
See this? These are most representative granulations.
In cartilage has perichondrium, so chances of vascularity are well maintained.
I
am not seeing the facial yet.
Avascular thing. So it gains its nourishment from perichondrium by diffusion.
Yeah.
So going to use cartilage without perichondrium is extremely high.
Very high.
Always use at least one side.
The paper produced by Professor Plester, Steinbach and Pusalkar that says that cartilage had varied absorption rates. But when we looked at the data, cartilage, they were using all sorts of things in those days. And that is why there was a lot of problem of resorption.
Semicircular. Yes, sir.
That is the lateral canal here. See the thin blue lining.
Yes, sir.
You can make out.
That's what we are
That's what seeing. Yes. The CT scan. Yes.
And
So it is not
in the anteromedial lap of this canal.
Yes.
Is the facial now.
Yes.
And it is completely
exposed.
Decent.
Decent.
Yes.
And in that lap,
Is use the largest possible for the area.
But I think for juniors, I think we should recommend diamond at the level.
Patli the diamond. Oh, so this facial nerve is
bleeding also.
Yes, it is edematous.
Yes.
all these perilabyrinthine cells,
Yes.
cells along the tegmen, all this. Now we have seen the facial nerve there. Like Dr. Ashim said, we have to go and find the entire course of the nerve.
Yeah.
Soon.
I think you had low down the posterior buttress so down.
Yeah, I will. See, completely right up to the anterior wall of the attic.
Yes, sir.
Yes.
There should not be anything hidden there.
Yes. That is the main site for recurrence of cholesteatoma if there is.
Supratubular.
Yes.
See, all bad
Another
granulation.
thing is that if you are keeping an open cavity, the perizygomatic pneumatization also has to be taken care of.
Yeah.
Mm.
And sometimes it can be deceptive.
That's what deceptive that is, because the
The
perizygomatic
open
cells
cavity is a
clearance-
difficult operation. I mean,
So that is the part which is bleeding anteriorly. Is it the soft tissue there or?
yes, we saw the soft tissue going into the schition tube area also.
Yeah, so that is the soft tissue which is
supratubal
going into
area.
the supratubal area. Yes, sir.
Yes.
So I think that area is also
See
bleeding.
this supratubal
Yes.
area.
Yes.
See, the middle ear is completely full of this all nonsense tissue.
Yes.
How will you prevent any stapes if it is there? Where we don't think that's there.
Pardon?
Foot plate. Foot plate. Yeah.
concentrating
I am
on
not
healing
working in the
aspect.
foot plate region like this.
Yeah.
Okay.
I will see that region first.
Later.
Satish, did you start any steroids pre-operatively?
Yes. He has been on antibiotic and steroids both
Yes.
Okay.
for last 5-7 days.
So you are back to almost normal surgeries, normal number of surgeries in your center, sir?
No, boss, very less. 10%.
Only 20-25.
He's only at 20 surgeries a day.
Okay, right.
I think in the corona's pandemic, he's the only person doing live surgery webinars. You just tell me in the whole world.
Agreed.
You about
Yes,
India.
yes. Agreed.
Really? No one is doing?
No. This is the only live surgical.
Stop
This is
doing lion workshop, sir, I think.
the only live surgical webinar, and we are very thankful. Satish sir for organizing, and Sun Pharma, Pachauri sir, really thankful to all of them
And we are thankful to you, Dr. Paramita, for your
for my
constant dedication and
Steadfast dedication.
yeah.
He's the real source of inspiration.
Rajiv, Ashim, I don't know, majority of the area. My wife is a
Here,
gynecologist.
see this.
Now the $1 million question, Satish, is in such a case of potential tuberculosis, would you slit the sheath?
Not
Or would
really.
you not?
Not really. I should not.
Please clarify. A lot of people recommend slitting the sheath.
See,
I personally am against slitting the sheath in such a case.
yes, because of the ongoing inflammation, infection.
Yes.
Exactly.
So the other side of the coin, because the pathology, it has already eroded the sheath, and that's why facial nerve palsy
Cotton
has
ball.
come.
no.
How are you
Not
going
necessarily.
to?
Not necessarily.
There are many mechanisms for the facial palsy. It's not always erosion.
Yes.
It is often microemboli.
Yeah.
Microemboli,
It's
okay.
overall it's not the pressure, it is the inflammation in the nerve overall.
Yes.
Drill. Now I'll come to the vertical segment. Cutting.
Satish boss,
Yes, boss.
once you expose the facial now,
Yeah.
do you use steroid soaked cotton over the facial now or adrenaline soaked?
Steroid soaked for this area now.
Hello.
I don't.
We are using the same cotton balls.
No, the cotton balls are soaked in saline or adrenaline or a steroid.
Saline.
Saline,
Not a
saline.
steroid. Not a steroid.
Okay.
See now, I'm going to trace the entire course, middle year, and then we'll graft it. See.
Suppose you find the whole nerve, I mean horizontal and vertical is intact, it's only the edema. What is your plan of action?
If it turns out to be the edema, I'll go beyond proximally and distally
1 centimeter.
to reach to the normal now.
Few millimeter. 1 centimeter or few millimeter.
Few millimeters.
I mean, if the nerve is intact, sheath, and it's only edema, do you need reconstruction or facial nerve grafting?
Yeah, facial nerve grafting is required when I find a nerve like a fibrous band or, of no use. The connection of no use. Then only we'll do a grafting.
Picture is not like that.
Yeah. In this situation, it is the inflammation of the nerve probably.
Yes.
Is the main reason, not the compression.
Yes.
And tuberculosis drug, anti-tubercular drugs will take.
Yeah.
Yes.
I mean, I don't know, Ashim, you should tell. I think this case maybe practically doesn't need the facial nerve grafting.
No. This one, it looks just a huge edema.
Yes.
And adequate decompression should do the trick along with the AKT.
And even post-operative 1 week steroids maybe also be
Absolutely.
helpful.
Absolutely.
Yeah, absolutely.
I was suspecting this to be tubercular. I mentioned in the beginning.
Yes, your diagnosis is correct. Any role of streptomycin, though it is autotoxic as an anti-tuberculous?
See, Madhu, for a couple of years, we are not treating any tuberculosis. The moment tuberculosis is diagnosed, we have a physician friend dedicated in our hospital only. They take care of IUC and all. So we have left everything upon them about the drugs and all, because you cannot follow them for their side effects and so many issues.
No, you are luxurious enough to have, but centers like us, anti-tuberculosis treatment we initially start and we monitor their hepatic and renal parameters and we continue.
No, but sometime MDR is also there and they are better able to.
You will come to know if it is an MDR.
You always do a gene expert and then you decide.
Yeah.
So now what
not possible in our centers to have gene expert, but we have a pre-operative, physician consultation. But for starting anti-tuberculosis therapy, we don't hand over the case to the physician.
Then it's better you start with a standard 4-drug regimen.
Yes, standard 4-drug regimen.
For me, streptomycin is a reserve drug.
Yes.
Yeah, streptomycin is a second
Can
line.
we some
Second line.
I am telling in my experience, within 2 weeks, if the tuberculosis is very much easily accessible, we will have a wonderful response. If it is an MDR, within 2 weeks you will know it is not healing and the patient will not respond. If it is a tuberculosis and responding with your 4-drug regimen, within 2 weeks you will see a good healing process taking over.
Absolutely. You see even large perforations healing by themselves.
Yes.
So pain, perforation, just the handle of the malleus that you are seeing, and miraculously these things will regenerate completely.
I go so generously, I send for biopsy and I start therapeutic trial of anti-tuberculosis because I take 5 days for the biopsy to come back. So there is nothing wrong. If it comes as non-tuberculosis, you can stop after 5 days and your routine antibiotic will continue.
In our hospital, it's necessary to notify the authorities about every case.
Yeah, there are so many issues.
Everywhere, throughout India, you have to notify. Not only in your area, in our area also, even OPD.
It's mandatory.
It's mandatory. Aadhaar number, telephone number, address, everything is mandatory.
Right.
So this part of the bone, the posterior buttress that you are...
I am just... See my ridge.
Yes.
See my ridge. And see this exposing.
Yes.
This is something your flap. You can leave it. Open kar de, isko hata de. We'll use it as a free.
Yeah.
Now this part of the facial now. See this.
completely full of granulations.
Granulations here.
Yes, sir.
You can't, differentiate. Let me further down this.
Sir, when there is lot of exuberant granulations, we keep dexamethasone for few minutes.
Yeah, even in the tuberculosis, the steroid as an initial course.
Yes, it
It
has
works.
a role.
It works. It works to reduce the inflammation.
Like, tubercular meningitis, when they use quite often steroids.
Ashim,
yes.
What is your experience or of incidence of cholesteatoma coming down with your father's time and now?
Honestly, the incidence of childhood cholesteatoma has not come down.
Yes.
Secondary acquired cholesteatomas has definitely come down.
Definitely come down. Yes.
Definitely come down.
Yes.
But childhood cholesteatoma, the congenital cholesteatomas, there's no change whatsoever.
Yeah. I still remember the words of KKR saying there are not tens and hundreds, there are millions of cholesteatomas.
So will you now use a diamond ball?
Yeah. I use cutting wire maximum. Give me the cotton ball. See everywhere the granulation tissue. See the facial canal underneath.
Yes.
What's it there? See my facial canal underneath.
Yeah. Second genu is almost exposed and we are able to see
See
there.
this. It's all granulations, Diamond. Diamond now. This is my by and large course of the facial now.
Yes,
We saw on the CT scan the scores beyond the second genu is okay.
Was normal. Magic of diamond work.
See, I am on the canal.
It said that when you are near to the canal, the bleeding is there always.
Expected. And see the fallopian canal down the vertical segment. That looks good.
Yes, sir. That was also looking good on CT also.
Yes.
Rubbing with a
The
ball
bipolar,
point in such bleeding points.
See this facial vessel. Can you see?
Yes.
Yes.
बिल्कुल कम करना.
That's what, sir. Because you are dare enough to use cautery there. But
Yes.
myself, I feel
very gently. Yeah. See this.
I use a ball point and just rub over that surface.
No. This is on the outer sheath with the minimal.
The cautery is at 15 to 20 in between.
Yeah, minimal.
Sometimes
I could see under high magnification that small vessel.
Yes.
What are minimal use?
sometimes in that area even a stapedius muscle also passes, which looks similar to facial nerve.
Find out. Now here you can't see the stapedius and all. I don't think
there is.
Yeah, there's no ossicle.
Anything left except
sometimes, yeah, it can be.
malleus head. Which
we have a much better picture of the facial nerve now.
Yes. We can discern it better, but it is swollen, edematous.
Yes.
I think each seal is filled with granulations tissue, hypotemperum cells. Also.
Give me.
For me, the perineurium looks intact. It's absolutely an edematous swollen sheath, and bony decompression of the canal much down will recover.
The patla dena section. Now see, I have a very good picture of the
facial
proximal and distal segment of the facial now. I will show both normal.
Yes.
And then come to the area of interest.
Yes, sir.
See this facial nerve segment?
Yes, sir.
Yeah, he's at the first gen, processes cochlear reform.
Can you see?
Yes.
This looks good.
Good. The C.
That is the part. See this. Iris, iris. That was the process of cochlear formation.
Yes.
Iris there, you need. See, this is the facial now.
Yes, yes.
And so
Yeah.
beneath we can see the stapes also, I think.
Stapes?
Foot plate is
No, I think.
I don't.
They are in
Stapes?
quite superior area.
that's not the foot plate there.
No.
No. Yeah, it looks much healthy.
Yeah.
Yes, that's where the most anterior projection looks bit healthy also. Now coming
area will
second genu and coming more down.
Yeah, see this, all osteomyelitis. See this? I can see the
region of,
So that is the foot plate region that can be seen.
and now it's the foot plate. This one, where the suctions are successful.
Sickle. See the facial now much better?
Yeah, very well seen. Entire course is seen. This
What
one
is Satish? What is your stake of hearing restoration in such cases?
Yeah, it's already mucosa.
Okay.
See, for osteoplasty to work good, it is the aeration which matters, the
Yes.
condition of mucosa,
Yes.
all these things. It's not about putting a strut connecting to the TM is going to work.
Yes.
Ashim, boss?
Yes, boss.
Would you do any osteoplasty here?
No, boss. What I would ensure is that there's a large piece of cartilage that will, you see, there's a lot of raw area on the promontory.
To keep the
to prevent
medial
keep a
surface
medial
away.
space.
Retract.
No, to get an air containing middle ear quite
Exactly,
sufficient
to
space,
keep a
what wrong
medial
you
space.
keep a columnar strut on the foot plate?
Yeah.
No. That
Not for hearing.
No, but
But
that
it
will not help, Madhu.
Why?
Because the raw area will be around the columnar strut. It is
Okay.
only wishful thinking for you to keep a tent kind of pole like that.
Yes.
Then you
Ashoka
have a
pillar.
large arch going from the
Oh.
inferior hypotympanum right up to the top. A large flat piece of cartilage arching
Like a
over.
boomerang.
Boomerang.
Something like that.
Right. Okay.
That will allow for a larger surface area. Because you
Okay.
see what happens is the fibrin of the raw areas.
I will put, across the middle ear a triangular cartilage somewhere.
Yeah.
Just to maintain the middle ear space.
Middle ear
To
space.
prevent these raw areas coming in contact laterally.
Yes.
Simple for that region.
So what about silastic
Assess the
sheet?
bone conduction.
What about silastic sheet?
Rejection rate of silastic sheet
Aropita,
is
in
very
this
high.
kind of an inflammation, silastic will
Yeah,
reject
it
almost
will
guaranteed.
extrude.
100%.
Okay.
It will extrude.
Yeah, you will see a small.
You are inviting more problem by putting silastic here.
Yes.
Okay.
Sir, my
Silastic
question
is
is
ideal
that
in cases like tympanosclerosis where it's indolent and not
cotton ball.
active.
put the graph directly on this kind of facial nerve.
I would not. I would keep a tent of cartilage over it.
Yes.
Cartilage on the facial nerve?
No, over it, going up to the lateral canal, large piece.
Yeah, but
So that what happens is your graft does not stick to the
Does
facial.
not stick to the facial nerve. That's
Even
what-
if it is thick, how does it going to make a difference? Because
Not really. I'm just looking at it at the second stage point of view.
in this
Satish,
patient,
the
boss,
registration tube
in
is
this
open.
patient, boss,
Yes.
the hearing reconstruction is no option. There's already
No, there's no option at 80 dB hearing loss. Where's the option?
Just
The
in case
whole
I would not
patient.
like my graph.
see my facial nerve here.
Yeah.
See this?
Yeah. See the when you are lifting up,
See this?
there is not much edema in the medial surface.
Yes. See the facial nerve looks good.
Yes.
Better than what it was before.
Yeah.
Yes, sir. Yes.
Decompress to the distance.
Yes.
I think he will
So
start
will you-
regaining within 1 week.
These, I would still take away a couple of millimeters of bone on both.
Anteriorly, yes, sir.
Yeah. I will.
Actually, anteriorly, sir. Posteriorly looks to be
See,
good.
the problem is anteriorly, that is the genu area.
Exactly.
Now what? See now here
Right
the
up to
facial
the
nerve is
reticulum.
going deeper.
back.
Even if with this even if I go Further, it's not going to help much. See this?
I think that's enough.
There is enough space. And it is turning here. Here is the labyrinthine segment starting.
Yes.
Yes, yes.
Satish,
See the facial now looking. I have removed all this granulation tissue from the nerve. Maximum possible.
Yes.
See the middle ear also I have removed the granulation tissue. The nerve looks मेरे को देना side circular. Let me show you the distal portion of as well. Cotton ball डालना है.
Satish, when you will start seeing the regeneration process and clinically
see, it all depends upon the response of ATDs now.
Yes.
This surgery is not going to improve unless the ATD responds. But I am going to start ATDs from tomorrow, whatsoever the report is.
That's what I am telling. Whatever may be the biopsy.
Tomorrow morning he will take the dose of ATD.
I think these people will start very fast recovery if it is an ATT and with steroids right from 1 or 2 weeks.
See, the picture is much better now.
Yeah.
Excellent.
Excellent.
Asim boss.
Yes, boss.
You told you would like to put a cartilage, piece of cartilage extending up to the little canal.
To maintain the space.
Yeah, but does this cartilage cause irritation of the facial nerve and hamper the healing in the post-operative phase?
No, in fact, we believe the fibrosis and so on and so forth, cartilage is not really pressing on the nerve.
Sir, usually the cartilage will not that. Yeah, there's not really much problem.
Now the nerve is
So
seen like
facial nerve is not need to be disturbed for anything, this kind of nerve. After this much of decompression,
बहुत हो गया
ना?
Yeah. Beautiful.
See all these. Now what I am ensuring again, all exenteration of air cells which I have seen.
Single supralabyrinthine area. Yes, sir.
Yeah, I will do that. I will cover in the, graft.
I think there are excellent cases today.
Yes, sir.
As always.
Exactly.
What are the chances of recovery in this case? How much do you expect to recover after giving ATT?
Facial nerve, good chances. Good chances.
He will get a grade 2.
Yeah.
99% he will get a grade 2.
I am quite optimistic for grade 2.
As per history, it is only 7 days old. So that also important that we might.
He may go between grade 1 and grade 2 also.
Not 7 days. It is for 1 month. He has come to us for 7 days before.
So do you also
But still, see, literature has seen even if it is done later, it recovers. Though the chances are less. But still, I believe grade 2 is likely.
And what about physiotherapy, sir? What about physiotherapy? You'll advise physiotherapy also.
The one and only thing on which the result depends is the ATD.
Physiotherapy is a myth or
whatever you do or don't do doesn't make any difference. ATD.
And most of these physiotherapists, they put some probe behind the mastoid and they say get the feeling of some current passing and they feel that it is a physiotherapy.
That's called billing, not physiotherapy. It's billing the patient.
Yes, that's what I would like to say.
Professor Fish,
your physiotherapist survive.
As you know, I work closely with Professor Fish and he used to laugh at the electrical stimulation.
Yeah.
And he's done more work on facial. He's forgotten more about the facial nerve than I have ever learned.
Yes.
So, if at all mechanical stimulation, you do it. You do your massages.
Muscle
you
exercise.
You selectively contract the muscle. That's the best thing you can do for it.
It keeps the patient busy.
Yeah, absolutely.
And these people will get wonderful socially acceptable recovery.
Absolutely.
Not be yes.
Absolutely. Yeah.
No doubt.
Yes.
Yeah, this should recover. Good.
The
ATD should work.
Can you see the patency of eustachian tube by a ball probe or something like that?
It looks good. I didn't want to traumatize. Okay. Give me.
Okay.
Yes, it is good. Good mucosal surface,
Yes.
See that?
Yes, we can appreciate.
The interior part is the part of annulus.
Yeah, this is annulus. I have some part of the flap free which I will place on the graft.
Right.
When the term graft has come, usually in a planned MRM cases, you always take the graft at the last, or you earlier harvest?
Fresh.
He always takes fresh.
Always fresh.
Now, what I am going to show is what Ashim was saying. What Ashim was saying to keep a triangular cartilage, that will maintain the middle ear space to prevent adherence from the medial wall and to keep the facial away as well.
And that will have some aeration also for the middle ear to heal.
Yeah. Paramita, to answer your question, rather than Celastic, you can use gel film.
Yes, gel film. Yes.
Very well.
Cost $100. It's more expensive even now.
Cost क्या बोलेगा अभी?
मैं तो आपसे लेता हूँ, आपसे लेने वाला हूँ.
आपको चाहिए क्या बॉक्स भेज देता हूँ.
Cartilage is better.
It's not available in India.
Yeah. Cartilage is better.
पतला देना वो.
But one sheet comes for many cases, gel film, na? It's
about 3 cases you can use. What you do is under sterile precautions, you cut it into 3 and store it properly.
Yeah, store it.
But it will work for 3 cases. So $35 each.
And usually the absorption time 6 weeks.
I am going to use this triangular cartilage
100%
on the tegment to the inferior annulus.
Exactly.
Yes, sir.
कॉटन बुटे दिल पतली होल बनाने वाली.
You will make an
Where will you rest?
Yeah, so that is important,
You make a groove.
Now, actually, everybody.
See, you can use from anywhere to anywhere. See, what I intend to show is to have a good middle ear space,
Yes.
Yes, everybody is waiting for this romantic scene. How you reconstruct.
Yeah, like those old Rajesh Khanna movies, a guy comes close to the girl and then suddenly 2 gulabs are touching each other.
Or
the side circular. See, this part of the nerve is so side circular. The distal part is so good.
Excellent.
This part.
Yeah.
Side circular.
Yes. That will decompress in the end.
See, this is not swollen up.
Yes,
and the thin bone I have kept. See, when I was using the diamond, keeping the thin bone there.
Reconstruction for cartilage, I mean holding the cartilage is, I think, taught in only Gujarat and Maharashtra.
See this?
We learned this from
this part of the nerve is absolutely normal.
Yes, sir.
We use this technique, but what Satish is doing is much anterior. We come a bit posterior.
See this?
Maybe at 12, he's at 11 o'clock.
So now what I have to acquire is some cartilage, some fascia.
Yes.
Okay, now I already have a flap there, and for all these, the depressions and all this, I will use some soft tissue, some cartilage or some bone dust, whatever.
Yes.
So actually, it should be like smooth cavity.
Yes. And no area of the cavity will be exposed to exterior. The bone should not be exposed.
Bone should not be exposed.
Those should not be exposed.
The bone is
bone has to be covered.
It will start otherwise.
And since you have removed the tip, this posterior area will be covered by your flap.
Tip is not removed yet. I think he has to remove it.
Actually, you can lengthen the inferiorly pedicle flap to a large extent to cover almost 80%. Because after all, when the graft, although it goes from bed to bed, it's avascular. So for more rapid epithelialization, we like to leave the muscle bare, actually. So the bleeding edges, the skin sticks to the bleeding edges, and it works much better in our hands.
See the final cavity?
Yes, sir. Very nice.
Yes, sir. Amazing.
Super. Master.
Not super.
So, Sita, you will first put
the case was not,
and then put a small.
So we should. So we should keep
only a smaller graft.
I am harvesting the tragal cartilage.
Yes, sir.
See, keeping the lateral portion of the tragal intact, it has a cosmetic value.
Clean the lens, please. Lens.
Many ways to harvest. I could use scissors, I am using here the knife only. Whatever way you can.
So we should keep one dedicated day for otology only.
Yes, yes.
Cholesteatoma and all the cases.
Then you will be doubly charged up. Eh?
Take promise from Ashim to be here.
Boss, where you are, I am always there, boss.
Satish, why you are preferring trackers? Why can't you use a conchal cartilage which is have a bow shape and has easily have that shape?
Yes.
Yeah,
Because
this also has a
posterior conchal cartilage.
This also has an inherent shape.
Acha.
It is strong enough. It is very much strong enough.
This is more sturdy, I think, than the conchal.
You can use conchal also.
Somehow I have found more stuff with conchal than with this, than with tragal cartilage. I don't know
the pericardium on both sides.
Very, very important.
Pericardium on both sides?
At least on one side you should keep. But here I am showing the pericardium on both sides.
Yes. And if it is on one side,
it's good enough.
Good enough.
Then which side you will be keeping the pericardium, on the bone side or on the superior surface?
On the side which is facing the maximum vascularity.
Right, on the bone surface.
See, this cartilage is to ensure that your medullary space remains, your facial remains protected, you know.
Absolutely.
Who is Nikata?
See, these are all steps for abundant precaution. It's not that if you don't do them, it won't work. It will certainly work, but this is abundant precaution.
Yes, sir. Why take chances?
Never take chances.
Ultimately, a good air-containing middle ear space is our goal of all this cartilage or technique. Otherwise, the whole graft or whatever just goes and adheres to the promontory.
Absolutely.
Though we are not going to give him hearing by any way.
Yes.
Yeah, डालना पानी. Hearing is difficult in the patient. There is nothing left. And these patients, you know, the sensory neural system is already involved.
Yes.
Yes. Sometime by direct extension, sometime by, you know, toxins and all that. See, simply I am going to take this cartilage from here to here.
Wow.
Absolutely perfect.
Super, 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 super.
Perfect.
So my graft is going to come above this. See this? My nerve is protected.
Fantastic.
Now it's protected. Everything is protected.
Fantastic, boss.
Yes, sir.
Now I think you will agree why I have used the term how everybody is waiting for this romantic scene.
So I will use it after the grafting.
And can you show the inferior based flap just how much it can without tip removal covers the cavity?
Yeah, this will cover. This will come right in the cavity like this.
Yeah, right.
And I will cover with the graft. I will release this flap a little bit more.
Yes, yes. Because you were telling that you were telling that the mastoid tip to be removed totally.
Yeah, yeah. I almost removed.
Almost removed 90% of the tip anyways.
Yes, yes. I will
the supralabyrinthine area should be covered a bit with the soft tissue.
Let me remove the rest of the tip. Give me
upper flap you can take.
No, monopolar. Let me remove the rest of this tip. Bone nibbler.
See, you can open the temporalis, the superficial and the deep fascia. You can find the plane between them and turn it on like an open book.
Yes, from above also.
Yeah.
Right.
What, Ashim? I didn't follow. You mean open?
That's what as the vascularized graft.
Okay.
You know, there is an investing layer of the temporalis.
Yes.
At that level, from high up, you take a cut and then turn the whole flap downwards.
Right.
I think Satish will need to do that in this case, so you can see it here.
Sir has shown us in very, I think.
You know, Hey, drill. Cutting that. A little bit of the portion of the tip I am removing. Little bit.
Yes, sir.
Finally, and then
Amit.
I will
Yes,
harvest
sir.
the graft. I will harvest some.
Amit Kesri, you had Asim boss.
Yes, boss.
A small tribute to sir.
Thank you, sir.
Everybody has learned from him only.
Everybody.
Yes.
Thank you. Very kind of you.
First time I saw ABR Desai in Visakhapatnam, I was.
Oh, 97.
Long
Long
back.
back.
At that time, I was everybody.
At
was
Surya Prakash
thinking,
Rao's course.
Yeah, to get an appointment. I was thinking really.
Sir used to come Ahmedabad, I guess, when we were doing residency or in
25 years back. That tells the volumes of his credentials. Really.
No, Amit, our clinic is still on in Ahmedabad.
Okay, right.
We come every month. Well, not in COVID time, but
Yes.
till March.
Right. We would do some
Interior.
interior.
Give it some good length, you know. पकड़ना, पकड़.
I think you have to take some temporalis muscle also.
I think for this kind of cavity, the one slab would be enough.
Yeah, I don't want to,
Yes.
close the cavity completely. But this will certainly help in reducing the size of the cavity. See this?
Yeah.
Perfect.
Yes, certainly.
Super, boss.
Very nice.
We'll suture it here to the upper layer so that it remains. See this? This will significantly reduce the size of the cavity.
Enough, sir.
And this much amount of wide is also necessary, and it's nice if you just suture. No more additional flaps are
See this
necessary.
here. We'll suture it to here.
Yes.
To keep it in place,
Yes.
And finally, we'll be needing some cartilage tissue or something to camouflage these areas. Always better.
Graft, neotoplasty.
And this, the graft, as usual, I'll take a little bigger one.
Yes.
So that no area of the bone remain exposed,
Yeah, the superior coverage will be good with the slightly larger graft.
Yes. थोड़ा इन्सिजन बढ़ा ले यार इसका.
Does using monopolar keep some more pain in the post-operative?
Here, if you damage the muscle, then see post-operative pain is so variable.
I use rehydrated.
Yes. We also harvest
most of
and
the time. How big is it?
पतला है बहुत ज़्यादा.
I'll be back in a moment, yeah?
For sure. थोड़ा little bit of. See here, we generally don't use
cotton ball
gel foam.
This is the first time I am seeing you using gels.
I don't, because now there are no chance of. इधर लगा देना.
Why you don't use gel foam
query.
here? Eustachian area?
Lab that you have, inferiority based. Lengthwise, can we thin it and make it longer? Is it possible?
Why don't necessarily prevent ventilation? But here, see, the things are different.
There's a question from Iran. Do you put any sheath in the eustachian tube? to
Yes, in
maintain the
case, yes,
pattern?
in aeration, when you do ossicloplasty, when you do reconstruction for the hearing, always better if you have raw areas.
Okay.
Always better. And
Okay.
silastic is different. That like Ashim mentioned, gel film. Gel film is a better option now because
Your take on stitch tube dilatation, quite a
you don't have to remove it. You know,
Satish sir.
silastic is sometimes the problem with the extrusion. Yes, yes, boss.
What is your views on stitch tube dilatation? It's like
Boss, no idea. And see, in the literature, still it is not a standard of care.
yeah, but not many articles are coming up.
Yeah, yeah, articles are coming.
I don't know if it's company driven or it's
Yeah, yeah, that
I
is one
think
of
you
the
know
big.
the balloon sinoplasty, the
That
honeymoon
is
is over.
company driven is a big
Same thing.
issue.
Doesn't have much role.
So,
Did it
Dr.
stand to the test
Rajendra,
of time? Balloon sinoplasty did not stand to the test of time.
exactly.
so Dr. Rajendra Kumar Teharia is asking from Jodhpur, can
Whatever skin.
cholesteatoma and tuberculosis both simultaneously occur? Any experience to
Very,
have
very
that?
common, very common.
Just for
I've
the
seen
skin.
that. I've seen that quite
Just for
often.
the skin which we made free.
Yes.
What is the question? Cholesteatoma?
Can
And
cholesteatoma and tuberculosis both occur simultaneously?
Yes, yes.
Certainly. They're two different disease.
Different disease. There's a coincidence. I have seen.
But always cholesteatoma is earlier, tuberculosis is super added.
Okay.
That is, when are you pressing the strut?
Pardon?
The strut?
Cartilage.
Yeah, I will.
No, the idea is to first anchor the anterior part
Anterior part. Yeah.
and then lift up the whole assembly and then put the cartilage.
Yes, so it doesn't fall down.
Right.
How will you sure that all cotton balls are removed?
Yeah.
Counting.
Counting.
Yeah.
See, we'll do a little bit of the myoplasty. So my flap will come here to extend the epithelialization. Because inferiorly it is going to come. Superiorly I have placed this. And now, before going further, I will use the cartilage.
What is your opinion on using that free skin graft much lower rather than covering the tegmen area?
Yeah, because inferiorly my, the myoplasty skin is going to come.
Ah, okay, right.
Satish, would you use external silastic in the external auditory canal?
Yes, many a times over the graft.
Yeah. Better epithelialization and lesser chances of stenosis.
Yes.
So when you use it, when do you remove it?
That would be at 6 weeks actually.
6 weeks.
Let it be. You don't need to remove so early. Let it be. It's not going to give any problem. And
it's external.
No, irritation?
No. Not in the external part.
I don't have any experience about that.
It's very good to
promote epithelialization.
Okay.
That is to promote
epithelialization.
See, this is quite lateral to the facial now.
Yes.
That's it.
Absolutely no pressure on facial nerve. Nothing to worry at all.
See the huge middle ear space you got. Wonderful.
Yeah, super. And good ventilation.
Suture this. I'll take a stay suture for this, flap.
It's a very small myoplasty you will do. Just to
Yes.
no cartilage.
It is very important, boss.
Myoplasty is the important step.
Myoplasty is a big cause of problems many a times. See what Dr. Ashim was saying, to bring down this part of the superficial layer of the temporalis. Yeah.
Your assistants are also, I mean, one of the greatest people around. Your assistants.
Yeah, they are very committed, very committed. I really, I'm so fortunate. See now, this is your facial now. That is your cartilage.
Yes.
That is your muscle which is coming. And now I will deposit this. And included that area of the, boss, dekh liya soft wall.
Yes.
Yes, it's almost, I was just about to comment, like it's looking like a normal ear canal. A bit, just wide.
No, what I have done, I have taken this area of the perilabyrinthal area.
It's just aerating the perilabyrinthine cells. Brilliant.
Brilliant, sir.
You're there.
Super.
Now I'm, what I'm looking at is starting ATDs in morning. That is most important.
Yeah.
Yes.
Whatever work you have done, not done, anything, and with this much of the work done, now the ATD is the only thing required.
Yes.
And sir,
Campesine is a
See my graft. See my graft.
Because
It is-
sometimes
see this graft is important coming on the vascularized tissue.
Yes, it has to come on the vascularized tissue. Not
See,
on
this will acquire vascularity very fast.
Yes.
See this completely coming on it?
Yes.
That is most important.
Yeah,
For the
many people
stability
put
and for
graft
the
in raw bone. That should not be done.
Yeah, no raw bone. See now, there's
Yes.
nothing, no bone is exposed from canal side. If you see,
Yes.
no bone is exposed. And see, this is on the vascularized flap. See this graft?
Yes.
Absolutely.
And this will acquire the vascularity faster.
Yeah, plus the posterior canal skin is also going to lie on it.
Yeah. See this, what a flap it is. See what a flap it is.
Yeah, super.
Robust.
Very nice.
That's why I wanted to show it from beginning with raising this flap. This is very, very important. Now,
And I recommend my resident to use this all the time. If they use it, fine. If they don't use it, just stitch it.
now somebody will do this thing for me. Give me a knife. There are many techniques. Simplest way. See, always do a little larger myotoplasty,
Yes. Always. a bit
because all your
bigger.
tissue what you have put in inside are going to shrink. It is always better to do a one size bigger, in the beginning.
Yes.
Now they will suture it on either side. See this?
Yes.
And what they are going to do is they are going to cover this cartilage. They'll remove the
That's a
cartilage
very
from the head
important point.
and they are going to cover it.
Yes, that at no point should any part of the cartilage be exposed.
Be exposed. Yeah. Chances of pericarditis are
very high. That's right.
Camera line.
Especially this case of tuberculosis, unimaginable.
Disaster.
On kar. So the last part is myotoplasty. He will do for me, and
Have some dinner.
see when Ashim is there now in otology, I really love it operating.
Boss, it's a pleasure to
He is
watch you.
One is always a source of inspiration. My otology starts with them only.
Boss, you are too kind.
See, you are operating from 4 o'clock and now it's 1:46.
1:46.
1:46. And how vibrant and how energetic he is. Really great, Satish.
Hey, Madhu, you are there. It's really a pleasure being.
Ashim boss is there, not me.
Anyways, we had a great session, sir, today, and it was great having Madhu sir with us. He was so interactive throughout.
Yes, awesome, Madhu.
Madhu, believe me, you are the man of the match today.
Yes, it was a pleasure to listen to
So many interaction. Whenever, I told him when Madhu is there, is always a good interaction.
Yeah,
Excellent.
It was
Excellent. I was
amazing.
listening to you throughout, Madhu.
Yes.
Thank you, Madhu. Thank you, Gautam sir.
From bottom of my heart, I should say extend thanks for making you be part of this. Very nice.
See this young man, 64 years. Madhu.
No, 63. Please don't increase my age to 64. I am only 63.
Only
Thank you,
63.
Satish. Learned a lot. And thank you, Dr. Madhusudan. From you also, I have learned a lot. Thank you very much.
Thank you.
Thank you, and see you all on Sunday afternoon with cochlear implant.
Yes.
Yes, sir.
Okay.
Good night,
Thank you
guys.
so much,
Bye.
sir.
Good night.
Bye.
I think we should say good morning.
Good morning.
Thank you. Thank you so much.
Thank you, Ashwin,
You've done a
sir.
fantastic job as always.
Thank you, sir. Sir is there when Satish sir is operating. We all feel energetic to be with him.
Exactly.
Thank you, Paramita. Thank you so much. And big thanks to 3 cheers for Dr. Rajeev Pachauri.
Yes.
Great, Rajeev.
Yes.
Fantastic job.
And Sun Pharma.
Sun Pharma, obviously, they have been so kind.
They are in dream now, I think.
As sun dissipates the energy, Sun Pharma is also dissipating this energy of Satish Jain to everybody in this world. Thank you, Satish.
Thank you, boss. Thank you, Madhu. Thank you, everyone. Thank you.
Thank you, Dr. Devang Gupta.
See you on Sunday, Satish.
Yes, Sunday 2 p.m.